Good morning, everyone. Hi, I'm State Senator Liz Krueger, Chair of Finance, joined by, well, we don't have the Chair of Ways and Means with us for the first couple of hearings, but every day the senior assembly member for the leading committees will be representing as if they are the Chair of Ways and Means. So today is my colleague, Amy Paulin. Some of you may have already noticed there's been some improvements in this conference room, which hopefully will make everybody's life a little happier. I want to remind or just point out to all legislators the microphones are new. They should be better. But note when you push the push button to be heard as a speaker, you have to push it pretty hard, and the light goes from red to green. And so it's just reminding everyone, make sure the light is green when you're talking, and also reminding my colleagues, because we all are guilty of this sometimes, make sure it's off when you're chatting when you're not supposed to be on record, because sometimes some interesting things pop up on the recording. The upgrades include increased Wi-Fi strength, so people should actually be able to get the Wi-Fi to work in here. There's both the member Wi-Fi and the guest Wi-Fi. So we're really hoping all of this works. This is sort of our beginning test since you're the first budget hearing. You also see there are new screens, as well as for people who have hearing impairment. There is, bless you, automatic text that will continue with whoever's asking questions or responding to questions. It's a really terrific technology. I use them all the time when I do webinars for my constituents. It really helps to have the text along. So I'm excited about our first day. I'm now going to, before I make the opening statement, I'll just go over a couple of other things. So for witnesses to present their testimony, each government invitee, and we have 3 with us at the table now, each gets 10 minutes to present. The non-government invitees, when we get to their panels later, only have 3 minutes to present. The chairs of the relevant committees get 10 minutes to ask questions, and they get a second round of 3 minutes if necessary. The rankers get 5 minutes. All other members get 3 minutes, and no second round for those storylines. So now to do an official opening statement. Good morning. Again, Liz Krueger, Chair of Senate Finance Committee, the co-chair. Today's budget hearing is my colleague Amy Paulin. Today is the first of 11 hearings conducted by the Joint Fiscal Committees of the Legislature regarding the governor's proposed budget for state fiscal year 24-25. These hearings are conducted pursuant to the New York State Constitution and legislative law. Today, the Senate Finance Committee and the Assembly Ways and Committee will hear testimony concerning the governor's proposed budget for the Department of Health and the Department of Financial Services. Following each testimony, there will be time for questions from the chairs of the relevant committees. I will now introduce members of the Senate and Assembly member, it says Helene Weinstein, but it's not. Amy Paulin will introduce members of the Assembly. In addition, my colleague, the ranker on finance, Senator Tom O'Mara, will introduce members from his conference. So just to note, for people who might still be confused if they're in the right room, today we have representing the agencies. I'm welcoming Dr. James McDonald, Commissioner of the New York State Department of Health, Amir Basari, Medicaid Director for the New York State Department of Health, and Adrian Harris, the Superintendent of the New York State Department of Financial Services. And just reading off the members from the Senate so far. Some people come, they go. There are committee meetings. Thank you. Great. We have Senators Rachel May, Senator Neil Breslin, who is the chair of Insurance, Senator Gustavo Rivera, chair of Health, Senator Zellner Myrie, Senator John Liu, Senator Brad Hoylman Siegel, Senator Webb. I think that's so far the Democratic senators. And I'm going to turn it over to Tom O'Mara to introduce the Republican members.
Thank you, Senator Krueger. Good morning, all. On our side here, we have down in front Senator Jake Ashby, Senator Dan Steck, and up here to my right is Senator Pam Helming, our ranking member on insurance, and Senator Patrick Gallivan, our ranking member on health. Thank you.
Thank you. Amy Paulin, who's technically the chair of health, but also leading for the assembly today. Push your button.
I did. Okay, good. Hi, I'm Amy Paulin, chair of the Assembly Health Committee. Today, in addition to my role as health chair, I'm also filling in for Assembly Member Helene Weinstein, who is the chair of Ways and Means, who originally or would ordinarily be chairing the hearing with Senator Krueger. Assemblywoman Weinstein is presently recovering from knee surgery and is expecting to be back in a few weeks. So everything's been said except the introduction of the assembly members, right? Got it. So on the assembly side, we have to my left, David Weprin, chair of insurance, assembly member Phil Steck, assembly member John McDonald. Down below, assembly member Ed Bronstein, Harry Bronson, Michaela Solange, Nader Saij, Alex Borres, Jen Lunsford, and somewhere is Khalil Anderson. I don't know where, but he is here. Got it. And then I'm going to turn this over to my colleague Ed Ra, who will introduce the Republican members of the Assembly.
Thank you. Good morning. On the Republican side, we have Assemblymember Josh Jensen, who is our ranker on health, Assemblymember Ken Blankenbush, our insurance ranker, and we also have members Gandolfo, Bendet, and Gray.
Anybody who wants to ask a question, so raise your hands. Okay. Thank you.
And just a little more housekeeping, because this topic comes up every year, and this is really for my legislative colleagues. If you have 10 minutes, 5 minutes, or 3 minutes, that is for both asking the question and getting the answer. Some people like to use all of their minutes asking a question, or perhaps sometimes it's not a question. So the deal is you still only get that much time. So if you use it all up on your side, there's not going to be time for anyone to answer. When that happens, and trust me, it will, I've been doing this many years, we will ask the testifiers if they can please respond in writing to myself and Ways and Means, and we will make sure all members get the written responses. And sometimes testifiers sincerely don't actually know the answer, which I think is fine. Then say, I don't know that answer. I will find out for you and get back to you. And that's a perfectly appropriate response. So, everyone who's testifying today, don't make it up. If you don't know, then just say, we'll have to get back to you. You stumped me. Everybody gets stumped sometimes. So I just wanted to make sure that I raised that storyline, because trust me, it will happen. And as Amy just said, for members of the Senate or the Assembly, if you want to ask questions, then if you're a Republican, let Tom O'Mara or Assemblymember Ra know, because they'll keep a list. And then if you're a Democrat, let me know or let Amy know, because we'll be alternating and taking turns asking the questions. And you can signal a staff person there. You can wave to me, try to get my attention. We all figure it out, but just because we do have some members who maybe haven't gone through as many budget hearings as some of us have, you just need to make sure you let us know. We will always ask the chairs and the rankers to go before we ask other people to go. Not that you have to have questions, but usually you do. So with that, I would like to turn it over to Dr. James McDonald. He has many letters after his name, but he's our Commissioner of Health, to testify for 10 minutes. Oh, I'm sorry, one more thing. If you are a legislator here, we have printout copies of the government representative's testimony. Everyone else's testimony is up online on the Senate, Finance, and or the Assembly Ways and Means sites. So we've decided a couple of years ago to stop killing so many trees and just make the testimony available online. So with that, thank you, Commissioner.
Yeah, thank you. Thank you. Wow, that's loud. All right. Well, hot mic. Got it. Yeah. Well, let me start with wishing a speedy recovery to Chairperson Weinstein. I'm sorry she can't be here, but I do want to say good morning to Chairperson Kruger, Rivera, and Paulin, and all the members of the Senate and Finance and the Assembly Finance Committee. It's great to be back. It's great to be with you today. And I'm really good to be the first person to talk about Governor Hochul's fiscal year 25 budget as it relates to health and well-being of all New Yorkers. You know, it occurred to me that when you look at the entire budget, the whole budget is about protecting the health and safety of all New Yorkers. I'm going to limit my comments and really focus on the Department of Health budget today. I do want to just acknowledge my colleague and friend Amir Basiri here from Medicaid. Great to have him, and my acting executive deputy, Commissioner Joanne Moore, who's with me today as well. Thrilled to have them. You know, if I could describe this budget in one word, it's really about stewardship. And, it's no secret this is a challenging budget year, and there's some difficult choices that are being made. But this is about stewardship for 2025 and beyond. You know, last year I traveled very widely throughout the state. I had 59 trips all in total, met hundreds of organizations and tens of thousands of people. Really traveled, from the far Rockaways to the Akwesasne. And of note, I had a chance to visit the Tuscarora Nation, the Tonawanda Seneca Nation, and the St. Regis Mohawk Nation. I was also particularly pleased to welcome the Rochester delegation to our regional office in Rochester. You know, at every meeting, I pretty much go with the same two things. I'm here to listen, and I want to hear how I can partner with folks to eliminate health disparities. I want to turn my attention now to talk a little bit about distressed hospitals. You know, the funding for distressed hospitals has tripled since fiscal year 21 and 2024. In fiscal year 25, we'll provide an additional $984 million to distressed hospitals, so just a little under $1 billion. Under the 1115 Medicaid waiver, we'll provide up to an additional $2.2 billion in multi-year funding to support our safety net hospitals, while encouraging them to transform in ways that will improve care and financial sustainability. All told, the 1115 waiver includes $7.5 billion, of which $6 billion is new federal funding to address health inequities. In my visits across the state, the issue that came up repeatedly everywhere was workforce, and we need your help to solve this problem. And I'm hoping we can work together to look at changing maybe some outdated laws that prevent healthcare professionals from working in New York. And these limitations contribute significantly to our shortage and rising costs. You know, we're one of only 11 states that hasn't joined the Physician Licensure Compact. One of only 9 states hasn't joined the Nurse Licensure Compact. You know, we're also, have to look at legislation about, can we let healthcare workers do things they're already trained to do? Like medication aids, allowing them to give basic medications in long-term care. I think we need to look at how we look at physician assistants, too. Physician assistants should be allowed to practice independently in primary care and hospitals after sufficient training. I think we need to look at medical assistants, too. We're the only state in the country that doesn't allow a medical assistant to administer a vaccine. While we're supporting healthcare workers, I want to shift our conversation a little bit to how we can make health insurance easier to obtain. Our 1332 innovation waiver, which I expect to be approved by the federal government this week, is going to raise, eligibility from 200 to 250% of the federal poverty line. So someone earning a little under $38,000 could obtain affordable coverage with no premium. It's going to help an additional 100,000 New Yorkers get affordable insurance. We're also proposing this year to allow subsidies for folks who make up to 350% of the federal poverty line for qualified health plans. And we're going to eliminate cost sharing in both the essential and qualified health plans for office visits, lab work, pharmaceutical, and other things for things like chronic conditions such as type 2 diabetes. I want to talk a little bit about maternal health. The budget also increased our commitment to maternal health in several ways. $700,000 to the Perinatal Quality Collaborative, which helps participating hospitals develop a multidisciplinary approach to eliminating racial disparities in birth outcomes. We also adding doula coverage for New Yorkers enrolled in the Essential Plan. We're also asking for allowing me, the commissioner, to write a standing order so anybody who's giving birth can access a doula. We're also going to eliminate out-of-pocket medical costs for pregnancy-related benefits via the Essential Plan and other qualified health plans, and use financial incentives to get hospitals to reduce unnecessary C-section births. Talking a little bit about children's health, I'm pleased with some of the investments we're making here. We're going to seek approval to provide continuous Medicaid coverage and children's health insurance coverage for any eligible little one up to the age of 6. This eliminates administrative burden for an estimated 650,000 kids enrolled in Medicaid and Childhood Plus. We're also making some investments in school-based health centers. And something else we're doing this year, which I'm excited about, is increasing the reimbursement rate for in-person visits for early intervention. It's a 5% increase across the board and 9% for rural areas of the state. I want to shift my conversation now to talk a little bit about emergency medical services. Now, I think most people think of this as an essential service, yet it's not considered an essential service in our state, so we'd like to mandate that. Because it's not mandated, we see a wide variety of response times, particularly in rural areas. We're hoping to change that by making this an essential service and creating 5 EMS zones intended to augment local EMS agencies where the workforce isn't quite what it could be. We're also talking about establishing a first-in-the-nation paramedic telemedicine urgent care program. This will increase access to care and hopefully reduce unnecessary emergency department visits. There was some energy here in strengthening primary care as well. In addition to the investments in the 1115 Medicaid waiver, which are substantial, we'll increase Medicaid rates per providers participating in patient-centered medical home, an additional $2 per member per month for adults and $4 per member per month for kids. I'm pleased that this budget includes some increased reimbursement rates for those providers who take care of people who are intellectually and developmentally disabled. It's 50% above the base rate. And I want to shift our conversation now, just talk a little bit about the opioid epidemic. Combating the opioid epidemic is definitely a priority of all of us in this room. In the last year, we've worked really well with the Office of Addiction Services and Supports to get out the settlement money out. The dispersed money, we're actually leading the nation in dispersing money from the settlement. We're better than any other state with this. But it's not just fentanyl that's a problem. We also have to consider the impact of xylazine. So one of the things in our proposal is to make xylazine a controlled substance, which I think makes a lot of sense. I'm going to talk really briefly about oral health. It's critical to our overall health and well-being. One of the things we have to talk about, though, is the challenge in people who are lower income accessing a dentist. Only 30% of Medicaid enrollees have seen a dentist in the last year. In addition, we're talking about adding dental services to school-based health centers, an additional $1.5 million for that. And we'll support the dentistry workforce by launching a new loan repayment program supported by the 1115 waiver, up to $100,000 for dentists who make a 4-year commitment to serve a Medicaid population in New York. There's also a proposal to increase the scope of practice of dental hygienists that will also allow collaborative practice in circumstances, which will improve access to care. It's interesting, when I visited the Tuscarora Nation, I was struck by how beautiful their new dental clinic was. It was really state-of-the-art, had all wonderful equipment there. But they didn't have a dentist, no dental staff at all. So their folks had to travel an hour and a half to Rochester to get dental care. It's been very wonderful to work with Deputy Secretary Rule, to find additional $4.5 million to address the critical oral health needs and disparities experienced by tribal nations. And the last topic I'm going to address is veterans. I'm very thankful for our veterans, and I'm very grateful that our budget includes an additional $22.5 million to ensure that our veterans receive the best possible care. We have 4 veterans homes. I had a chance to visit the folks at St. Albans and at Batavia this year. I look forward to meeting the folks at Oxford and Montrose next year. But it's nice to see that investment continues. In closing, I do want to thank Governor Hochul for her commitment to supporting healthcare and public health. And get back to the one word in our budget, it really is about stewardship, and this budget reflects some difficult choices. I know finding $200 million in savings in long-term care and Medicaid is going to be hard. I look forward to working collaboratively with you and your team to identify the best way to achieve these savings. Thank you.
Oh, sorry. Yes, it's on. Someone turned it on for me. Thank you up there. So we're going to not have, my understanding is the Medicaid director testify separately, but we will be asking questions that are specific to Medicaid, and that will be directed to her. To him, excuse me, I'm so sorry. And now I'm going to turn it over to Adrienne Harris, who's the superintendent. Always concerned because she's not a commissioner like everyone, and I get lost. So on insurance issues, Adrienne.
Wonderful. Good morning, Chairs Kruger, Breslin, Weprin, Rivera, and Pollen, ranking members O'Mara, Ra, Helming, Gallivan, and Jensen, and all distinguished members of the New York State Senate and Assembly. And I also wish a speedy recovery to Chair Weinstein. My name is Adrienne Harris, and I'm the Superintendent of the Department of Financial Services. Thank you for inviting me to discuss the executive budget and all the DFS has accomplished in the past year, thanks to the support of the governor and legislature. Created in the wake of the 2008 banking crisis, DFS regulates the activities of over 3,000 financial institutions, including globally systemic institutions, with nearly $10 trillion in assets. When I arrived at DFS just over 2 years ago, the department was known as a lone wolf prosecutor, famous for little process, transparency, or stakeholder engagement, including with our partners in government. The department was underfunded and without adequate investment in human capital, technology, or process management. This left DFS incapable of meeting the standards New Yorkers have a right to expect from their government. So I got to work on transforming the department. I spent the first several months identifying issues and risks and created a strategic plan mapped to those findings. In its simplest form, it's what I call the 3 Ps: policy, process, and people. On policy, I instituted a rule that going forward, all policy would be data-driven rather than based on ideology. The policymaking process would include robust collaboration and engagement with stakeholders to achieve our mission of building an equitable, transparent, and resilient financial system. I deepened the department's focus on kitchen table issues, things that are meaningful to the everyday New Yorker and that would help them trust that their government is working for them. For process, I committed to DFS becoming a transparent, process-driven organization. We began to set KPIs, measure progress, and build knowledge management. And then I emphasized that neither our policy nor our process goals could be achieved without the 3rd P, people. We had to attract and retain expert talent, fostering a culture of inclusion and performance. To unify employees across divisions, we rewrote our mission statement and established 4 core values: equitable, innovative, transparent, and collaborative. I'm immensely proud of the progress we have made in my time since joining the department. From a policy perspective, we have implemented 100 amendments to the insurance, banking, and financial services laws, issued more than 60 pieces of regulatory guidance, promulgated 31 data-driven regulations, and secured more than $344.4 million in restitution. In the past year, we amended our nation-leading cybersecurity regulation, modernized the fee structure for check cashing, and adopted guidance to protect banking institutions from climate risk. On process, we are clearing significant backlogs and are engaged in a department-wide technology transformation, rolling out a new CRM platform, data warehouse, and productivity tools. These upgrades give DFS the modern resources to identify and respond to risks and better protect financial markets and consumers. But to do all this, the department relies on the third P, people. I spent much of my first months engaged in a risk-based analysis of our human capital needs and created a 5-year strategic plan. We have been able to get the agency fully funded for the first time in its history, thanks to the support from the legislature and the governor. As a result of that backing, we have hired 336 new team members and promoted 309 existing team members since January 2022. Beyond the people within the department, we have expanded our network to collaborate with partners at the state, federal, and international levels. For example, for the first time, New York is represented on the U.S. Department of Treasury's Financial Stability Oversight Council, a role in which I am honored to serve. All the actions we have taken have been with one core objective in mind: to transform DFS into a preeminent regulator fitting of the financial capital of the world. As we move forward, we will focus on 3 key areas: equity, innovation, and consumer protection. We consider policy decisions through the lens of building a more equitable financial system that protects and empowers all New Yorkers, including those in historically underserved and marginalized communities. In the past year, the department has taken definitive action to help New York's financial and healthcare systems become more accessible and equitable. We enacted policies to cut check cashing fees, implemented expanded abortion protections to reduce reproductive health inequities, and have prioritized increasing access to affordable banking services to underserved communities. DFS also remains laser-focused on innovation, a key area that shapes my vision for the department and our future. In revising the department's mission statement, it was important to me that we articulated DFS's commitment to driving economic growth through responsible innovation. One clear example is our world-leading virtual currency framework, which has served well to protect consumers, keep entities safe and sound, and hold bad actors to account. To carry out this work, I have built the largest virtual currency regulatory team in the nation, growing the unit from a handful of employees to more than 60 seasoned experts. The same principles of responsible innovation also apply to AI, where significant benefits and risks coexist. Just last week, we proposed guidance on regulating the use of AI in insurance to help mitigate harm to consumers. Finally, I want to discuss DFS's progress on consumer protection. Last year, in partnership with all of you, we created the Health Guarantee Fund, a critical safety net for New Yorkers. Now New York is no longer the only state without this essential protection for policyholders. The department has published new guidance prohibiting deceptive overdraft practices, introduced new financing disclosures for small businesses, and mitigated a national banking crisis, safeguarding the finances of consumers and businesses. One of my proudest accomplishments is our continuous work to put money back in New Yorkers' pockets. Last year, DFS returned a record $163 million to consumers and healthcare providers, bringing the total in restitution during my tenure to more than $344.4 million. Before I close, I want to take a moment to reflect on the events of the past year. In March last year, just 1 week after I testified, community and regional banks across the country suddenly began to fail. The self-liquidation of Silvergate Bank and the $42 million run on deposits at Silicon Valley Bank quickly led to 3 of the 4 largest bank failures in the history of the country, including one here in New York. The unprecedented speed of events put DFS at the center of preventing a global financial meltdown. Along with regulators in other states, in Washington, D.C., and in Europe, my team and I worked around the clock to mitigate further panic and contagion across the broader banking system and ensure that individuals and small businesses could safely access their money, all while we continued the day-to-day operations of the agency. It is a set of events that is marked in the history of this country, and as we approach the 1-year anniversary, I want to again express my deep gratitude to my team for all they did to protect New Yorkers and the global financial system. I'm also grateful for your partnership. Your support and collaboration were critical as we weathered the storm. I look forward to continuing to work together to advance an affirmative policy agenda to benefit New Yorkers. Thank you for the opportunity to address you today to discuss how the department is working to build a more equitable and innovative financial system that benefits New Yorkers, supports businesses, and drives economic growth, cementing New York's place as the financial capital of the world. I look forward to answering your questions.
Sure. Thank you. Thank you very much. Our first questions will come from Senator Neil Breslin, the Chair of Insurance. Oh, Neil, before you start, I'm so sorry. We've also been joined by Senators Brooke, Senator Hinchy, Senator Borrello, Senator Comrie, anyone else? And Senator Rhodes. Any Assembly members out?
Thank you, Madam Chairman, and I will be brief, but I think I should first talk about the appointment of the superintendent, and I've been around for many years, and I found the relationship between the department and the legislature to be at the best possible stage imaginable. There's participation, there's discussions. As in past years, it seemed as though either one side or the other were the enemy. Whether it was the agency or the legislature, there was a continuing battle. And when we both work on the same team and we're both discussing the same issues and how to confront them, it makes the job of everyone that much easier. So thank you, Superintendent. There's so many issues that confront insurance today with the economy the way it is and the expense of insurance. And so many people know if they collect all the checks that they write to various forms of insurance, it's a lot of money. And our job is to make that a little more pleasurable. The first I'd like you to talk about, there's been some discussions recently about low-income housing insurance. And obviously, if that's an impediment to housing, particularly for low-income people, it's a real problem that must be solved. But I'd appreciate your comments on
Yeah. Thank you so much, Senator Breslin. It's an incredibly important issue and one that we've been deeply engaged in. And of course, as you know, the governor has proposed prohibiting insurers from asking the question about the presence of affordable or subsidized housing units in the underwriting of those multifamily housing buildings. It's something we've been engaged on for quite some time, but also, as you alluded to, the cost of insurance across many lines is continuing to go up due to a number of factors, including inflation, supply chain issues, reinsurance, and climate change. But I think the governor's proposal is a strong one so that we can eliminate a factor that many feel is discriminatory in the underwriting of multifamily housing.
Thank you. In the in the area of PBMs, and we've had discussions for many years. We've finally taken measures to regulate a group of people that referred to as PBMs, who many of us did not know anything about until there was initial legislation and now additional legislation. I'd like you to tell us the progress on the regulation of PBMs and our ability to control them so that there's access to the marketplace by not only the three major pharmacies, but the independent pharmacies as well.
Thank you. And again, I'm so grateful to the legislature for giving the authority to regulate PBMs to DFS. They are a middleman that often seeks rents and contributes to increasing the cost of prescription drugs and therefore increases the cost of the provision of healthcare overall. So having the ability to regulate them and add transparency to the space is incredibly important. As it was a new authority, we had to build a new bureau from scratch. So we've added about 25 experts to our team to build that bureau from scratch. We've also now successfully licensed every PBM that does business in the state, as was the requirement in the statute by January 1 of this year. We're also already examining the PBM. So our examiners go in and they're currently on site with some of the largest PBMs in the country, making sure that their financials are as they should be and examining for market conduct. As you know, we also proposed some market conduct rules at the end of last year. As we were engaged in the SAPA process, there were lots of very helpful comments that came in the connection with that process. And those comments led us to take another look at the proposal that we had made. I felt, given those comments, the best course of action was to withdraw that proposal and start again, because that engagement with stakeholders is so important, and we need to be taking that into account. So we've been working diligently so that we don't lose too much time, but to meet with those stakeholders, engage with those stakeholders, and we've been doing that since last year, and we are weeks away from reproposing some very strong market conduct and consumer protection rules.
Thank you. Another area that's of great concern to most consumers is long-term care. The problems predate your coming to the department, but it doesn't mean the problems have been solved. Could you discuss with us some of the steps that we've taken to make it a better market and a more inexpensive market and a long-term providing care market?
Yeah, thank you, Senator. As you noted, this is really a long-standing and nationwide problem. As you know, I write a report to the legislature every 2 years, as I'm required to do under statute. But last year, the department took the extra step of writing an additional report that laid out the history of long-term care nationwide and how we landed in the crisis that we have today. So it really goes back to when the product was invented, there was not a history of claims to inform the underwriting experience. And those products, when they came online 30, 40 years ago, were mispriced, essentially. And then rates were kept artificially low for ideological and political reasons, again, around the country for decades. Now those chickens are coming home to roost, and we see large rate increases that we're forced to sometimes grant so that we can make sure the insurers don't go under and that seniors don't lose decades of investment. We are trying to think very creatively at the department. One of the things we do is we work with those long-term care insurers to phase in rate increases over time. We also allow for consumers to choose whether they'd like a rate increase or a reduction in benefits, which is not a pleasant choice, but at least it gives consumers some optionality. And then in rare instances where we're able to do so, we require capital infusions from other parts of the corporate family, although that is not something we're able to do often. But we continue to work very hard to mitigate this nationwide issue. We're implementing Senator Mayer's transparency laws now, and we look forward to continue to collaborate with you and your colleagues and other stakeholders on this issue.
And one last question. It's really dealing with the mandates that face the legislature each and every year. All legislators have, or not all, but most, have ideas of who should be covered as a mandate on their health insurance. And many of us, including the chairman of the Insurance Committee many years ago, did not think about the consequences of mandates and the expense to the ultimate health insured person. Can you give us an idea of how that discussion takes place in making recommendations to us when we put in proposed legislation mandates?
Thank you, Senator. As you allude to, there's no such thing as a free lunch, so to speak. So every time we seek to add a coverage or cover a new population, there is some cost to that. At the department, we do our best to provide technical assistance to help policymakers understand what the potential costs of additional mandates might be, but of course helping to weigh the policy decisions of providing these important protections to consumers. And then as we are reviewing rates, we are tasked with balancing increased costs to consumers with the safety and soundness of the health insurer, because really the best protection that we can provide to insurers is to make sure that there's a solvent insurance company at the end of the line that is there to pay claims when they come due. But it is always a balancing act.
Thank you very much, Superintendent. I would be remiss, too, if I didn't mention that we're joined by Senator Helming, the ranker on the committee, Senator O'Meara, who's down there and is always here, and our newest member, Senator Jake Ashby. Thank you very much.
Thank you, Senator.
Thank you, Assembly.
I never noticed that. There we go. Thank you. First, before I call on our first person to question, We've been joined by Assembly members Latrice Walker, Rebecca Seawright, Anna Kellis, and Jessica Gonzalez Rojas. So the first person for the Assembly will be the chair of our Insurance Committee, David Weprin, who will get 10 minutes.
Thank you, Chair Paulin. Thank you, Superintendent Harris. I must say at the outset, it's been a pleasure working with you in your office and your team this past year. It has been a very productive year, including, as you mentioned, the first healthcare guarantee fund joining 49 other states and doing that. And I know that was a priority of both of us during the session, and that, in my opinion, was a major accomplishment. And I hope the results are good, and I'd like to hear about any particular companies that may take advantage of it, but I'll get into that in a little while. First, I'd like to talk about the Physician Excess Medical Malpractice Program. How would the proposed changes to the Physician's Excess Medical Malpractice Program under HMH Part K impact the medical malpractice insurance market in general?
Thank you so much, Chair Weprin, and it's been a pleasure to work with you over this last year as well. We also saw that proposal in the budget. My understanding is it is, although it's MedMal, it is a DOH proposal. So I may defer to my colleagues from DOH on discussing that proposal further.
Okay, Commissioner McDonald, would you like to address that, or someone on your team?
Yeah, no, I'll address that. It's really moving from 2-year budgeting to 1-year budgeting, is my understanding, and just decreasing eventually over time the reimbursement on that. It's one of those things where it's about trying to find savings in a challenging budget year.
And you think there will be significant savings?
Over time, it will be over time.
Okay. Superintendent Harris, in the affordable housing discrimination area, as you may know, I carry a bill along with Senator Kavanaugh in the Senate, which would prohibit discrimination against affordable, subsidized, or Section 8 housing in any underwriting or insurance policy decisions. How would the proposed changes under TED Part FF affect the premium rates of affordable housing developments?
Thank you, Mr. Assemblymember. This proposal is really about what we were hearing from affordable housing owners and the discrimination that they felt they were encountering in the underwriting of insurance. And so the governor has taken the step of following your lead in proposing that we prohibit insurers from asking about the existence of affordable or subsidized housing in the underwriting or renewal of these insurance policies. So I think it's an important policy decision to make sure we're rooting out any unfair discrimination. We know that some insurers were asking this question in their underwriting, and many were not. So we will have to see the impact of this policy decision on premiums as it rolls out, if enacted.
Well, do you think this proposal would inhibit any underwriting of affordable housing developments?
Well, as you know, sir, we cannot dictate what insurers choose to underwrite and what they don't underwrite. We can only require that they don't engage in unfair discrimination. So it may be that there are insurers that decide if they cannot inquire about the presence of affordable housing, that they decide against underwriting some of these buildings or providing insurance to some of these buildings. But in our collection of data from the insurers, most of them were not asking this question or inquiring about the presence of affordable or subsidized housing. But I can't say for sure what the impact will be. But this is always a risk that insurers will decide not to underwrite these projects.
Okay, getting back to the Life Insurance Guarantee Fund tax credit reform. How was the assessment offset plan under TED Part LL developed, and which entities were consulted in the process?
Absolutely. Thank you, Assemblymember. We consulted with all stakeholders, not just in the executive, including the Department of Tax, but with the plans themselves and many others, including legislators. As you know, we were directed as part of the creation of the Health Guarantee Fund to figure out how to put not-for-profit insurers on the same footing as for-profit insurers who already had a tax credit available to them under the pre-existing Life Guarantee Fund. To do so, we work closely with the tax department and others and have put forward a proposal to the legislature in time for the January 15th due date that proposes to reduce assessments for the Health Guarantee Fund on not-for-profit insurers by 80%, and that would effectively put them on par with for-profit insurers who receive an existing tax credit for participation in the fund.
And how does the proposal differ from the current model of how tax credits are issued to members of the life and health insurance company Guarantee Corporation?
So it actually just extends the credits to not-for-profit insurers. Under the Life Guarantee Fund, for-profit insurance companies were entitled to a tax credit that existed prior to our enactment of the Health Guarantee Fund. So with the Health Guarantee Fund and the proposal that the legislature required us to put forward, that tax credit is extended to insurers that are now part of the Guarantee Fund that weren't before. And again, we took the step as directed by the legislature to reduce assessments on not-for-profit insurers 80% to put them on par with for-profit insurers.
And how do you think the proposal will impact overall state tax revenue receipts?
So I think that question is probably best answered by the tax department and DOB.
Okay. One of the governor's major proposal, and I know you're a supporter of it, is the insulin cost sharing elimination or elimination of co-payments. What is the anticipated effect of eliminating cost sharing for insulin prescription on health insurance premium?
Thank you, sir. I think this is an incredibly important proposal, especially as we talk about health equity. As we know, communities of color are disproportionately impacted by diabetes. We expect the premium impact to be minimal, 0.03 to 0.04%. Is our best estimate, but we've seen from studies in other states where this has been implemented that taking the cost of insulin to zero, cost sharing, increases medical compliance, reduces the rate of complications from diabetes, and can result in up to 18% in cost savings overall.
How many other states have proposed or enacted a zero cost sharing proposal, similar to the one the governor's proposing?
So I can come back to you with a precise number of the other states. We looked at a couple of states, and I think the most studied state in this space is Louisiana.
Okay, so it's still a small number of states?
I'd have to come back to you with a precise number of
Okay.
how many states have done this, yes.
APG rate floor for Office of Mental Health and OASIS facilities. And again, this might be a question for Commissioner McDonald. How does the average commercial reimbursement rate for OMH and OASIS facilities compare to the APG rate?
Absolutely. So, sir, as you know, I like to be data driven. And so when we looked at the data around this question and proposal, we found that in some cases, commercial insurers paid more than the Medicaid reimbursement rate, and in some cases, they paid less. But we thought it was important, the governor thought it was important to make sure that everybody was paying at least the Medicaid reimbursement rate. And so, as I said, in some cases it's more and in some cases it's less. But putting this floor in place assures that those who are paying less can no longer do so.
Ian, how many facilities would be eligible for this rate floor under the proposal?
That's a question best answered, I think, by OMH. I know it's the state authorized OMH and OASIS facilities.
Okay. And now time is going, but what on supplemental spousal liability reform? How will insurers implement that proposal? And will the proposal apply to renewed policies as well?
Yes, and I will be mindful of time so we can follow up in writing. This is a proposal with which I have some personal experience, having had to decline supplemental spousal insurance as a single woman. But we will work with insurers very closely to make sure that they are implementing the new proposal within the 180 days of enactment, if it's enacted, and happy to follow up separately in writing and otherwise to fully answer your question, sir.
Okay, and finally, will single insurers enrolled in this coverage have to submit a... I'll get back to it on my
Okay,
on my
sounds good,
3-minute rebuttal.
Yes, we're very serious about time limits here. So sorry.
I see.
I'm sorry. I just want to let people know that for those of you who have seats sort of in front of the top panel, when we call your name and you need a microphone, just ask someone who's near a microphone to give up their seat and then give it back to them afterwards. And they will be very happy to be helpful with that because we've just already outgrown the room. So our next questioner is Pat Gallivan, the ranker on health.
Thank you, Madam Chair. Good morning to everybody on the panel, and thanks for being here. My first question is to Director Basiri. And the governor's budget proposes $400 million in unallocated cuts in Medicaid. I'm curious about a number of things. Where did the number 400 million come from when these cuts aren't identified at all? And what ideas do you have for cuts? I mean, are you able, surely if you came up with the number 400 million, you've got ideas of where cuts should be made.
Thank you for the question, Senator. The number 400 is really specific to being balanced in the Medicaid global cap. We do have a statutory growth rate of around this year at 6.2%, 6.7%. We are growing at almost 11%. And so many of the reductions are to get us in line with that statutory growth rate, the 400 being included. 200 of the 400 is specific to long-term care. The other 200 is general. We don't have any predetermined savings proposals. I think that's something that we would work collaboratively with the legislature to identify. But we do take our stewardship in the program very seriously and want to live within the resources we've been allotted, which we are currently not doing. So we don't have any specifics to share at this time, but certainly look forward to working with the legislature through the budget process.
And you anticipate all of that to be identified before the April 1st budget's adopted?
I do.
All right. Thank you. Dr. McDonald, you testified briefly about the opioid epidemic, and it is an epidemic. Each year we talk about it, and we come back the following year and there's more people that have died as a result. Do you happen to know, as far as the deaths that are taking place across the state, are these overdoses caused by legally possessed drugs, or have they come into the hands of these people illegally? And what I mean legally, like a prescription.
Yeah, I really appreciate your interest in this. It's really shifted, hasn't it? I've been dealing with the overdose epidemic for well over a decade here. It's interesting how it used to be prescription drugs were really the way that just killed people. But it's interesting, in 2013, when you saw fentanyl really take over and fentanyl analogs come in, you really saw this shift. And really, it's fentanyl, but it's the illicitly obtained fentanyl. It's interesting. You do see fentanyl as a legal drug. You certainly, if you have a colonoscopy or something like that, you get fentanyl from your doctor. But it's the illegally imported fentanyl that's really driving the deaths in New York and every other state across the country. And so really, it's the illicit drugs that are causing the majority of the deaths.
So what do we do about it?
So there's a lot that we can do. I think of it as a supply problem and a demand problem. As far as the supply problem, there's not a whole lot the Department of Health can do. It's coming into the country. There's other places and people who can help mitigate the supply into the country. From a demand problem, we do what we can to reduce the risk of someone getting a prescription opioid. We want responsible prescribing. We're doing a lot in this budget to increase access to buprenorphine. It's interesting. The federal government moved in a direction to allow people to get a 3-day supply of buprenorphine. We're having an amendment in our budget so we can do that in New York as well. So if you go to the emergency department and you're interested in getting treatment, you can get buprenorphine. I think it's a nice, tangible change. We're doing other things to make buprenorphine more widely available as well. We do that through telemedicine. I love the Matters program. We're doing some other things as far as making sure there's more peer recovery coaches out there doing things like that. And of course, there's more naloxone. It really gets to one of the other issues I talked about in my testimony, though. It's not just fentanyl. Xylazine is real. It's a real big issue. And I think getting that on the controlled substance list would help a lot. So at least we can educate people about preventing that from being more of a problem than it is. Thank you.
Thank you. Doctor or director, I don't know who would be the most appropriate to answer the question very quickly because of the time. The proposed budget calls for the elimination of the Quality Incentive Program and its funding. It seems to me that's been a successful program. Why would we get rid of it?
It's certainly, the department certainly prioritizes quality. This is not a cut that we're necessarily proud of, but in a tough budget year, we wanted to preserve services and avoid cuts that would impact members directly. So we are exploring other ways to mitigate that through the 1115 waiver. But yeah, it's a tough cut.
Thank you.
Thank you. Before I hand it back to the Assembly, we've also been joined by Senator Gounardes and Senator Mannion. Thank you.
And on the Assembly side, we've been joined by Assemblymember Jennifer Rauschenmeier. Next on the Assembly list of questioners, Assemblymember Ed Roth for 5 minutes.
Thank you. Good morning. Thank you all for your testimony. So, Commissioner McDonald, just to start, we obviously have a managed care procurement provision in this budget. I know that this report was just released yesterday afternoon, which is, disappointing because we have a proposal in this budget. The report stated October 2023, so a few months ago. Why was this dropped at the 11th hour the day before the budget hearing? That is something that I expected from prior administrations within your department, but it's disappointing to see that happen so that the legislature didn't have a chance to review that prior to today's hearing.
Yeah, I'm sorry about that. I'll just own it. How's that? I mean, I just say we are trying the best we can to get reports out as quickly as possible and to get them on time. I want things to come to you on time. It's something that I think it's just harder than I imagined it would be. But we'll do what we can to get them. There's a couple dozen reports we had to get out this year. I'm sorry about the ones that were late.
So there's an estimated $300 million total Medicaid savings related to managed care from this procurement proposal. Can you elaborate on how you believe that this proposal would achieve those savings?
Let me have Director Basiri address that, please.
Yes, thank you for the question, Assemblymember. We are currently assuming a percentage of administrative efficiency that would be able to be achieved through the managed care procurement, which is on across all lines of business with the exception of HIV SNP plans. So it's an assumption on administrative efficiency that we would garner from going through the competitive process and identifying plans that had broad provider networks and would be able to spread some of their fixed infrastructure across the state.
And does the procurement proposal and the elimination of quality incentive funding run counter to the work DOH expects the plan to do as part of the recently approved 1115 waiver to improve health equity, eliminate disparities, and address social determinants of health?
I would say that it shifts some of the quality incentives and priorities that we currently have towards the goals of the 1115 waiver, which are centered around health-related social needs and connecting members to the social care supports that they need So it's really a shift because the current quality incentive programs are focused on medical and clinical outcomes. So we're sort of reprioritizing our quality incentives.
And I have Commissioner McDonald. I have one a totally separate issue, but I don't know if you happen to see this, but there was an op-ed yesterday in Newsday about, I guess, illegal vaping products coming from China. In particular, ones that are geared towards children. I know this has been an area of focus, both for the administration and the department over the last few years. I was wondering if you can tell us anything that's going on within the department to address that issue and crack down on these illegal products.
Yeah, I'm concerned about children, just period. And I'm very concerned when children participate in vaping. I don't need children addicted to any substance. You can expect the department to be deploying some funds from last year, some from the Juul settlement, some from you, a little over $7.5 million towards campaign we're doing to address this. I think really one of the big issues we have to face, though, is that this stuff is far too accessible, and it's really just one of those things we have to look at is how do we make this less accessible to children? The age here is 21, but there's too many kids who are getting access to this.
Okay. Thank you. I think that's all I have. Thank you very much, Madam Chair.
All right. You don't get his extra seconds. I'm sorry. Our next is Ranker on Insurance, Senator Helming.
Thank you, Senator Krueger. Thank you, Commissioner, for your testimony. Superintendent, it's always great to hear from you. As you all know, I'm not saying anything that you don't know, probably even better than I do, but our hospitals, our nursing homes, our FQHCs, they're in crisis. They're struggling. We talked about the workforce issue. We talked about funding issues. And I just want to make it very abundantly clear that they need our support right now. They don't need more cuts, especially to funding. I wanted to talk real quick about FQHCs. In my district, what's happening, because the funding reimbursement rates aren't keeping up, is I'm seeing closures, cut to service, cut to hours. I don't know, Commissioner, if you saw the Urban Institute's recent study that they did, that it showed that costs for FQHCs are 44% higher than the maximum allowable Medicaid rate. This is unsustainable, and again, it's driving those changes to operations, which in my rural communities is a real detriment. There aren't primary care individual single providers who are available. We count on these centers. So we need to invest in our providers. And one of the things that we can do, I did notice in the budget that the governor proposes expanding billable providers to certain entities. Those providers being whether it's substance use counselors, doulas, we've talked a lot about, et cetera. But it doesn't expand that billing option to our FQHCs. Why not?
Yeah, I like FQHCs a lot. There's a lot in the budget to improve funding through the 1115 patient-centered medical home. So that will help those that participate, which is probably most. I really do think the workforce issues are real. I've talked to a lot of federally qualified health centers. They'd love to have medical assistants who give vaccines. They'd love to be able to hire more doctors. I think the licensure compacts are more important than ever because they can't find staff. And the dental work, oh my gosh.
Can you just address the issue about why not expand to FQHCs the ability to bill for doulas, substance use providers, and similar, so that they can continue to provide those services?
So I don't know necessarily that they're prohibited. I'll have to take that back and get more. Like the coverage is for the patient, for the essential plan. One of the things we have in the budget this year is a standing order so everybody can have access to a doula who's having a baby. That would apply to anybody. I don't know that there's actually a prohibition.
Into that, the billable ability, I can get back to me. I appreciate that. I also wanted to get back, Commissioner, I believe it was you who said that on the question Assemblyman asked about excess medical malpractice, that the state is looking at finding savings. You know what? From my perspective, we need to balance that out, right? Physicians are already paying more in this state than, I read 68% New York has the highest cumulative medical liability payments of any other state, 68% more than the second highest state of Pennsylvania. So again, when we talk about the state is looking at trying to find savings, and that's why the proposal in Part K, the governor's budget, is what it is. Can you just tell me, is that going to incentivize physicians to come here to work here? We already have the highest taxes in the nation, it's one of the highest tax states. Now we're going to continue to drive up the cost of medical malpractice liability. How does that encourage or incentivize physicians to come here and want to work and live here, especially in my rural communities where we desperately need them?
Yeah, we do need physicians, and I think there's a lot of incentives to come to New York. Not obviously, this isn't one of them. I think one of the things to just put in mind of everybody is this is a challenging budget year. There's been a lot of difficult choices that have been made. I want to be really transparent with folks. Like, there'll be a lot of difficult choices that had to be looked at. And quite frankly, it's about how do we have a sustainable path forward? We need stewardship for this year and next and the subsequent years. So decisions
making
are
it
being
more
made.
difficult for physicians to practice in New York State is not the answer.
Thank you.
I am on the yellow warning light already. I wanted to touch on there are a lot of great things in the budget, the expansion scope of practice, etc. I did want to touch on emergency services, especially in rural areas. A couple of years ago, we formed the Rural Ambulance Task Force. The report was due back to the legislature in December. My question to you is, was that report ever done and completed and submitted to the legislature? And two, the recommendations in the budget, are they based on the recommendations of the task force?
So I'll check on the report. I don't have a lot of time, but there's a lot of nice things in here for emergency medical services. And they definitely came out of stakeholder input. And I think we have a nice path forward with emergency
Did the
medical
task
services.
force meet and provide recommendations?
I'll have to get back to you. As far as I know, they did. But
I
I'll get
asked
back
that
to you.
same question last year too. How many meetings? And
Well, as far as I know, they did. You know, this was built on task force recommendations as far as I know. But I'll get back to you to be certain.
And the senators who are walking in, and assembly.
Our first, we've been joined by Assembly members Jacobson, Reyes, and Delan. And the next Assembly questioner is the ranker on health, Josh Jensen.
Thank you very much. Oh, that was loud. Chairwoman. Commissioner, in the 2023 enacted budget, there was $187 million allocated to support nursing homes to comply with the mandated staffing ratios. That funding was never released. Simultaneously, DOH is now starting to penalize nursing homes for their failure to comply with these same mandates. Is there a plan from DOH to allocate that funding at some point? And what is DOH going to do to assist the long-term care facilities to comply with the mandates, especially in areas of the state there is a labor shortage?
Yeah, so we are enforcing the state staffing law. There are regulations. We are enforcing that. Some of those cases are walking through the regulatory process now, and of course, I can't get into that. Having said that, as far as the money goes, as far as I know, it's been allocated and some of it's actually been spent, but not all of it's been spent. So there is a path forward for that.
Okay, so some of that 187 million is starting to go out the door, or
Yes.
Okay.
Yeah, and as far as the staffing shortage goes, well aware of that. I couldn't agree more. There's a real problem with staffing, particularly in the western and north, and your part of the state. Quite frankly, it's very acute up there.
Hence my question for it. This transitioning to assisted living, the governor's budget proposal eliminates the Equal program. It's only a $6 million program, and the money is directed for resident councils for facility improvements. Can you explain the thought process for why we're eliminating the small amount of funding
Yes.
for assisted living that's already suffering from some underfunding?
The thought process is we had a lot of difficult choices this year and a lot of difficult decisions. We had to find a lot of savings. Medicaid's growing really rapidly. A lot of things are going really rapidly. It's crowding out other things. So we had a lot of difficult decisions to make. Regrettably, this was one of them.
Transitioning to, and I know Senator Helming brought this up, but in relation to dental care, why are we seeing reimbursement rates for dental care not match the same reimbursement? This, I guess, for Director Passeri, why are we not seeing the Medicaid reimbursement rates for dental care match the same level of increases or commitment that we're seeing across other healthcare areas?
Well, we are increasing dental rates. Governor Hochul put in and instituted an across-the-board increase, the 1%, which compounds year after year, and that does apply to dental rates as well as every other rate. I do think we have a supply challenge on the dental side, and we have spoken to other state Medicaid programs who similarly struggle with this issue, and we've been told resoundingly that increasing rates will not single-handedly solve this problem. And so what you'll see in this budget that Commissioner McDonald and others will speak to is around a multi-pronged strategy that includes scope of practice changes as well as investments in the 1115 waiver specifically to get more dentists into the Medicaid program.
Okay. In the financial plan, the Medicaid budget, I guess for you again, Director Passeri, the Medicaid budget is expected to exceed the Medicaid global cap starting in fiscal year 26. If the Medicaid budget continues to threaten the global cap, is there a plan to address the financial health of the Medicaid program to ensure that we stay under the global cap moving forward?
Absolutely. Each year we go through that process, including right now, which is why, there are some difficult choices, as Commissioner McDonald said, and specific to the Medicaid program. There are some concerning trends that suggest we will continue to spend over the statutory growth rates absent any change. And that is why we have some hard choices that we'll have to work through over the next couple of months.
In the executive budget, there's a mention of a high enrollment and lower than expected disenrollment based on the public health emergency unwind as it contributes to Medicaid funding. What are the reasons for the discrepancy between the disenrollment projections and the actual disenrollment numbers?
So there's a few reasons. The good news is that we've done a really good job of retaining coverage through the unwind process, the 14-month unwind process. And part of that is due to the federal flexibilities we've received around ex parte and multiple modalities and giving people multiple opportunities to come back for their renewal process. When we did our initial projections, some of those flexibilities were not in place, and so our projections were slightly off. But month over month, that compounds, which is why you see more people staying on the books than anticipated.
Thank you both.
Thank you. Senator Hinchey.
Thank you very much, and thank you all for being here. My questions are for the Commissioner. In the executive's briefing book this year, it states that currently 75 of 261 of New York's hospitals are financially distressed, with that number increasing. The executive budget also acknowledges that there's an unmet need between $1 and $1.5 billion for financially distressed hospitals. And most of these 75 facilities are not eligible to participate in the 1115 waiver funding for financially distressed hospitals, which is limited to a small subset of hospitals currently. Under the financial picture presented in the budget briefing book, will there be any resources available for hospitals that are on the verge of becoming financially distressed that need funding to be able to operate for fiscal year 25?
Yeah, let me address that first, and Amir can add if we want to. We do have $984 million. We obviously want our hospitals to survive and do well. We're concerned about our hospitals. I'm very familiar with the data you're quoting, of course. And so it's one of those things where we have a process, there's multiple tools we have, and, there's $984 million. That will go quite a ways.
Right, but we know that there's more, all of that funding right now is allocated effectively for the 6 hospitals that receive it. And there are significantly more hospitals that are on the brink that do not qualify right now today, but will qualify or would qualify in the future, let alone 25. What's the plan?
So if you don't mind, I can go back to the first question. You said the 1115 waiver does not include hospitals in the 75. It actually does. One of the criteria is that they have to have been in receipt of one of our state subsidy programs, the Vital Access Program Assistance Program, VAPAP, we call it for short. And we generally monitor case-by-case issues with all hospitals on a ongoing basis. To the extent they are coming into financial distress, we will know that in advance. Our payment programs, some of them are specific to eligibility, whether they meet a level of need or Medicaid and uninsured payer mix. We do have the VAPAP program to address one-time and emerging needs, and we would continue
Which needs
to do that.
more fund. I mean, we're in this situation right now with a hospital in my district, and the VAPAP funding is not there for it, and they don't technically qualify for distress hospitals today, but they will. And we're seeing that the amount of funding that is allocated today does not cover the need that's there. So we can follow up with you separately. I have 25 seconds left, but I think there's an acknowledgement that there's going to need more support. On December 6th, the governor announced $3.5 million for mental health services, and we actually are fighting to get our mental health beds back. And notably, within the 13 new clinics across the state, the Mid-Hudson Valley was not included in that list. So in the same day that we're having discussions with the executive's office on bringing back mental health beds, with an acknowledgement, I'll get this in writing, of course, but when we were fighting for mental health beds and an announcement comes out for funding,
Michelle,
ours is not included.
You're out of time.
What's that reason? I'll look for
You
it in
can
writing.
follow up with them afterwards, and I'm sure we all love to know the answers. So if you would mind, put them in writing in some long list of questions you will have to respond to after the hearing. Thank you.
Thank you.
Assemblymember Michaela Lodge.
Thank you for being here. You know, I see a series of funding cuts to public health programs such as Cancer Service, Tick-Borne Disease Institute, Nurse Family Partnerships, the Medicaid Managed Care Pools, Quality Pools, which is an evidence-based program. I'm just really worried. What is the thought process behind this, and how are these impacts are going to affect health equity here in New York State?
Yeah, so I really want to preserve health equity. And what I'm really trying to do is provide the best resources to everybody with the best outcomes. The thought process is we had to find savings. We tried to find savings that weren't going to have as much impact as others would. When you look at where our money is going, it's going to hospitals. It's going to Medicaid. That's where the vast majority of our money is going. We're trying our best to help patients in our medical home. We're doing a lot. We don't want to cut any public health programs, but we had to make some small cuts in some of these programs. It's painful, but that's where we had to go.
Yeah, some of these programs like Nurse Family Partnerships really goes at the root of the problem, making sure that mothers have access to high quality needs programs. So I think we should really think about how we should invest into these programs versus cuts.
I'd love to work with you as we go through the budget process.
So next, I want to go back to the conversation about electronic cigarettes and cigarette devices and vaping. So we see these devices getting in the hands of our young people, and I want to know, what is the response? What are we doing in respect with law enforcement, using our governmental powers to ensure that these products are not getting into the hands of youth and others?
Yeah, local health departments are doing what they can to work on enforcement of this. We're going to be doing advertising and messaging with this. It's really an issue much larger than us, though, right? Like, why do kids have access to this? Why are people selling this to people when they shouldn't be? Because kids are kids, but why are people selling this? Shouldn't they understand they have a consciousness not to do this? So we have a lot of work to do in this space.
Can we go after the bad actors? We see a lot of these convenience stores selling these products to young people. Is there anything that DFS can do to go after these actors?
Happy to work with you on any proposals you might have to put forward. In terms of the convenience stores or others, that would certainly be outside of DFS's purview.
Okay. Is there any ideas? I mean, you have an educational campaign, but what does that entail?
So, a lot of it is speaking to people at their, we do focus groups, understand what people want to hear, find messaging that works. We've had a lot of success with tobacco in the past. So it's finding the right message and getting in the right medium. So a lot of it is persuading people. But a lot of it is to get to the hands of enforcing what we can do. And a lot of this is left to local law enforcement and local health departments, and they're doing the very best they can.
Are we collaborating with those local law enforcements?
Local health departments are collaborating with local law enforcement to the extent they're able.
Okay. Thank you.
Sure.
Sorry. Thank you. Next is Senator May. She did say she would have to run quick. We'll put her back on the list for later. Senator Ashby.
Thank you, Madam Chair. Thank you for being here. Commissioner McDonald, given the governor's focus and your focus on maternal and internal health, infant health, I have some questions I want to talk about the Burdett Birth Center. Trinity Health has submitted a closure plan to your office for the Burdett Birthing Center due to the fact that Trinity began acting on the closure plan prior to approval, requiring your office to offer a cease and desist warning, and considering the Save Burdett Birth Center Coalition uncovered falsehoods contained within the closure plan. Do you believe that your office should commence a full review rather than a partial review?
Yeah, I really appreciate what you're asking, and I'm obviously very aware of what's going on in this area. By the way, I get emails every single day about Burdett, just so people know I read their emails. Every single day I get many, and just so people know I read every one of them. I can't talk about this as much as I'd want to because it really is firmly in the regulatory process right now. I think one thing I would say, though, just to every hospital out there is it's very important not to get ahead of the department. It's very important for hospitals, if they have an idea they want to close something, to go ahead through the process, but not get ahead of the department, and you shouldn't assume what the department's going to do. What you should do is go through the closure process, do the health equity impact assessment, but very important just to not get ahead of the department.
Given the fact that they have, wouldn't that warrant a full review now?
Yeah, I really don't want to get too much into Burdett. I really hear what you're saying. I appreciate what you're saying. I think it's very important for me to preserve the regulatory process. So I hear what you're saying, understand what you're saying, but I think we have to just leave Burdett to the side for a minute.
Do you believe that the closure would negatively impact the health of mothers and newborns?
Yeah, I don't want to answer it directly about Burdett, but I am concerned about maternity deserts in New York. And I'll just throw this for consideration. We do have 2 maternity deserts in New York. One's in Hamilton County and the other one's in Seneca County. I don't want to see more maternity deserts. So just from a large scale issue, I think that's something we understand that hospitals have certain direct patient care functions. I think maternal care is really important. People should be able to go to a hospital and have a baby. But I can't speak specifically to an active regulatory issue right now.
Appreciate that. This question for yourself or Director Basiri. Given the cuts that we're looking at in Medicaid towards long-term care, has DOH estimated how many nursing homes may close because of this or limit their beds? I mean, we're talking about hundreds of millions of dollars in cuts.
So thank you for the question, Senator. I think you're referring to the 2 nursing home actions, one being on the capital reduction. We don't anticipate any nursing homes closing as a result of that action. It's building on something we'd done a couple of years ago. Certainly not ideal, but don't anticipate closures as a result of that. The other is actually unallocated funding. I wouldn't frame it as a cut per se. It's funding we have not allocated over the past 2 years for financially distressed nursing homes.
Thank you.
Thank you. Just to remind members who might have come in before or later than when I gave my lecture in the beginning, that clock is for your questions plus the answers. So some people go on longer. So I'm just letting everyone know again, look at that clock, and that's for you and also for the responder. And if they don't have enough time to answer, we're asking them to put the answer in writing and get them to the 2 lead chairs, and we'll make sure all members get the answers. Thank you. Next assembly.
Yes, thank you. First, we've been joined by Assemblymember Forrest and Hunter. Thank you. Our next assembly speaker is Ken Blankenbush, ranker of insurance.
Thank you. Welcome, Superintendent. It's good seeing you again. And I, again, with David Weprin, appreciated you showing up at our Insurance Committee meeting. Hope we can do that again this year. I have a follow-up on the ownership of affordable housing and insurance. In November of 2022, DFS released a report and on affordable housing and insurance. Since that report has come out, have you received any types of complaints or any feedback to your agency related to the affordable housing and insurance?
Yes, sir. We've engaged quite a bit with housing advocates on the issue.
And Has the department identified any patterns or practices that reflect misconduct by insurers?
And sir, we did an initial data call to insurers and got quite a robust response. Many of the insurers indicated that they don't ask about the presence of affordable or subsidized housing as part of their underwriting. Some indicated that they do ask that question, but that it doesn't necessarily impact their underwriting. So that was just an initial data call that we did after the report was issued.
So your response by some insurance companies, even though they asked the question, it doesn't reflect their underwriting decisions?
It doesn't reflect their underwriting, yes.
But some do?
But some ask the question, but it doesn't necessarily result in them not issuing insurance to the. It does not result in them not issuing insurance to the property.
So, what kind of enforcement mechanism or oversight is going to be put in place to oversee this?
So if this proposal is enacted, of course, we will examine accordingly to make sure insurers are not using this factor in underwriting. And every time we go in to examine a company, our experts go in and look at the books, interview executives. If we find that they are improperly using this, we won't hesitate to bring supervisory or enforcement actions.
Penalties?
Potentially, yes, sir.
And who sets those penalties? DFS or?
Sometimes they are set by the legislature in statute. Sometimes they are administratively set.
Okay. Because I've been in the insurance business most of my adult life, retired now, but so no outside income. So my question, over the years, I've had discussions with underwriters. I guess you could call them discussions that I thought particular businesses or property was a good fit for the company, and the company underwriter sometimes has disagreed with me and so forth. And over the years that I've worked on this, I've had companies that would pull out of certain markets because it was a loss ratio for them. And sitting here looking at this, I can't imagine them not having an effect on the availability and the affordability of insurance. I think that your answer just a little while ago is, well, you don't think that's going to be the case? Or?
Sir, it's hard for us to know. Of course, we can't tell insurers, to your point, who to underwrite and who not. We can only tell them what factors may be unfairly discriminatory and that they're not permitted to engage in discriminatory conduct. But of course, a business will make its own determination, as you noted, as to who to underwrite and who not. So whenever we prohibit a factor in underwriting, it is a risk.
Okay. I want to also follow up on the supplemental insurance question. The major reason I voted no on this bill was the opt out.
Correct.
Rather than the opt in.
Yes.
So my understanding now is if I was still in business and I was writing a piece of property or a life insurance or automobile insurance, if I ask the question, are you married? You're automatically in. Now, so how do you get out? Could you do it at that same type when you're writing the application? Could the insurance agent submit a piece of a paper or something opting out at the same time that he submits for new business?
So I'm cognizant of time on the clock, so we can follow up in writing, but there will be the same declination form for people to opt out if they are defaulted in.
Thank you.
Thank you. Next is Senator Zelnor Myrie. Thank you.
Thank you, Madam Chair. My questions will be directed to Commissioner McDonald, but I'd be remiss if I didn't join Chair Breslin in commending the superintendent for her work at DFS, and particularly last year during the Signature Bank crisis. I think we should be investing as many resources as possible to allow the department to continue that work. Commissioner McDonald, 2 years ago, this legislature passed a statute that required the department to issue a study on health inequities in Central Brooklyn and to also consider constructing new health facilities for women and children. We inquired about the status of that report in October of last year. You responded on October 17th, 2023, saying that it would be complete by October. It was not. We checked back this in January, and you responded last year, March 7th, 2023, to say that it would be completed by this month, January 2024. There are 8 days left in this month, and so my question is simple. Where is the report?
I know exactly where it is, and it's coming soon. I'm sorry you don't have it. I'm sorry you don't have it. You should have it. I'm just sorry you don't have it, but I know where it is, and it's coming soon.
Okay, so we don't have the report on health inequities in Central Brooklyn. We do not have the report on potentially new facilities for women and children. We do not have the report on capital investments for regional perinatal centers like SUNY Downstate. But in this budget, the governor and SUNY have insisted on a transformation plan for SUNY Downstate in Central Brooklyn, where there are health inequities, where we need more services for women and children. So my next question is, did SUNY inform you about this transformation plan? And if so, when?
I learned about SUNY's transformation plan in the media. So I don't have any more knowledge about that than you do. I will tell you, when you do see the report, it's robust and it's got data analysis, so it should be worth waiting for. Again, I'm sorry we didn't get it on time to you.
Okay, so I just want to be clear for the record, being mindful of time. So we did not get the report in the statutorily required amount of time. And then the so-called transformation plan for Central Brooklyn was not even communicated to the commissioner of the Department of Health for the only state-run hospital in the city of New York. I think that's unacceptable. Thank you, Madam Chair.
Thank you, Assembly.
Thank you. The next up for us is Assemblymember McDonald.
Thank you, Madam Chair. My question is going to be towards DOH. It's about maternity services. As Senator Ashby had mentioned, Burdett is proposed to be closed in Troy. There's 24 closed in the last 15 years. Maternity wards in general. Currently, there's 5. Burdett. Last week, St. Catherine of Siena on Long Island. The governor has made some very, I think, meaningful proposals in the budget, and I support them in regards to expanding maternal services. And also my understanding, and Amir will correct me if I'm not wrong, Medicaid raised their rates for fee-for-service and managed care back in October of last year. And hospitals upstate, at least, are seeing a significant shift because of the Medicare wage index, which is going to help their overall health, but also have an impact because a lot of times fees based off the Medicare wage. So those are facts. That's not opinion, it's facts. Simultaneously, DOH has issued regulations for midwife-led birth centers this past year. Burdett is a midwife-focused birth center. Midwife-led birth centers within a hospital would have the resources to handle higher-risk situations if they arise, and I think are an ideal model and something I believe should be statewide. Personally, I think Burdett is the model we should be shooting for. However, Trinity Health, an out-of-state conglomerate worth billions of dollars, is looking to close Burdett, which I find to be problematic. Now, my question is not about Burdett. My question is, when can we expect more on the midwife-led birth centers from DOH? And just as importantly, as the department is looking at these closures in general, are they looked at retrospectively on the sustainability question, or are they looked at prospectively on the sustainability issue?
So I do expect midwife birthing centers to open in New York State in 2024. That goes through Public Health and Planning Council. I expect that will happen. One thing I think it's really important, though, is people not get ahead of the department. You mentioned some facilities that are talking about closing the maternity units. That doesn't mean we haven't made decisions on this yet. I just want to be really clear. Please don't get ahead of the department on this. There's a process that people have to go through. And I just don't think people should assume where the department's going to go. I think the midwife regulations we're working on are going to be helpful as well. And to your question about data, we look at data retrospectively, and we do look at what is the prospective impact on the community. I'm not speaking about any particular closure, but obviously when someone's talking about closing anything, anywhere in the state. We're very concerned about health equity and how it's going to impact the people who count on hospitals, emergency departments, whatever we're talking about closing.
DOB has proposed a $228 million cut to the health home program. Does this include the children's program?
I don't believe the proposed cut is of that magnitude, but we're happy to take that offline and get you more details about that.
Thank you, Mayor.
Senator Borrello.
Thank you. First of all, thank you all for being here. I have questions for all of you, but I'm going to start with the most pressing one for you, Commissioner McDonald. Your predecessor instituted Rule 213, Department of Health Regulation, perhaps, without a doubt, actually, the most draconian rule ever to be put into health code in New York State or perhaps anywhere in the United States. It would allow any public health official to forcibly remove someone from their home and quarantine them. It included no due process and no proof that that person is actually sick. Something you'd see more in mainland China, in communist China, than you would in New York State. That was overturned by the state Supreme Court on grounds that it was unconstitutional. I brought that lawsuit along with others. And then shamefully and incorrectly, the Fourth Appellate Division overturned that because they said we as state legislators didn't have standing to bring a lawsuit on the separation of powers. So with that being said, that paves the way for you to be able to reinstitute Rule 213 or something similar to it. Do you have any plans to do so?
You know, I can't talk about active litigation, but I do want to talk a little bit about some things. I think far too often we confuse the terms isolation and quarantine. You said we would remove someone from their home by quarantine and they weren't sick.
Yes, that's correct. There's no requirement they actually
just
be
so we
sick.
know. No, I understand. That's the very definition of quarantine. You were exposed to something. I just want to make sure people understand that because too often you get this confused. If you're ill, you isolate the ill, you quarantine the exposed. Having said that, there's active litigation on that issue. I can't get into it in great as much detail as I'd like.
But we already have a rule. We already have a law in place for 70 years that included due process and other constitutional protections. This was a copy and paste of Assembly Bill 416 by Nick Perry, which never went anywhere, which was the basis for our lawsuit. So the question is simple: yes or no? Do you plan to reinstitute Rule 213 or not?
I don't have any plans at the moment to reinstitute that.
Okay, that's good.
Okay.
I would suggest that you and the governor do not do that. It is perhaps the worst Department of Health ruling ever in the history of our nation, and I would strongly suggest that you protect our constitutional freedoms by not doing that. Thank you very much. I'm going to move on now to the Medicaid Commissioner, if I can. How much? 48 seconds. Non-emergency medical transportation has been a costly boondoggle that has benefited these brokers to the tunes of millions of dollars. More than 2 years ago, the Medicaid redesign team said we need to throw it out. Our comptroller said it's wasting millions of dollars, and yet we haven't seen any reforms. Can you just quickly speak to what you're doing to ensure that we're not paying taxi drivers more than we're paying doctors and nursing homes to care for our elderly?
Yeah, sure. Thanks for the question. And in the time remaining, I would say we have implemented a statewide transportation broker earlier this fiscal year. It is being expanded for the Managed Long-Term Care Program in a couple of months. But that protest at the comptroller's office was resolved, and we did move forward with a statewide contract. So we are getting delivery rates under control.
Thank you.
Thank you.
Thank you, Assembly.
But before I did, we've been joined by actually two members prior that I failed to mention, sorry. Assembly members Walsh and Blumenkrantz, and more recently, Joanne Simon. The next Assembly member is Assembly member Bennett. And oh, I skipped Gandolfo. I skipped Gandolfo.
All right, thank you. Thank you for being here. There's an $810 million state share Medicaid funding gap for nursing homes, and more than 6,000 beds have been taken offline over the past 6 years. Medicaid members are in need of care for nursing home placements, remain backed up in the hospital, or have to be placed in facilities outside of their communities, causing family members to drive hours for a business. Despite this, the governor's budget really decimates the nursing home industry. With billions of dollars in reserves, why would the governor cut nursing homes?
Thanks for the question, Assembly Member. I don't think there's as wide of a cut as being perceived. I was mentioning in one of my earlier responses, part of the reduction is unallocated state subsidy support for nursing homes. In the past 2 years, we've had $100 million to issue to nursing homes. Only $22 million each year has been expended to between 10 or 9 nursing homes. So it's not necessarily a cut per se, but it is a better reduction than would be to cut services. So it's unallocated spending, which is the primary focus of that reduction.
And how many nursing homes do you think will close if these cuts go through?
I don't know that I can answer that, but I don't anticipate any will close as a result of these reductions.
Okay. Thank you. The governor's budget freezes the NH opening rate at January 24th, 2024 levels. Last year's budget included a 7.5% Medicaid rate increase. Only 6.5% was provided in the rates. Does this freeze mean that NH's nursing homes will not receive the additional 1% that was approved last year? And if so, the Medicaid scorecard does not reflect this savings account.
So two separate issues. So the 7.5% rate increase from last year is still under federal review and approval. The state moved forward and issued 6.5% to the nursing homes. And when we get the federal approval, they will get the additional percentage point. The freeze is a separate issue that is something we do not have an option to address. And it's because the way we calculate acuity in the nursing home, which is a factor in the payment, is done by some federal assessments. We draw down on the federal assessments. They're changing their methodology, and they're using a different assessment called the patient-driven monitoring program, and that is a different assessment. So the freeze is temporarily till we are able to align to the new federal implementation, but it's something we don't have an option on.
All right. Thank you very much.
Senator John Liu.
Thank you, Senator Breslin, for the tech assistance. And thank you, Madam Chair, and thank our commissioners and their colleagues for testifying. You know, I'm looking at the testimony between Commissioner McDonald and Superintendent Harris. And it would appear that DFS is like a perfect agency, right? Got this long list of accomplishments, 2023. I guess my first question is there anything that DFS hasn't done? Or anything that Superintendent Harris feels that DFS could improve upon?
There are always things that we can do better, Senator.
Like what?
Any number of things, sir.
Just name one.
We could always have more staff so that we can move more quickly through the backlog. For instance, we've put in place 60-day lists because of the backlogs that we have on many of our filings. As a result of those 60-day lists, we've moved through 11,000 old filings in the past year. But I wish we could move more quickly, and for that, we are working very hard to increase our staffing.
Well, you actually cite that as an accomplishment. I'm actually asking you, what can it be improved? What was not an accomplishment?
Well, there's still quite a lot of backlogs around the agency, sir.
Okay, so you can't think of anything that you could improve upon. The $163 million returned to consumers and healthcare providers. Would you happen to have a breakdown between consumers and healthcare providers? $163 million is a lot. Is it mostly to consumers? Is it mostly to healthcare providers? What's the rough breakdown?
I don't have that with me, sir, but happy to provide it to you.
My conjecture would be that would be mostly to healthcare providers.
That may be the case, sir. Happy to come back to you with that information.
That would be the case. Okay. So the consumer protection aspect of DFS, it seems to always take a back seat to I guess, larger, more glamorous issues. I mean, your testimony says that DFS was at the center of preventing a global financial meltdown.
Yes, sir.
And that was because of the closure of Signature Bank.
And the ripple effects to European institutions that we also regulate.
Who closed Signature Bank? DFS?
Yes.
I guess the FDIC likes to claim credit for that as well.
So
Are they wrong?
DFS closed? No, absolutely not. The way the mechanics work is DFS closes and appoints the FDIC as receiver, and that's what we did in this case, sir.
Okay. Wow, that goes quick.
I know. Sorry about that. Thank you, Assembly.
Thank you.
Assemblymember Lunsford.
Thank you very much. And my question will be for Commissioner McDonald. I see in the governor's budget that there is an increase for early intervention, and I know you share my passion in this area. I see a 5% increase statewide and a 4% rate modifier for rural and underserved areas. So I have two questions. The first, is this entire increase funded by the 1115 waiver funding? And two, how are you determining what an underserved area is when, for the most part, the entire state is underserved for EI services?
Yeah, so it's not funded by the 1115 waiver. It's funded a different way through Medicaid and the traditional way we fund early intervention. Underserved area is based on access to care. And it's mostly rural areas of the state. It's your part of the state, quite honestly, where you're from. So yeah, early intervention is very important. And, you know, getting any investment this year in a year that's this challenging is a big deal. Very thankful the governor allowed us to do this.
I appreciate that, and I know that you've been a strong advocate in this area. Still on EI, I see that there is this rate increase is just for in-person services. Is that correct?
That's right.
So that means that there wouldn't even be a 5% increase for teleservices.
Right.
So in some of our rural areas that are the most underserved, while telehealth is not ideal, it is truly the only mechanism for access. What are we going to do to help these areas increase when there isn't even an in-person provider to access the rate modifier?
No, I agree. I'm concerned about it as well. You know, I think we just have to be honest about this year's budget. We're just getting this increase was a lot of work to get it. Quite frankly, very thankful to my team and the governor for getting it done. I think if we get more providers, period, and I don't know if this increase alone will do that, but we need more providers, period. Quite frankly, the rates are the issue. I'm concerned about our timeliness of care in New York. I'm worried about how long it takes us to get people in. You know, one of the things I remember when I visited the Rochester location was we had a mom come in who gave just a wonderful, honest description of how hard it was to get access to care, and her child aged out before they could get care. I just don't want to see that happen in New York. So I'm worried about it as well, but we weren't able to do that increase either.
I'm trying to squeeze in a quick question about CDPAP. I see that there is an elimination of the wage parity, and that's wage parity for home health workers, correct?
Yes, that is correct.
So that decrease represents an almost $3 cut in the city and an almost $2 cut in upstate, which completely eliminates the $2 raise we put in 2 years ago. You're shaking your head.
Well, it's not upstate. It's wage parity for home care workers is downstate in New York City, Nassau, Suffolk, and Westchester.
So exclusively?
Correct.
So you're just eliminating their wage increase from 2 years ago?
No, they are still going. This will have no bearing on their ability to get the $3 increase that was instituted a couple of years ago.
Okay. I'm out of time. Thank you very much.
Excuse me. Thank you. I believe the next is Senator Brooke.
Thank you so much. And hi, everyone. Thanks for your time today. This isn't very quickly at the top, it's not a question, but just something that is a growing concern. I think it's been mentioned many times about Medicaid reimbursement rates when we're looking at our nursing homes. In Rochester, we just had the single most patients seen at one of our hospitals in its history, and there's over 100 people who are ready to discharge and can't because we don't have the beds. So I urge you, if you're waiting for the emergency, the crisis, we're in it, and I hope that we'll see more to come in the following negotiations. But I want to turn my attention to doula care. Obviously, very exciting that January 1st, the Medicaid reimbursement rate went into effect. Thank you, Commissioner, for all the work that you put into that. I'm wondering a couple things. As we looked at other states who have done this before, before us, we've kind of been able to learn from their mistakes. Notably in California, they did the same thing that we did. The reimbursement rate was a little bit lower than ours, and they've learned that no one will actually enroll because it's actually not a living wage, and they've actually more than doubled the rate that they're doing for doula care. What has New York learned from other states, and what are you looking at in terms of making sure ours is successful?
So we did increase our reimbursement rate quite a bit. I mean, and I have talked to doulas. I was out at meeting calming doulas in Western New York this year. They were optimistic that this rate would work. I think it'll work upstate and downstate. And by the way, just want to highlight again that I think allowing me to do a signed standing order so any birthing person can access a doula would be a really nice thing to do for people.
Agreed. Commissioner, I'm just going to interrupt quickly because yes, it increased from the pilot, which was like $800 something at birth. That wasn't sustainable at all.
Right.
But it should be noted we didn't get to the 1930 that the overall doula community in New York State had asked for, right? And so I'm glad to see the standing order coming into place. Hopefully that will help. When would that actually go into place?
The standing order?
The standing order?
Yeah, the standing order.
I can't do a standing order till you good people let me do a standing order. If you let me do it, I'll do it really quickly.
So if it passes in the budget?
Yes.
If you pass it in the budget, I will have my team start drafting it because I love your enthusiasm on this.
Love that. Okay, in my last 50 seconds, I think this is going to go to Medicaid director. Speaking of things I'm enthusiastic about that haven't happened yet, the state talked about the plan to put a state plan amendment to expand Medicaid services for behavioral health services in schools. And we talked about that at the end of last year. My question is, we know that things like vaccinations, vision screenings, other preventative health measures are much needed in schools as well. Why not expand that SPA to actually include other types of medical services and not just behavioral health?
And thank you for the question, Senator. I know you've been a champion of that school supportive health services program. I think we've been fighting very hard with the Center for Medicare and Medicaid Services to get the initial expansion. We have seen the guidance to go further. I think the reason we've held off is really feedback from the districts and not everyone being in the same place. So we want to do the first part.
Thank you very much.
Thank you. Assembly.
Assemblymember Gandolfo.
There we go. Thank you, Chairwoman, and thank you all for being here today. My question is going to be toward DOH, specifically regarding the Medicaid waiver, which will invest $7.5 billion over 3 years in our state's health and social care systems, including what appears to be a $451 million investment into the investment of state funds appropriated in this year's executive budget. Will any of this investment address the needs of New York's rising population of older adults on Medicaid, the vast majority of which are duly eligible for Medicare and Medicaid?
So there will be benefits for older New Yorkers on Medicaid, although it's not as direct as some of the other investments in the waiver. But specifically, we're doing a lot of career pathways training and workforce development that will include nursing titles and other mental health practitioners that will serve Medicaid beneficiaries, including older adults, specifically nursing homes and those in the community. But in our conversations with CMS, there was much more of a focus on not necessarily the non-elderly, but they felt like we've done a lot through the American Rescue Plan Act and the investments in home and community-based services, which is north of $5 billion, that there was a bigger focus on just delivery system reform and a focus on children's health, as evidenced by some of the investments in the waiver.
Thank you. And the waiver also invests $3.2 billion in health-related social needs services over the next 3 years, targeted to Medicaid high utilizers, individuals experiencing SUD, serious mental illness, intellectual and developmental disabilities, or homelessness, pregnant and postpartum persons, criminal justice and juvenile justice involved populations, and children. Will older adults in need of long-term care services who are not experiencing these conditions benefit from these services at all?
Well, they will be eligible to, because they'll meet the criteria necessary. However, we do have some investments in the managed long-term care program and specifically in care management that include some of those services, including Meals on Wheels and some nutritional services, which would be eligible for funding under the waiver and continue with the demonstration.
Okay, thank you. And what about individuals who are duly eligible for Medicare and Medicaid and therefore would not receive medical or hospital services through Medicaid? would they benefit from the services as well?
All Medicaid members, regardless, will get level one services, which we're defining as case management and health related social needs. So they will get screened for their social risk factors and demographics information and be connected to any state and federal support services if they're not eligible for the higher level services.
Okay, thank you very much. That concludes my time.
Excuse me, Senator Steck.
Thank you. Good morning. In 180 seconds, I'd love to ask a question of Department of Health regarding nursing homes, specifically vacant wings due to inability to hire staff or meet staffing ratios. I've got constituents that are putting loved ones in nursing homes 2-3 hours away. Medicaid reimbursement rates simply have not been keeping up in over the decades. We did a little bit last year, but it's not keeping up with inflation. And I'm hearing my nursing homes tell me that they're in peril of closing. So I'm very concerned about that. Unfortunately, I can't ask about that. I need to ask a question of Superintendent Harris regarding Medicare Advantage plans. Over the last few weeks, my office has called and emailed your office a few times trying to get an answer. We still haven't gotten the answer. There are potentially tens of thousands of policyholders in the capital region, so myself and many of my colleagues up here are affected by this, and I've gotten calls on it. Recently, Albany Med, Saratoga Hospital, Glens Falls Hospital, and Columbia Memorial Health reviewed their relationship with two plans, WellCare and Humana, and decided to terminate them. I have two questions, and we're in the open enrollment period now, so that's why this is time sensitive. It's late January, and the open enrollment period ends at the end of March, and I've got constituents calling me. Two questions are business practices of Medicare Advantage plans providers monitored and reviewed by DFS, and if they're not acting appropriately, are there repercussions? And the second question, the more pressing, are these insurance companies required to notify their policyholders that certain healthcare organizations are no longer participating with their plans? Healthcare providers are notifying individuals in their system. Glens Falls Hospital has notified 6,000 people that they serve, but their concern is people that aren't currently on their radar in their system are going to be finding out and potentially surprised that they thought they had coverage at the local hospital and they don't. So I'm very concerned about that, and again, the open enrollment window. So if you could answer those two questions, please.
Yeah, I will do my best to do so expeditiously and then, of course, follow up in writing. With respect to the contract disputes, we do not have jurisdiction over those contract disputes between insurance companies and providers. We try very hard to use our soft powers to encourage them to continue working together.
Who does have jurisdiction then? The Attorney General?
I'd have to come back to you on that, but usually these are private contractual negotiations, and so they're at their leisure to either come to an agreement or not. What I will say is there are notification requirements for consumers. There are also cooling off requirements. So a consumer has to be able to continue for 60 days to get the care from their provider, even after the contract has expired. And in the case of cancer patients or postpartum care, there are extended windows for cancer, 90 days and through postpartum care.
Thank you.
Thank you.
Thank you. Senator Rachel May.
No, I think.
Oh, no, I'm sorry.
Yeah, yeah.
That was Senator Steck.
Yeah.
Assembly. Excuse me.
You. Assembly Member Gonzalez Rojas.
Okay. All right. Thank you so much. Thank you, Commissioner, for being here. Thank you all. The U.S. Centers for Medicaid and Medicare Services has confirmed that we can use the 1332 waiver for the pass-through funding to fund health insurance coverage for individuals not authorized to be here. It would save us $500 million in Medicaid spending. We know DOH received nearly 2,000 comments from labor, individuals, advocates, etc. And the vast majority have supported the use of this waiver to cover our undocumented community. As you know, this would save us $500 million in state costs in Medicaid. And a recent analysis by CSS anticipates that even with the expansions included in the testimony for the 1332 waiver, we can still cover 150,000 immigrants and still have $790 million to spare over the 5-year waiver period. So the governor talked about doing this back in 2022. We didn't get it done. 2023, haven't gotten done. So here we are. So can you talk about why this population hasn't been included in the 1332 waiver?
Yes, we are covering people 65 and older starting January 1st this year, which is a good thing. I expect to hear from, sorry?
And pregnant people.
And people who are pregnant. And I also expect with the 1332 waiver that I expect approval this week, we'll be adding the deferred action for childhood arrival population as well this year.
Thank you for that.
You know, obviously as a state health commissioner, I want everyone to be insured. I do. You know, it just is. It's a social determinative health, so I understand the gravity of the issue. You know, just as we look at the money, I've gotten different numbers, and just so it just isn't there because of budgetary reasons, is what I'm told. I don't have a better answer than that for you.
We're going to continue to advocate for this coverage because, again, we'd be saving our Medicaid dollars. One quick other question. I'm actually really thrilled to see that my bill with Senator Baruch, 8164, to provide continual coverage for children enrolled in Medicaid and SCHIP would be included. There is a discrepancy. Our bill ensures that folks that might need to switch from SCHIP to Medicaid can do so, but we don't see any language in. Can you speak to that?
Yeah, we don't need any legislative language to be able to effectuate that change. That happens today. It's seamless. The member doesn't even see it. We do it all on the back end, and that would continue under this waiver amendment with continuous eligibility.
And actually, just the last thing on the follow-up on Assemblymember Lunder's question. I got data that $2.54 cut in wages to benefits to home care workers. That's about a 12% cut, and that puts their compensation at the lowest rate. I guess I can't answer that, but we do really want to hear the response to that.
We don't see that magnitude of cut.
Thank you.
Next is the health chair, Senator Rivera. 10 minutes.
How y'all doing? All right. I'm going to do a lot of follow-up because I've been, as you know, I kind of lean back and kind of see how things are going. First of all, following up on Senator Myrie's question about the report. Commissioner, you say you know where it is. Is it like in a like on top of your desk or in a drawer or something? Could you go get it? What's happening?
I know where it is, but it's one of those things.
So if you know where it is, why is it not here right
It's
now?
not just the Department of Health that has to completely finish a report. So
Okay. So wherever it is, could you tell your people?
I would love to give it to you. I'd love to have it for you. I like Senator Myrie. I want to have everybody have what they want. I really do. I would love to get it to you.
Gotcha. If you know where it is, please. And to the
It's
universe,
not me
wherever it is.
personally
Okay,
holding it
gotcha.
up.
But we need it.
I know.
Particularly because, as Senator Myrie was saying, this whole notion that, and we're gonna follow up with SUNY when they come over here to talk about this transformation and what have you. The fact that this report has not been, you found out that they were going to do this, like in the middle, that you found out in the media. All this stuff it's a little nuts, and the fact that this report is not with us, so we don't know as far as the inequalities that exist there and whether the changes are actually going to address these inequalities. It's kind of important. So
Understand.
please make sure you
totally agree with you.
Remember, gotcha. Number two, what are the rates that you folks that are being developed and regularly approved by the state's actuary differ so greatly from the actual costs that providers are reporting to us?
I'm sorry.
You got a face like that's not true.
No, I didn't understand the question. I'm sorry.
I will ask again. Why do the rates that are being developed and regularly approved by the state's actuary differ so greatly from the actual cost that providers are reporting to us?
Can you do that?
Has your data shown that that the costs are decreasing for providers?
Well, it depends on the service, Senator, and I think it's really two sets of information. The actuary does set the rates. They're actuarially sound. That's what we pay the health plans on a per member per month basis. The health plans pay providers based on their direct contracts with those providers, and then providers will pay their workers and any other costs they incur to run their business. But what we're providing to you, I assume, in the actuarial rates is what we pay the health plans.
Right. So, because there was a couple of years ago when we were in this room and we were talking about the fact that the budget was going in a positive direction as opposed to the decade before that. Last year, we could say it's kind of the same thing. This year, can't do that. Kind of turning back. And some of the cuts, and we're going to get to those in a second, are more than a little bit disappointing, particularly because I want to follow up on what Assemblymember Gonzalez Rojas was talking about as far as coverage for all. If y'all are coming over here and you said these are tough choices, we always have to make tough choices during budgets, but I really need to understand this. And I don't think I'm going to get an answer, spoiler, but are y'all really seriously telling us that we don't have, the money that we have to do cuts, including these unallocated cuts, which are another weird thing that we'll get to in a second, and that you're not pursuing what it could be $500 million from the federal government and almost $800 million left over for things that don't have to do with coverage for undocumented folks that you could use for other types of coverage that is allowed. Why you ain't doing that?
Yeah,
I need a good answer. Wasn't a good answer before.
Oh, I answered as best I could, my friend. I understand your frustration. I share your frustration. Quite frankly, I'm working within what we have here to offer today.
All right.
I'm happy to work through the budget process and see what we can do.
Gotcha. Amir, you got anything?
The only thing I would say, Senator, is just technically, because the amendment is not yet approved and we're waiting for the approval, we can't change that pending amendment. So it technically couldn't be applied for till a later date.
Again, sorry, not a good answer, particularly since the federal government last year told us explicitly when we asked them, they sent us a letter, I don't know if you got it, I got it, that said explicitly that we could do this. And yet y'all are not doing it. And yet you're coming here to us to tell us that we got to make these cuts, which not really cuts, we'll get to that, but they're not really cuts. And you got $500 million at least that you're just leaving in the air. It's banana to me. And so not happy about that, but okay, moving on. Where am I? So 4. All right. So follow up on Assemblymember Lunsford's point. So can you confirm here related to CDPAP, can you confirm here that the intent is to eliminate the minimum wage protections as well for these workers? And additionally, is there a concern that while we are in the middle of a healthcare workforce crisis, that reducing the wages will actually worsen the situation?
Can you repeat the first part of the question, Senator?
So there's wage parity. We're talking about wage parity for CDPAP workers. So number one, can you confirm that the intent here is to eliminate the minimum wage protections as well for these workers?
No.
Well, that's not it?
That is not the intent. It is simply...
Okay, then you need to look at the language because it's kind of what it does.
I think that was identified the other evening and it will be addressed in the technical...
Okay, so you do acknowledge that y'all need to fix that? Because that wasn't the intent.
I'm not an attorney, but yes, I would acknowledge that it needs to be.
Thank you. And also, additionally, is there a concern that we talked about healthcare workforce crisis, endlessly. Did this not make it worse because you're paying these folks less?
I think that there's certainly a workforce crisis. I think this governor has made unprecedented investments, as a legislature, in the home care workforce, specific job growth in the home care sector continue to be the fastest growing sector of the healthcare workforce.
That might not continue that much because of these unallocated cuts that we're going to. I just got to work on the time, bro. I understand, but we will continue to have these conversations also in private, but since we're having them here and I only have 4 minutes left, let's get to this next one. This one is really a head scratcher. And again, this budget is very different in so many ways. Like instead of a 2-year allocation, you do a 1-year allocation. And then these unallocated cut stuff. Bro, are you seriously saying that what you're doing is just saying to people, okay, we're going to have to cut off either your pinky or your pinky toe. So you just have to be the hand on the machete as we cut it. That's what you're saying?
Not at all.
Oh, that's not it?
No,
okay,
not at all.
Explain it to me.
No, so what we're saying is the governor is asking you to work with her to find cuts that work and that are less painful. And quite frankly, Blake Washington like I do. I trust his numbers. They're difficult numbers. If we went to a 2-year budget, the cuts would have been worse this year. He went to a 1-year budget to help us.
Which brings me back to what I said just earlier, the fact that you're leaving almost $500 million on the table is even more frustrating. So remember it is. If it's not y'all, if it's somewhere in the DOB, and one of these days, hopefully we have the DOB sitting right there. If there's somebody over there, whomever it is, bro, like you're saying these unallocated cuts, which again, I've never seen this before. You always come to us and say, we're going to cut these, or savings, that word that y'all use to cut savings is cuts. So you do the cuts or the savings, and then we fight with you to figure out which, in this case, you're saying like, well, you're gonna have to help us see where we're gonna chop. Somebody said to me, it's like being the caterer at your own funeral. That's basically what this is saying.
It's also like partnership too. That's another way of looking at it.
But there's $400 million that you're doing here, right? 200 Medicaid, 200. And again, because all money's fungible, right? You could get this 450 million that would actually help you address that, which might make some money available elsewhere. It might be so. Just a little nutty. 2 more minutes. All right. Don't worry. You won't have to deal with me that much longer. Okay. Okay. Are you planning on implementing the ADL requirements that have been suspended?
I lost the audio on that. Planning
Sorry.
what requirements?
You got it? The ADL.
I got this one. Yeah, yes, we are. It is state law, and we will be implementing that change. It's assumed in the financial plan and in our forecast.
Do you have what are the updated fiscal projections?
We don't have an updated fiscal projection at this time. It needs to be based on the actual assessments that members complete, and that was currently finished in November, December. So we're looking at it, but no updated fiscal at this time. We don't anticipate it being different.
All right. So just again, 1.5 minutes, and I'm going to be done before that. But you obviously can tell I'm a little frustrated. We were doing so well. In all honesty, we were going in a positive direction. This seems like it's a turn back, even though you're all trying to put a good face on it. And particularly, there's some concerns here because there's money on the table that we could go get. And this is without counting on the raising the taxes on the wealthy, which I'm going to be bothering some other people about, not y'all. But just within the confines of what you decide and what you impact directly, coverage for undocumented folks, which, by the way, according to your own numbers, if I'm not mistaken, last year was what, $860 million of emergency Medicaid? Is that correct?
Yeah.
So it's $860 million that we're already spending because we got people who are uncovered who are going to emergency. So,
yeah,
you have some clarification for me?
Just that is the state and the federal share of emergency.
So it's only $400 and some odd million. Okay, thank you.
Yeah.
400 some odd million dollars that is both for the state and for the localities. And we could actually be addressing that. And again, because money's fungible, a lot of this stuff could actually help us to deal with some of the cuts that you're proposing here. We're going to have a lot of conversations over the next couple of weeks and months. We're starting early, kind of disappointing. There's a lot of stuff that I'm seeing here, and I'm certainly going to follow up. But I've got another 5 seconds, so I should just linger and just say, so how you think about the Knicks? Oh, here we go.
Well done, Senator Rivera. Assembly member.
Thank you. Assemblymember Gray.
There we go. Thank you very much, Madam Chairwoman, and thank you, ladies and gentlemen, for being with us today. So it's clear that we've heard and it's no surprise, the healthcare industry is in a dire position. Doesn't matter if it's nursing homes, hospitals, EMS service. 75% of our hospitals are operating with negative margins. 40% are relying on VAP or VAPAP for supplemental funding. Is it prudent to be cutting VAPAP at this time?
Is it prudent to be cutting VAPAP at this time? I think we have to, the level of subsidies that the state has incurred for financially distressed hospitals is growing at an exponential rate. We are currently at around $3 or so billion. We did get federal funding through the 1115 waiver, which was a very challenging thing to do because we are at every payment limit that the federal government has put in place for hospitals. So I think we have to live within the resources we have, and we continue to make sure hospitals are getting what they need to provide essential services for the community.
So the VAPAP is a 1-to-1, right? Is it a 1-to-1 match? Are we leaving money on the table?
VAPAP is zero federal match.
Zero federal match. Okay.
VAP has a federal match, but is subject to federal payment limits, one specifically known as the upper payment limit, which we are currently at.
Okay. Medicaid rates. I mean, there's nothing proposed, and there's no increases proposed. And last year, the facilities are staffing shortages. We have cost increases that they're facing, and reimbursements not keeping pace with that. Where are we going to go with them?
Yeah, I mean, we did make a historic increase last year, as you noted here. I think one of the ways to look at this, though, for nursing homes and hospitals is, you can increase rates, but the other thing you do is find ways to reduce costs. If you look at our scope of practice proposals, we all should want hospitals and nursing homes to have less costs. I mean, if you can let a certified medication aid work in a nursing home, that's going to help everybody. Medical assistant give a vaccine, that helps everybody. Look at the license compacts, they're really going to help everybody. Hospitals are still paying a lot of money for agency nurses. That's something that we need to own. That is not in our best interest for anybody. Finding methods to reduce hospital costs are very important to all of us. And I'm willing to work with hospitals on any idea they have to reduce costs. And I think there's methods out there where we can do that. And I think there's things out there that we can work on together.
And so what are we doing to address agency or contract nursing or travel nurses in that regard? Because that's what they're relying on right now, and it's exorbitant cost to them.
Yeah, we did get the authority last year to register them. We have registered them. Our report's coming out soon. It'll be out before you know it. But it's also one of those things where this is still a very big expense for hospitals. H&H in particular is paying a lot for this.
Thank you.
Thank you. Next is Senator Rachel May.
Thank you, Madam Chair, and thank you all for being here to testify. Commissioner, I want to start by thanking you for your attention to the Native health clinics, which were neglected for so long, and I have many constituents who are grateful for your attention and the increased support in the budget. I also have a lot of constituents who are worried about Upstate University Hospital and its future. And given that it's losing its support for the debt service, I hope you're aware of that we are also, the Medicaid gap is only going to grow, and they receive zero operating support from the state while serving dozens of counties with essential care. I wonder what your vision is for the future of that hospital.
Yeah, Upstate Medical Center is very important. They provide care to a lot of people, not just tertiary care, but quaternary care. They're very important to that part of New York. I met with Dr. Dewan. I went out there and visited them. I have concerns about their physical plant, as he does as well. And I think they're looking for resources to estimate where they need to go for the future. And I think that's very important. I think they're going to be in the future of New York, and I'd like to see them something that we try to help and move forward with. But they do have needs. I'm addressing them as best I can here. I don't mean to not give you specifics. I understand their concerns, and I agree with Dr. Dewan. I'm concerned as well.
All right, thank you. On lead pipes, I was gone for half an hour, so I don't know if you've talked about this yet, but we asked for $50 million last year. The DOH, I think, has spent $30 million, which is estimated to be about 1% of the need statewide for getting rid of the lead pipes and lead service lines. What is your plan?
I think we have $115 million this year. The governor just announced yesterday projects across the state, by the way, as well. And we're replacing lead service lines. In fact, one of the big projects yesterday was in Rochester in particular. So I think we have a nice system going to releasing the money. There's more federal money coming for the next several years. We're not going to replace all the lead service lines, but I like the investment I saw yesterday, and I think you'll see more coming as the years go on.
Okay. Thank you. And then on nursing homes, just on the Medicaid gap there, how many beds do you anticipate will close because of the gap that we have? And should we have our constituents call you? Because they're calling us on a daily basis looking for some help with long-term care.
Well, constituents contact the department all the time, and their messages are welcome. We're happy to hear that. And I think with nursing homes in particular, we have to look at how we can help with scope of practice and licensure contract compacts to help them. I think that's something we can all agree we need to help reduce costs on in particular.
Okay. Thank you.
Thank you. So because we've had you here 2.5 hours and we have more, we're going to allow everyone to take a 15-minute break till 10 after 1 to do with whatever you, 1 after 12. Oh my goodness. Sorry, everyone. 10 after 12 to do whatever people might need to do during those minutes. Thank you.
Okay, Anna Kellis. Jonathan Jacobson. Boy, that bathroom break took care of a lot more than just Joanne Simon. There we go.
I still get 3 minutes.
Okay. Yeah.
And there's no rush.
Okay.
There we go. Thank you. This is what happens if you come back on time,
right? So thank you for your testimony. And I only have 3 minutes, so I have a couple of quick questions I'd like to outline, and then and that is, one of the responses about cuts to nursing homes about unallocated state subsidies, and my question is, why are they unallocated? The other point I wanted somebody could really clarify for me how it is that you can have this wage parity with the CDPAP program, and how it will not harm both the workers, discourage people from joining the workforce, and lead to a lack of care. And then the other question I have is the school-based health clinics. The governor has proposed school-based mental health centers in any school. Having lost 5 school-based health clinics, which happen to be administered by Downstate, I have a real question about how we are going to have the money and the wherewithal to actually do these school-based mental health centers. And I also don't want to lose school-based health clinics, not to mention I don't want to lose Downstate. So thank you.
Thank you, Assembly Member. I'll start with the first question on the nursing homes. Why is it unallocated? I think that's a question that we should hear from the nursing home industry. There is an application process to receive VAPAP or state-only funding. They have to submit. They have to meet, financial distress criteria, days cash on hand.
Could you be a little closer to the microphone?
Sure.
I'm having trouble.
So I can't necessarily answer definitively as to why they are not applying or whether they're not applying and not meeting the criteria, but I'm sure we'll hear from them later on. We have awarded 10 nursing homes through that funding, and that's been consistent for 2 years. So given the budget challenges, it seemed like a more prudent use, reserving unallocated funds than trying to reduce services. Your next question was related to the wage parity reduction.
Yeah, how does that work? I don't understand your answers from before.
Wage parity was put in place in 2017 and really intended to level the playing field between the CDPAS personal aides and the LICSA personal aides. And since that time, we've learned a lot about the program. It's become clear that our CDPAS aides are eligible for health insurance benefits, or some of them are, especially with the expansion in the Essential Plan and the Qualified Health Plan. But we do know that many of the workers are receiving that benefit through base wages and not benefits. And we've made a tremendous number of investments in base wages, including indexing the minimum wage to inflation permanently.
School-based mental health centers.
Thank you. Next is Ranker for Finance, Senator Tom O'Mara. 5 minutes.
Thank you, Senator. Good afternoon. Thank you for your responses today so far. With regards to the migrant crisis in New York City that we read about every day, and all these cuts to Medicaid we're talking about, can you explain to us what the impact of the migrant situation is on the Medicaid program in New York? How many of those are eligible or ineligible?
So some members who are migrants are eligible for the Essential Plan, and we do have assisters who actively help them get the Essential Plan. So we do try to enroll as many people as possible. In addition, just to highlight another issue, there is about $25 million in this budget to help with making sure people are screened for tuberculosis and get vaccines before they get insurance. That's additional money that's put forward to help to address those issues when people arrive. As far as Medicaid goes, my understanding from Medicaid is they're eligible for emergency Medicaid if they need it. You can supplement it if you need to.
Yeah, it will really depend on the individual's status, documentation status upon entry into the country. If they are undocumented, they are eligible for emergency Medicaid, which is a life-threatening or critical condition, inpatient services. And then, as Dr. McDonald said, if they do have, if they are asylees or asylee seekers and are working and have work authorization, they would be enrolled in the Essential Plan. So no Medicaid costs.
So, but you don't have numbers of how many migrants are enrolled in the Essential Plan, as opposed to getting emergency Medicaid?
I don't have them in front of me, and it's a little harder to answer that than it may seem, but it's certainly something we can get back to you on in writing.
Yeah, well, with all the discussion about the financial impacts of this migrant crisis, particularly in New York City, we should have a handle on that and know what the impact, what the cost is, and really, what we should be asking federal government and President Biden to supply to New York State to cover these expenses.
And I think some of those expenses are well beyond Medicaid and costs that New York City has had to incur for other social supports and housing services.
Moving on a little bit to hospitals and Medicaid, it's been consistently reported that Medicaid is underpaying hospitals by about 30% for the cost of supplying those medical services. Do you agree with that number? And what is the state looking at doing with regards to making hospitals whole for providing those services?
I haven't looked at the numbers closely enough. I know they reference a 70%. I think that's as a percentage of their cost. We do have sort of rules, and the federal government has rules that dictates what Medicaid can reimburse hospitals for services. We are at those limits, meaning we cannot pay them anymore while continuing to receive federal financial participation on those payments, which is why you've seen such a large increase in our state-only Medicaid payments, because we can't get federal match anymore. So I think there's certainly some alignment on the numbers, but we've done a number of things and invested in those reimbursement rates through state-directed payments and other payment vehicles. Unfortunately, we are just running out of options to get federal match, which is important.
Are there discussions going on with the feds to deal with that
Absolutely.
inequity?
There absolutely are. It's something we spent a considerable amount of time negotiating with them as part of our 1115 waiver. So they are agreeing to provide federal match, even though we are above those limits for those hospitals, which is not the ideal scenario, but it is an acknowledgement, I think, on their part that more needs to be done to support those institutions.
Getting back to the migrants for the last few seconds I have, what is the impact on hospitals or other healthcare providers of providing services to uninsured or ineligible migrants or illegal immigrants?
I think there are, to the extent they are uninsured, they would be getting Medicaid. Undocumented, they would be getting Medicaid reimbursement. But many are eligible for the Essential Plan and are receiving reimbursement from the Essential Plan, which is higher, significantly higher than the Medicaid rate.
Thank you.
Thank you. Alex Boris. Oh, sorry. You were next.
Thank you, Madam Chair. Thank you all for being here. Commissioner McDonald, I'm actually going to ask you the same two questions I asked you last year with some updates. The first is you've talked about licensure compacts. There's also interstate data sharing compacts that the federal government's prioritizing to prevent growth in diseases. I know we participated in many of them. Last year I asked about norovirus and Norostat. Since that time, Colorado's added in. Any updates on that or other initiatives to share data across state lines?
As far as I know, we are sharing data on that, but I'll get back to you to be 100% sure because we like sharing data. It's obviously in everyone's best interest to work together with that.
Cool. The CDC doesn't list New York. I hope they're wrong, but
I'll double check on it. I thought we did, but let me double check.
Cool. And if you could just follow up in writing with sort of where we are sharing data, that'd be really helpful.
Sure.
And then the second is last year's budget put a strong priority on fighting future pandemics and investing in strengthening vaccines. There's some of that in here, right? The testing of HIV and hepatitis, et cetera, but certainly not as much. You spoke really passionately last year about how you wanted to spread more in fighting future pandemics and vaccines. I'd love if you could just update on kind of where that's reflected, or are those initiatives really cut?
Yeah, I mean, the federal government's taken a lot of lead in this. I mean, one of the things I hear from the federal partners is for a new virus, they expect to have a test within, their words, not mine, 10 days. and they expect to have vaccines available within like 90 days, which to me is their words, not mine, which is quite remarkable. And I think one of the things you notice is we're much better supplied with personal protective equipment. And, if you remember at the beginning of the pandemic, that was just one of those things where we just weren't ready. No state was, because no one saw how much of a need that was going to be. Obviously the public health department is much better prepared because we lived through it, but we're also much better staffed. Thank you very much. We are in a much better place than we were last year. Last year, we had barely broken even in 22. This year, I have hundreds of more team members on my team that I'm very excited about. And we're actually now at pre-pandemic levels, and we have more positions than we're hiring, and we really like the momentum we have at the department.
Wonderful. And could you just comment specifically on the Division of Vaccine Excellence?
Yes. Yeah, I'm thrilled with that here. So we have a new leader in that area, which is good. We're hiring more staff for that. Really looking at how we address things like vaccine confidence. How do we get it just, quite frankly, more available? And, I think one of the things you saw this year was, hey, the COVID vaccine transition to the commercial market, it was helpful for us to have team members who could explain to people how that was going to happen, to make that as, smooth as it could be. It was bumpier in other states than it was here. We were pretty good at getting information out, and Medicaid, thank you very much, did a great job as getting it covered. We had our team members, our Medicaid members covered quicker than commercial players, which I really appreciate my team doing that.
Thank you.
Senate.
Okay, there's that. Thank you, Chair. So my question is actually, questions are directed to the Commissioner. So with regards to reproductive health, I appreciate the increase in funding for reproductive health center security grants. And so what I didn't see in the increase was direct support for providers. And I know this was an issue that we brought up last year. And so, and the executive proposal did not include that, to increase Medicaid reimbursement to cover the actual cost of medication abortion. So my question is, how does the department expect that those services can continue when providers are not being reimbursed for their true costs? So that's one question. And then my other pertains to the HNAP Nourish New York program. I want to lend my voice to this. These are two important programs to address food insecurity. However, what was troubling is that Nourish New York is not a true replacement. And so with the proposal on the table, how does this proposal address these issues? So I'll start there.
Thank you for the question, Senator. I'll answer the first one with respect to the abortion services. Though we did make an investment last year, it was a 2-year investment to increase the reimbursement. It is very complicated given the federal rules on financial federal match and just generally targeting the funding in such a way that we get it to the right providers. We did get some feedback from a few outside groups and are thinking about alternatives to expand on what we did last year, but it has been a major undertaking to implement last year's investment, and we would hope we can build on that in further discussions.
And then, can I repeat the question on Nourish New York and Hunger Prevention Nutrition Assistance Program we had, please?
So last year, those programs were essentially kind of combined, and that was a problem for a lot of us who serve rural areas, especially dealing with food insecurity. So my question is, how does a new proposal, if there is one, address these issues with those two programs?
Yeah, it went through a competitive procurement. I know everybody wasn't pleased with the results of that, but it's a competitive procurement. We did 390 million emergency meals last year. As far as I know, the program did work. We fed a lot of people, and our plan this year is to continue with the same. I don't know of any new investment. Obviously, I'm concerned about food insecurity too, though. It's a big issue, but we're trying to support as many people as we can with this.
Okay. And then my follow-up deals with maternal health. What actions is the Department of Health going to take to address unnecessary C-sections? I know the governor included this in her budget. We also advanced legislation yesterday. Any responses to that? And we can also talk offline as well.
There is a significant investment incentivizing hospitals to reduce their C-section rate by 1%. We give them money.
As much as I want to hear a more expanded answer, we have to move on. Assemblymember Walsh.
Thank you, Chairwoman, and good afternoon. As New York State continues to express its desire to increase health equity for all residents, there continues to be one population that does not get the opportunity to participate. There's only one clinic in the capital region, Center Healthcare, a division of the Center for Disability Services in Albany, that is fully accessible and has true integrated care under one roof, including primary care, dental care, and that's especially important now that 600 individuals are on a wait list for service after St. Peter's closed their dental clinic. Neurology, psychiatry, physical, occupational, and speech therapy, social work counseling, and physical medicine. Many of these services are not available in community practices due to the complex nature of the patients. Time required to treat, including in some instances a Hoyer lift to safely transfer in and out of a wheelchair, and assistance to undress and dress, and the increased staff that's necessary due to behaviors such as a minimum of one dental assistant and up to 3 assistants in addition to the dentist or hygienist for any dental work being performed. Emergency rooms and urgent care centers have turned into basic health care for individuals with IDD because of the lack of access to services and the transportation to get to and from an appointment for someone in a wheelchair in the community. The center's health and dental clinic has not had a rate increase in 17 years, while the hospital-based clinics have had routine cost of living adjustments approved by the legislature, including last year at 7%, only to have a local hospital close their dental clinic this past summer, as I mentioned. Emergency rooms are not the answer for individuals with IDD or autism. They are crowded, they're loud, and they're short-staffed. The individuals served at the center are often nonverbal, which creates additional challenges in an emergency room or urgent care center, often resulting in unnecessary testing and costs. I know you visited, Commissioner, the center recently, as I did. The question, how will New York support health equity and health services for individuals with IDD in clinics like the Center Healthcare, which is not eligible for federally qualified health center funding? These clinics are crucial to the future of healthcare for individuals with disabilities, and they cannot be expected to continue to serve this population on a rate that's been frozen for 17 years. How will New York, with current state budget funds and the new 1115 waiver, make a commitment to properly support individuals with disabilities in a proper setting like the Center Healthcare for basic healthcare and dental service? What we have today is not health equity, and it's discrimination, and I think New York has got to do better. And in the little remaining time, I would appreciate your thoughts on that.
You made a lot of great points. I think you made a lot of really good points. There actually is a pretty substantial increase in this budget. It was a pretty important investment, I think. And I think you're absolutely right to call out. People with disabilities are a vulnerable population, and health equity matters a lot. I couldn't agree with you more. There's a health disparity. The increased investment should help to address that.
Senate.
Thank you, Mike. Thank you very much. Next is Senator Gounardes.
There we go. Thank you, Senator Krueger. Good, afternoon, commissioners, everyone. I want to pick up on a theme that was started a little bit earlier by my colleague, Senator Hinchy, and that's to talk about some of our financially distressed hospitals, the safety net hospitals in particular. I'm here, and this is my 6th budget cycle. I feel like every year we talk about a safety net stabilization fund, a safety net fix, a temporary fix. It's $500 million here, it's $600 million there. We're going to divert New York City sales tax to shore up our hospitals. Every year it's a Band-Aid, and every year it's crisis to crisis to crisis. What, if anything, is being advanced in this budget to shift us away from that perpetual crisis mode towards a more sustainable funding for our safety net and financially distressed institutions?
Right. You're exactly right. Every year it's the same thing, right? And we cannot buy ourselves out of this issue. I couldn't agree with you more. And I think this is really, really why it's important to look at how do we help hospitals reduce costs? How do we help nursing homes reduce costs? Some of that is in the scope of practice changes we talked about. Yes, there is money in the 1115 waiver. Yes, we have money for them as well. But I think we need to look at ways we can help hospitals reduce costs. Agency nurses are still a substantial cost for hospitals. But I think you need to go back to, are there other things we're asking hospitals to do that are a cost to them that we can relieve from them? I'm happy to work with hospitals to put data together to help improve their throughput and make sure this is something that is sustainable. But we really need a sustainable path for hospital finances, and it's not, the answer isn't just adding more money every year. And Dr. Amir, do you want to add to that?
I just wanted to add that the 1115 waiver that Dr. McDonald mentioned is certainly a long-term investment. It is not a Band-Aid. And while there are only a subset of safety net hospitals that would be eligible for enhanced funding, It is tied to a broader federal model that includes all payers, not just Medicaid, and has a tremendous number of flexibilities that would be attractive to a hospital and helpful in addressing this long-standing issue.
I hope that I'm not here next year asking this similar version of the same question. I suspect that until we actually change the structure of how we finance healthcare, we're never going to get to a truly more sustainable system. You mentioned hospital spending and hospital costs. Over the last decade plus, hospital costs have increased by about 90%, far outpacing other sectors of the healthcare industry. What are we doing to kind of drive down some of those costs? At the same time those costs are rising, some of the big corporate hospital chains are posting profits of billion plus. So something the math is not adding up. And what are we doing to right-size the equations there?
The largest driver of hospital costs is labor costs, and that's still agency labor, and that's still a pretty big impact. And I think, we just need to find ways for hospitals to be able to reduce their costs. This is where a lot of the license compact stuff we're talking about is important to think about. The scope of practice changes we're talking about too. There's long-term solutions there. I hope people just entertain them and look at them closely, but I think we need help with labor.
Thank you.
Thank you. Assemblymember McDonough. Oh, McClellan. Sorry.
That's okay. Just a few questions. With the rise of fentanyl deaths, Narcan is needed more and more. It is my understanding that the Department of Health purchases Narcan from only one source when genetic supplies exist. Why?
Thank you. Yes, the purchase of naloxone or Narcan has been with a single source. We've maintained a contract with that particular contractor. We have, as a result, have been able to distribute thousands of kits across New York State in order to advance and save lives.
Is there any plan to extend it and put it out to bid so that there's more than one contractor we're purchasing it from?
Yes, as we continue to move forward and as we continue to advance in the availability of different types of models related to naloxone, certainly we will look at that.
And following up on something my colleague said, in my district, I have a public benefits corporation called NUMC that will be running out of money shortly. It's my understanding that funding, especially from the state, has been limited over the years. What are we going to be doing to help?
I lost some of your audio. You said do you have a healthcare facility that's running out of money? Is that what your question is?
Yes.
Yeah, so there's a process for them to apply to the department to see what funding we can offer to people and see what's available. Is it a hospital?
They did, yes. It is a hospital.
And then it just has to walk through the process. I can't specifically address any particular facility now, but I can have my staff look into it. And since they're listening, I'm sure they already are right now.
Okay, so we can maybe set up a meeting and they can reach on out to me.
I'm sure my staff just heard what you asked. And I'm sure they're looking into it, and they'll get back to you about what we're doing with them. Does that sound fair?
Thank you.
You're welcome.
Thank you so much, Chairwoman. And I actually share that hospital in my district with my assembly colleagues, Assemblyman Micklin. So I would be very interested in that answer, Commissioner. So thank you very much. Just you mentioned that hospitals are having difficulty making ends meet. And one of the things that I wanted to address was medical debt. In the governor's proposal, she wants to increase the hospital financial assistance program to cover now 400% of the federal poverty level. In addition, she wants to increase or decrease rather the gross monthly income threshold from 10% to 5%, reduce the interest rate to 2% on medical debt. What's the estimated financial impact to hospitals due to the governor's proposed changes to hospital financing?
I don't know the exact number, but I think it's rather minimal. When you look at who we're actually getting medical debt from, it's some of the poorest New Yorkers. And this is one of those things where suing people for medical debt hasn't generally been that effective. I think they're recovering generally 14 cents on the dollar anyways here. And really a lot of what this is about is try not to create a financial barrier we don't need to. Not necessarily demanding a credit card pre-authorized before you get health care, but not suing people. And there's some nice changes here, so SUNY doesn't have to be suing people. I don't know that they want to be as well, but it was interesting how SUNY is one of the largest litigators of medical debt. I'll see if I can get you the exact number from my staff on how much money this is going to actually impact hospitals. My understanding, it wasn't that much.
And was there any consideration given specifically to safety net hospitals with respect to that, since they treat primarily an indigent population?
Yeah, I don't know that safety net hospitals are the ones who are actually really influenced by medical debt. I think that's one of those things where, a lot of their patients have Medicaid and have other insurance issues as well. I mean, I can share your concern about our hospitals. I want to help them to stay whole, but I don't think this is one of those things where it's going to be as big a cost driver.
Well, just would a proposal such as this necessarily result in higher medical costs for individuals who do have the capacity to pay, because hospitals are trying to make up a shortfall for what they can't collect from other patients?
Yeah, so when you're collecting money from people who are either uninsured or underinsured, they have to negotiate rates here. Sometimes people who are underinsured or uninsured, by the way, are paying a lot more money than someone who's insured because they don't have the power of an insurance company to negotiate for them. And sometimes the difference is stunning. Sometimes the cost that, the insurance company pays. You see this on your explanation of benefits is 10 or 15 cents on the dollar, and the hospital is happy to get that from the insurance company. Oh, it's not true for every expense a hospital gets. But I think this gets back to just sort of parity, and it's really an equity issue. We're taking, this is really a proposal to just stop taking advantage of some of the poor New Yorkers, quite frankly, because that's the population that's affected by this. And medical bankruptcy isn't pleasant for anyone.
I'd appreciate seeing those statistics. Thank you, Commissioner.
Assembly?
Yes, Assemblymember Latrice Walker.
Awesome. I guess your muscles are stronger. Good afternoon. So we have heard a number of times about SUNY Downstate potentially either being downsized and or closing. In light of the fact that SUNY Downstate and many other hospitals, such as those under the One Brooklyn Health program, it would be interesting to hear what the federal Medicaid waiver dollars, or how many of them are going to be utilized in order to support public benefit corporations and hospitals who are safety net hospitals, such as those under One Brooklyn Health and Downstate.
Thank you for the question, Assemblymember. There is significant funding in the waiver, $550 million annually for financially distressed hospitals, but private financially distressed hospitals. It does not include public hospitals, and this was something we advocated for, but the federal government held firm in that public hospitals have access to other means of Medicaid financing through intergovernmental transfers and changes to the disproportionate share hospital payments, whereas private voluntary hospitals do not. So that is the reason why it is limited to only private hospitals to 500.
Correct, but isn't hospitals such as Brookdale Hospital, Interfaith Kingsbrook, aren't those considered private hospitals but just provide public benefits simply because most of the constituents or utilizers of those hospitals are people who are on Medicaid, who we know many of those hospitals are in distress because there is a network adequacy issue where doctors are being underpaid through their reimbursement rates. And so why don't they have access to the dollars?
I may have misunderstood your question, but I can tell you One Brooklyn Health is absolutely eligible for the 1115 waiver, as are other safety net hospitals in Brooklyn, the Bronx, and Queens.
Well, so there's a serious issue with respect to lower reimbursement rates that providers receive without recourse. And so I'd be interested in hearing at what point would DFS and DOH consider a lack of network adequacy a public health crisis and intervene by regulating the reimbursement rates between payer and providers?
Yeah.
Yeah, my muscles are working too. Thank you for the question. In terms of reimbursement rates on the mental health side, of course, the governor has proposed that for several clinics that commercial providers start to reimburse at the Medicaid rate. or the Medicare rate. With respect to network adequacy, generally, DFS has just proposed a regulation for mental health providers, in particular, requiring that the first appointment be given within 10 days. If there isn't I'm happy to provide more in writing, ma'am.
Awesome, thank you.
Busy adjusting mics. Sorry, this is the first time. We are at Senator Hoylman Siegel.
Thank you, Madam Chair. Good to see you all. I wanted to bring up the issue of Paxlovid, which I know you're familiar with, Commissioner. In November of last year, Pfizer and the federal government announced that Paxlovid, which has been shown to reduce serious illness of COVID-19 by 89%, was transitioning to the commercial market. And since then, the market price of these treatments has exceeded $1,500. And even some people with insurance are seeing co-pays or carve-outs that are footing them with steep bills for these life-saving medications. I wanted to let you know that I've introduced a bill today to require all insurance providers in New York State, including Medicaid, to provide coverage for COVID-19 therapeutics that are approved by the FDA. Do you agree that New Yorkers should be foregoing life-saving treatments like this because of cost?
No, I mean, I don't agree with that. How about being just straightforward like that? Of course not. I want every New Yorker to have access to the medicine need to get better. I'll tell you, when I had COVID last July, within 22 hours taking Paxlovid, I could tell I was heading in the right direction. And I was miserable with my COVID. I don't ever remember being that sick. And I was as updated with the vaccine as you could be. So I was so thankful to have it. But it's weird to me how expensive it is. Really weird.
Is there anything in this budget that would address those kind of costs?
It's covered by Medicaid. So Medicaid does cover Paxlovid, as we cover every other FDA-approved medicine. So that's how we address that.
Thank you. And then I wanted to also ask about gun safety. We passed legislation last year that would allow for Medicaid reimbursement for hospital-based gun violence prevention programs, an approach that studies show that reduces gun death in communities. Wanted to know if either the superintendent or the commissioner knew whether you've applied for approval of an amendment to the state Medicaid plan as required by the legislation. That application was due, I believe, in mid-November.
Yes, we did file that, Senator, and it is under review with the federal government. In the interim, we are processing enrollments for community health workers who are employed by either community-based organizations, hospitals, or partners of hospitals to do that hospital-based intervention prevention programming. It's primarily through outreach and working with community members from peer support navigators. So.
And there's one more part of that. You're supposed to approve an accrediting body to review and approve training and certification programs for these violence prevention professionals. That approval was due, I think, just a couple of days ago.
If we don't have that, I will follow up with you on that in writing.
Thank you very much.
Thank you, Assembly.
Thank you. Khalil Anderson is here. Okay. Jen, here? No. Jennifer Lachman, is she here? Yep.
Yes.
Okay, good.
Thank you. Thank you, Commissioner McDonald. And as a pediatrician, I'm sure you will like this topic, which I think you alluded to in your opening. In July 2023, I introduced the Keep Kids Covered Act, which will allow 600,000 children enrolled in Medicaid to stay on it continuously until age 6, regardless of change in eligibility and without redetermination. Children on Medicaid are more likely, as you know, to have a regular provider, to get routine medical care, and even complete high school and college. And Senator Hoylman Siegel, I'm proud to say, is sponsoring it in the Senate. So if we pass our bill, will we have your support to apply for the necessary federal Section 1115 waiver?
I think we're doing that anyways, aren't we?
We are, and actually, that is public at this point. We put it in the federal public notice, and there's legislation in the budget, and we're proposing to finance that is connected to our recently approved 1115 waivers. So we're very excited about that.
Fantastic. Well,
Yep.
if you do it faster than us, even better. So my next question is about cannabis shops. I have introduced the Smoke Out Act, and my legislation will empower local law enforcement to shutter illegal smoke shops that are selling unregulated cannabis. A random sampling of their cannabis products actually found that 40% contain dangerous contaminants such as E. coli, salmonella, lead, and pesticides. None met the safety standards of New York State's legal cannabis market. So my question for you is, would you say that these illegal smoke shops are a threat to public health that needs to be addressed?
Thank you for that question. First, let me just acknowledge that certainly cannabis management within New York State is overseen by the Office of Cannabis Management. That said, the Department of Health does work in partnership and is responsible for the public health impact. We are working collaboratively with the Office of Cannabis Management as well as other partners in looking at what we can do to ensure the safety and wellness of New Yorkers who may in fact be impacted by these illegal smoke shops, as you referenced.
So you would agree that the illegal smoke shops are a danger to public health?
Yes, we would certainly agree, which is the whole intention behind looking at adult use cannabis and creating spaces in which there can be regulated as well as safe access.
Great. Well, thank you for your work and partnership on it. I hope that we can close all 36,000 illegal smoke shops across the state because they're such a threat to health. Thank you.
Thank you, Senator Comrie.
He's gonna.
Oh, no, he was right there. Far end. Oh, Elizabeth.
Oh, here we go. Here we
There it
go.
is.
Oh, there he
At
is.
the end.
Good morning. Somebody said, "Wow." Good morning, commissioners. I wanted to ask a couple of questions. I'll try to go through them quickly. Last year, myself and Assemblyman Aubrey put out a bill to deal with the underbedding in Southeast Queens, which has been long documented and long discussed. I'm over here. It's just that's, and DOH didn't support the need for making sure that we could have more hospitalization and hospitals built in Queens. Throughout Queens, Queens has been determined to be underbedded from a study released 25 years ago that was done by the state, and we still haven't had any resolution to that. Can you explain why DOH did not support the bills, S 5172, Assembly 5970?
Let me just offer to get back to you with that.
That's at some point we have to have some understanding of it. How do you understand hospitalization usage, and what protocols do you do to determine it?
Based on population, resources, time to get to a hospital, time to get to an emergency department, type of service offered, diversity of service offered, how many people actually can get throughput, what their bed status is, how many people are in the beds, how long it takes for people to get out. These are just some of the variables that come to mind.
Thank you. And then also, I would hope that we could find some way to come up with an assessment without trying to do $1 million study to understand hospitalization, since you have all those statistics at hand already, and to make sure that we can have some new hospitals built in Queens. Just another issue. CDAP, CDPAP, and the fiscal intermediaries, and the issue of the contract. Can you give us an update on where we are with that new contract?
I thank you for the question, Senator. I assume you're referring to the request for offering, and unfortunately, there's active litigation, and unable to provide an update at this time.
We went from worse to worse. So, dealing with I'll just follow up on, instead of Paxlovid, the lack of ability for pharmacies and folk to be able to get Ozempic and for people that actually need it because of the burdening folks that are taking it that don't need it. Is there a state response to working on folks that are suffering from diabetes that can't get those medications?
Thank you.
Thank you. You'll have to get back to Senator Comrie afterwards. I think, again, on that probably very long list now of things you need to get back to us on, add that to the list. Thank you.
Assemblymember Reyes.
It's got to press really hard. Okay. I will preface, this is for DOH, I will preface my question by saying, one, that New York has 1.4 million children Medicaid eligible, and that 25 states have already submitted their state plan amendment to CMS. So you were asked earlier by Senator Brooke about the state plan amendment being submitted to CMS, and are concerned that your SPA is too narrow in scope and doesn't include services such as dental, optical, and other forms of care. I'm also concerned that there are few mental health professionals in schools that are actually licensed to bill Medicaid, and clinicians like school psychologists who have been in schools providing services for years are not included in this current SPA. Why not submit a more broad state plan amendment to CMS, and how will you address the need to add school-based mental health professionals to those able to bill Medicaid so that the expansion will actually help meet the growing mental health crisis and children's mental health needs?
Thank you for the question, Assemblymember Reyes. And I know you're a huge champion on this initiative, and it's been great working with you on this thus far. What I would say is it's been a long haul to get where we are with the state plan that is before the Center for Medicare and Medicaid Services. Since that submission, there was recent guidance put out that allows for the broader services that you're alluding to that you're interested in us seeking. And I think based on our work with the schools themselves and the districts, I think we are cognizant of the undertaking that the current state plan allows for with the data sharing and the infrastructure to actually bill. So it's not that we don't want to go for more additional services, including those mental health services. We're just trying to take the right approach, given that we're not going to get from 0 to 60 overnight, and it is a large undertaking to implement what we've worked on together.
Yeah, I would just add that the guidance from CMS was changed like 2014. This isn't like new guidelines, right? And there have been states that have had significant time to do this. I've been talking about this for like 3 years now. But you did say that there were some school districts that weren't on board.
I wouldn't say that they are not on board. I think there's a large infrastructure that is needed to be able to bill Medicaid for the services they're incurring for those students, and the data exchange to make sure that they are Medicaid eligible students.
Absolutely. And I would add that once we're able to do that, we will also be able to access matching dollars from Medicaid. And I think that would offset some of that cost and that build out. My last question, and I don't have a lot of time. How does the OH plan to achieve the additional unidentified $400 million in Medicaid savings in the budget, the $200 million in general and $200 million in long-term care?
If you're asking what the specific proposals are to achieve that savings, we don't have them predetermined at this time. It's something I think we envision working with the legislative staff and legislators with as we go through the budget process.
I guess to be continued. Thank you.
Yes.
Trying to get that work. So I believe I'm the last senator, just for keeping track. And I have 10 minutes as the chair. Thank you. All right, I have a variety of questions. Let's start with something that's already come up a number of times, but for different hospitals. So we've already heard about the concerns about SUNY. Senator Comrie just asked questions about how do you evaluate. I know in my district, or it's not exactly my district, but it's 4 senators' districts in Manhattan. We're very concerned about Mount Sinai's closing of Beth Israel without seeming to go through appropriate procedure. We've met with you, Commissioner, and you actually put a cease and desist for them. But apparently they're ignoring it and just doing what they're doing anyway. So I'm very concerned about that they view a couple of $1,000s a day penalty isn't worth their listening. So when you were just asked, how do you assess whether there's need for a hospital not to close or even a hospital to be open, You sort of ran through a list. Is that in writing somewhere? Is that a regulation that we can look to understand? Because, for example, SUNY Downstate is Brooklyn. Beth Israel Mount Sinai is probably the last large hospital in the southern part of Manhattan. We know that they take a huge number of their patients from Brooklyn, but now we're going to have another Brooklyn hospital closing. So is there something we can all look at and so that we know how we evaluate there or how you're evaluating?
The department has broad authority to assess this through all the different tools we have. And it comes through the department first. If the decision isn't to the liking of the hospital, they can appeal to the Public Health and Planning Council, who can then make a recommendation back to me. I don't know if there's something specific in writing. I know we have broad authority here. I'll just have the team get back to you with what actually our authority is. I did talk to our legal team about this last week in particular, and I'm told we have very broad authority here. And this is part of why when I just say to people, I really think it's important hospitals not get ahead of the department. I think that's really important for them to know. I also think that I can't comment on any particular regulatory action going on, but if people have concerns about something, they should let us know. I said earlier, I actually read every email. I don't respond to everything, but you'd be surprised how fast I process information. But I do read every email we get, and I do forward it to people in the department to do things about it. And I'm not specifically calling out one hospital, but I'm kind of aware of what's going on in the state.
Thank you. So the governor puts into her budget again this year the creation of a data warehouse, which she now is specifying will be to analyze maternal outcomes. She's put that money in the budget multiple years. Did anything happen so far? Is there any development of a data warehouse that's in process? Because originally it was for more kinds of data than just maternal outcomes, but I think the language this year is a data warehouse for maternal outcomes. What's the story here?
So there's a lot going on with maternal health. There's a lot going on with maternal mortality. I don't know specifically what you're referring to with the data warehouse, so I'm going to have to get back to you on that one.
Okay, she's putting money in for the building of a data warehouse. I don't quite know what that means either yet, but I'm still trying to figure out when there's a cloud why you need a warehouse, but never mind, that's a different question. All right, so the Medical Indemnity Fund, MIF. That was set up under the Cuomo administration. It's for children who are born with serious disabilities and rather going through the medical malpractice court system. There was a different setup. And the fourth quarter report for 22 is the last one published. So I think we're a year behind and I'm looking for the new data, but most relevantly, in the fourth quarter report from 22, the estimate of the assets to expense ratio was expected to exceed 80% by the end of the second quarter of 23. So that would be over 6 months ago now. And it referenced closing down the fund and not letting any other patients in when they literally were running out of money. I need to understand, are we putting new money in? Have we stopped accepting more children? We have a legal obligation to the children that are in the fund for the rest of their lives. What's happening?
Thank you for the question, Senator. We have not stopped enrollment, and if we did, we would notify you as well as others per the regulation of the program. But we are continuing to see higher enrollment month over month and expenses month over month, as you know very well. Individuals who are in the MIF have the lifetime benefit. They're living longer. We have continued the commercial rates or the change that was made to reimbursement since 2017, which has really put pressure on the allocation for the MIF. There's no new investment at this time to support the MIF, but it's something we are very open to working with you on, knowing the current trends and the trajectory of the program.
Well, if I remember reading the previous reports, you should very soon be actually out of money. So what's going to happen here? Where are you supposed to get the money? Because we need to pay for those kids, even if we don't accept any more into the program.
I think there's an understanding from the executive and the division of budget that more money may be needed, and we look forward to working with you on ways to get that level of support to the MIF.
So there's a 30-day amendment time frame for the governor. I hope that there's someone listening there on the second floor and that they will go ahead and put the money in, because I don't know about anyone else, but I don't want to wake up one day and learn that you don't have any money in that fund and you have desperately ill children who were promised lifetime care and we don't have any more money for them. I take this very seriously, and I think you do also.
As do I. Yeah, we're on
Thank
the same page.
Okay, thank you. Okay, we had a conversation with some people from Department of Health a few months ago about the importance of providing more training for doctors and physician assistants and nurse practitioners in reproductive health care services, that there was a shortage of providers in the state. And I had made a proposal to the governor's office with some of my colleagues for an investment in expanded training services for people who it's in scope of practice, they are already licensed, but they've never had the training to provide some of the care procedures disproportionately in second and third trimester and needing to be in hospitals. I didn't see any proposal like that in the budget. Is it there and I just missed it?
I didn't see one in there either. I'll get back to you though and find out if there isn't one in there. I'll talk to my team.
Okay, thank you. Okay, sorry. A number of people brought up the discussion about the long-term care providers and the amount of money being spent on the agencies as opposed to the actual service providers. And there was even some recent data, came out in a couple of op-eds, I think one yesterday, that the state is paying MTLCs $4,500 per consumer for each month, regardless of whether that's actually going, or a significant percentage of that is actually going to home care workers. And a concern that home care hours approved were in the lowest hour categories, even though we're paying these middleman agencies enormous amounts of money. A number of advocacy groups, I think that will be testifying later today if somebody stays and listens, will be arguing that this is a total misuse of the limited funds we know we have, and that we should be rethinking completely this model and putting more money into the actual payment of workers, because we have a desperate shortage both of the number of workers and the pay still seems very inadequate to get people to want to do this work. And yet we're spending an enormous amount of money on the middleman agencies. Has your department been discussing any of these proposals at all?
Yeah, we have seen some of the legislative bills that have passed and are still reviewing those. But I would say it's not as simple as one would think. And there are a range of considerations with respect to modifying that program. And we have the same concern that I think you expressed with cherry picking of members who may not need the level of services that the premium currently assumes. I think we've talked about this in the past and have some proposals to address it, but it is something we're concerned about. But I don't know that we have a position on the legislation you're describing and whether we agree with the estimates that tied to that proposal.
Yeah, I don't know about the estimates either. I would just argue that then you should do the research and come up with your own projections on the numbers. But I do think that when you look at the breakout of the dollars being spent on the quote-unquote agencies versus the workers, something's wrong.
One thing just in the last 10
Yes.
seconds is we did pass together legislation to do more reporting, both on the payer and the provider side. And so
Yes.
we are implementing that and look forward to getting you that information when it's ready.
Thank you. I have 3 more minutes. Oh, technically I have 3 more minutes, but I'm going to wait to see if there's more people going first. Thank you very much. My time is up.
We have more assembly members. Next is Anna Kellis.
So I just wanted to make first a comment following up on the MIF question. My understanding is that the funding was supposed to originally come from hospital assessments, but that funding has been going into the HCRA. which is lumped in with a whole bunch of other funds, which makes it really difficult to follow and track and make sure the money goes to the right place. So I can follow up with you, but I'd really love to hear how that is being handled to make sure that it's going to the right place and it's still coming from the hospitals. My understanding is we haven't actually collected money from hospitals in years.
That's not my understanding. There is an assessment that is imposed on hospitals specifically that funds the appropriation in the MIF for the MIF. A lot of our taxes go through HICRA, so that doesn't necessarily mean it's not being applied. It is.
Another question. In March of 2024, the list of vital tasks that we use for determining someone's eligibility for managed home care is going to reduce down to 7. A lot of the things that are being removed were tasks that really do identify limitations in cognitive and physical disabilities, and I'm curious if that's being reevaluated, given that managed long-term care is certainly, or home care is certainly much more cost-effective than someone being in a home.
Can you repeat the question? I didn't.
So there is a list of vital tasks that are used to determine whether or not someone is eligible for home care, managed home care. And that list was reevaluated and is being reduced from 22 tasks down to 7 tasks. And my question is, given that that is much more cost effective than someone being in a assisted living or a home, nursing home, are we reevaluating this since it's going to go into effect in March of this year?
I think we'll have to take this one offline. I think we may be talking about a separate issue with respect to eligibility.
Okay. Happy to take that offline. Then, last question, given my time. This past November, the Drinking Water Quality Council recommended 23 PFAS chemicals to be designated as toxic PFAS chemicals or as emerging contaminants, and that would require statewide drinking water testing and notification. So I'm curious when that is expected to come out, and if it's expected to come out before the budget, since it may have an impact, of course, on our budget.
It's yes, that happened. We do listen to the Drinking Water Council. I expect that to happen. I don't know the exact timeline. It'll be coming in the coming months, so it has to go through the regulatory process, is my understanding.
But we should expect that to come out, and they will be identified and put in as emerging contaminants.
Yes, that's my expectation. Some of this will depend too on what we hear from the federal government as well. Remember, the Environmental Protection Agency is doing their own list as well. We plan on listening to that and updating our list based on that.
Thank you very much. Next on the assembly list is Jonathan Jacobson.
Thank you, Madam Chair. I have 3 questions. I got to go quickly. We don't have a lot of time. To Superintendent Harris, a lot of people are getting flooded all the time in their homes, and they call their insurance agent and they find out they don't have coverage because wind-driven rain is not covered. It's never been discussed with them. I would just hope that you could set up new rules and regulations so there's more disclosure on what is in a homeowner's policy and even a renter's policy, and to have some more evaluation, because when someone's doing a closing, they're looking to save every nickel because it's costing them more than they thought, but that they should know what the risk of reward is on getting flood insurance or additional coverage.
Absolutely, sir. It's a very important issue. I'll note that we are providing a briefing for all members of the legislature on Thursday around homeowners insurance, flood, and climate change. We do have rules around continuing education requirements for brokers and how they must speak to homeowners about what's contained in their insurance.
Well, I look forward to new, stronger rules to make sure there's more disclosure. To Director Passeri, it seems like we're penny wise and pound foolish when it comes to Medicaid spending for home health aides, because it's very hard to get the workers. If we don't get the workers, they're going to the nursing homes, and the nursing home is the most expensive place for anybody to be taken care of. So we've got to change it. You can't look like it's just a budget item for this year. You got to look more longer term. You think perhaps there could be a change of thinking on this?
I mean, I think we're always looking to be more creative and innovative Governor Hochul has made a tremendous investment in the home care worker wages and workforce, not just over the past couple of years, but prospectively indexing that increase to inflation and paying above minimum
I
wage.
got to go to my next question. I hope that's a yes. I'm not
Yes.
sure, but I hope that's a yes. To Commissioner McDonald, in the Hudson Valley, which I represent, the average time to get served, for want of a better term, to be treated in a hospital is 163 minutes. At Vassar Brothers Hospital in Poughkeepsie, it's another 90 minutes, 250 minutes. So that means it's better to go travel a half hour, 25 minutes to Newburgh or Kingston to get treated. How can we allow such long wait times to let this? Because you're not getting treated.
I can't answer that in a second. We'll get back to you, my friend. We'll get back to you.
All right.
Saved by the bell.
I'm happy to answer it. It's your time limit, not mine.
Next on our list is Khalil Anderson.
Okay, there we go. All right. Thank you so much, Madam Chair, for allowing me a moment to just ask some questions. It's good to see all of our commissioners here today. Thank you, Commissioner McDonald, for in your opening remarks mentioning your trip to my district. I trust that you got to see some of the things we need to work on at our healthcare institutions across our state, including in parts of Queens that are distressed. And hopefully we'll get you to come, Superintendent Harris, to the district. As you know, we're a banking desert, and it's really important to visit. So my question first, and I know my time is short, is for Commissioner McDonald, and I'll go over to Superintendent Harris. One of the things I mentioned to you on that tour last year was the need for funding resources and set aside for hospitals that are geographically isolated. I think I kicked this in your ear among the other things we talked about. And this is not something that is a phenomenon to my peninsula community in Southeast Queens, but this is stuff we're seeing in North Country, other parts of the state. So I'm just wondering if there is an angle or a space in this budget to look at additional resources for geographically isolated hospitals.
Yeah, so I really enjoyed my visit a lot. I learned a lot about Queens. It was great to meet you and others down there. It was wonderful just to see the healthcare situation down there. The 1115 waiver does offer some help in this regard, though, and I think this gets to one of those issues where a lot of what the 1115 waiver about is, when I say health equity, it's about getting healthcare, part of this, to the people who need it the most, and trying to deal with some of this isolation. Because you're right, your area is different, and there's a uniqueness to it. But I think the 1115 waiver could be helpful in that regard.
Excellent. I'm interested in following up with your folks to figure out how the fee waiver can be used to help support geographically isolated hospitals, because it's one thing when you have distressed hospitals, but then there's geographically isolated hospitals. So we're looking forward to follow up on that. Superintendent, it's always good to see you. My first question, and I've been working really hard on the issue of captive insurance. And I noticed that, we've been working on this bill for a long time and figuring out how to keep insurance providers who are in the state providing that insurance and providing support for those who need it. So I'm wondering if you can let me know if there's a cost associated with implementing captive insurances, including the one that was passed by the legislature and implemented by the executive last year in Ithaca.
Yeah, so there are including $100 million in reserve requirements that are required for captives in the state of New York, but always happy to talk offline or reply in writing about additional requirements that we have to make sure captive insurers are safe and sound.
So there's a $100 million price tag generally for a captive in general? Oh, okay.
Yes.
So we'll follow up. Thank you.
Thank you very much. I'm on now for, Pam Hunter.
Yes, good afternoon. This probably is for Commissioner McDonald. I think we obviously all are aware that there's an emergency room and healthcare crisis. And just to set the stage a little bit, the traveling nurses who are getting paid exponentially more than someone who lives literally across the street from them. And I know that there's a bill to try to take care of that, but that is a significant issue. And I know you were talking about cutting spending, but we have to find a way to get that done. So where I live in Central New York, there's a nursing home that has 2 days cash on hand. And I need to go to his county because we have people waiting in the emergency room for 8 hours without even being seen. So apparently they must be doing something right down there. But there's beds available but aren't open. In one of our nursing homes, the roof actually collapsed with patients, residents in the nursing home. A resident actually left through a window, and the people didn't even know in the nursing home that the person was gone. And then there's been conversations that, really a health system has to be bankrupt before the Department of Health steps in. So I guess I'm asking, if you can answer the question, how can we alleviate this 8-hour wait time in the emergency room? Because it's not just people not having primary care visits in order for them to go to, and it's not just a well now issue. And you spoke about talking with healthcare facilities about better finances and cutting spending. So can you just give a couple examples of where do you think they need to cut spending? And I will give you the rest of my time.
So I think the emergency department wait time, which is something I really appreciate you both bringing up here, is a multifactorial issue. There's a lot going on. Where hospitals and emergency departments need help is getting staff. So if you have licensed compacts or you actually get nurses from other states who will practice there, that will help. And, I think getting people like physicians is also another licensed compact help. There's other scope of practice changes like a PA, not necessarily having to be supervised because hospitals can find ways to do that. This is so they can hire more staff. But there's other issues as well that we're dealing with here with this whole, emergency department wait issue. Part of it's just quite frankly, not just the availability of qualified professionals, but just, the throughput in hospitals. Like one of the things hospitals are struggling with is you have someone who's ready to go home, but they can't get them to the next destination, whether it's a nursing home or some other setting of care. So I'm more than happy to help hospitals try to solve the throughput problem. I think that's one of the biggest issues we have right now is helping hospitals move patients through their system. Hospitals have a hard job. There's nothing in our culture like a hospital where anybody can show up with any problem and the hospital is expected to solve
An
it.
example of cutting spending? A couple
I just gave you several. I talked about labor. Labor is the biggest cost. It's about helping hospitals not have to hire urgency nurses. The agency nurse costs are excessive, very excessive.
Thank you.
Is Farah here? Yeah. Next.
Good afternoon, everyone. Superintendent Harris, according to the American Diabetes Association, attributable costs to diabetes in New York is $7 billion in premature mortality costs, $11.3 billion in lost productivity costs, and $17.3 billion in medical costs. That's $35 billion in costs to the state for diabetic costs. So, do you think that getting rid of insulin copays and allowing access to the life-preserving drug will save the state more money or more money than any infinitesimal rise in insurance premiums?
Ma'am, I do. I think we expect about a 0.03 to 0.04 premium increase as a result of the governor's proposal to take cost sharing for insulin to zero. And some studies from other states, including Louisiana, show that when you take the cost sharing for chronic disease medications to zero, you can save quite a bit in overall costs as people become increasingly compliant with their care requirements.
Thank you so much, Superintendent Harris, because I look forward to seeing us really take a stab at that $35 billion cost.
Likewise. Thank you.
My next question is to either Commissioner McDonald or Dr. Basiri. As a Black mama and one who gave birth at a public hospital, maternal health is very important to me. Safety net hospitals are especially dependent on Medicaid, correct?
Yes.
Okay. And in New York City, particularly, Black women are more likely to deliver at a safety net hospital or public health hospital. Is that correct?
Yes.
Okay. So the governor in her budget wants to battle Black maternal health. And also cut the Medicaid budget by $1 billion. So, what will be the impact on Safety Net Hospital and, by extension, the Black maternal health? What will be, impact will be by cutting the Medicaid budget by $1 billion. And do these cuts contradict her goal in helping Black mamas like me?
So I'm not aware of a $1 billion cut. There are substantial investments in maternal health. The Birth Equity Improvement Program is something new the department started last year that I think is very helpful. 70% of the hospitals are participating in it, covers 76% of births. The Birth Equity Improvement Project is really trying to get to anti-racist messaging, addressing people's implicit bias, giving people a chance to actually interact and tell us retail what their birth was like. Did you have a respectful birth? That kind of thing is very important. That feedback's important. But there are investments going on in the Perinatal Collaborative as well.
Okay, thank you so much, Commissioner. We'll talk more about it later.
Thank you. So now I'm on the clock for 10 minutes. First question, getting back to the issue of C-sections and the proposal. Exactly what are the financial incentives? It says financial incentives, I'm reading your testimony, to get hospitals to reduce unnecessary C-section births. So I wondered exactly what the proposal looks like.
Sure. Thank you, Chairperson. We are investing funding in a quality incentive program that really evaluates based on a subset of hospitals that have a minimum number of deliveries with cesarean rates that are above, the average. We will provide incentive funding if they're able to get those rates down to the statewide average. And if they're at the statewide average, we will give them incentive funding if they get 1 percentage point down. So it's really targeted to help them or give them the incentive to make upfront investments and programmatic and clinical changes to prevent cesarean deliveries overall and to reduce their number as compared to themselves. So they have to improve.
So I guess 2 follow-up questions. So this is every hospital's eligible if they fall into those categories.
The hospitals that are eligible are those, I believe, it's with a minimum of 500 deliveries in managed care. On an annual basis, I think it's 500. I can get back to you to confirm.
So they're not only Medicaid patients; they're across the board.
Well, they actually are. It is 500 deliveries for Medicaid managed care.
So it's only for. So the only reduction program is for those who are enrolled in Medicaid.
That is what we are measuring against. Yes, that's what we are paying on. We're paying through Medicaid, and we're measuring their percentage of Medicaid deliveries.
So do we know, or have we looked at the amount of C-sections outside of that population? Is there any program to address those excessive numbers?
I think there are.
So there's a robust maternal health package in the Department of Health. We do work with the Perinatal Quality Collaborative. That's many hospitals that deliver birth, to have birthing hospitals in the state, and they focus on all these quality metrics. One of them is decreasing C-section rates, particularly for low-risk individuals. So that's one example of how the Perinatal Collaborative does work. And they do work also that addresses mortality as well and adverse outcomes as well. They're trying to all work collaboratively together to do that.
Are those financial incentives?
The Perinatal Collaborative, it gets an additional $700,000, but it's not a financial incentive. It's work we do with them so the hospitals learn best practices and work together. And they've had success in the past. I mean, they've actually done things that have created protocols that all the hospitals use to improve birth outcomes and maternal outcomes.
With all due respect, we're 49th out of 50th state for primary C-sections, and that's a problem across the board, not just Medicaid. Although I would argue, evidenced by the report that came out by the department a couple of years ago, that Black and brown pregnant people are more at risk for C-sections. So, but they're not necessarily on Medicaid. It's because of their race.
The Birth Equity Improvement Program is working on that as well, because you're hitting on, I think, very important issues, which is some of the racial disparities, which shouldn't exist, not just for the C-section rate, but for the maternal mortalities. And that's why there's a multi-pronged approach. There's also the maternal mortality review
I would
board.
just think we might do more.
Happy to do more, and I'm open to your ideas.
Oh, I think we talked about that a little bit yesterday, but I think there needs to be financial incentives across the board to increase midwifery. That was also in the report. We need to have financial incentives for all hospitals that are, as you say, above average to reduce the C-section. I don't know that it's limited simply by Medicaid.
We do pay midwives 95% of what we pay obstetricians, but I'm open to other suggestions you have.
I think we should perhaps, if we want more midwives in hospitals, think about paying midwives more.
Oh, that's interesting. Okay, so you want to pay midwives more than obstetricians?
Perhaps,
Yeah.
but I do think that you need to drive the change, and if you want to drive the change, it's dollars that does that. So I'm gonna move on because I only have not that much time. Procurement. According to the report issued to the legislature a few days ago, there has been mergers and acquisitions in the MLTC resulting from the quality metrics that we enacted last year. Specifically, 9 MLTCs do not meet those metrics, and there are already been 7 acquisitions to conform to those standards, and 1 plan has closed. What is the need to go forward with an additional procurement of all plan types when we have proven that implementing quality metrics can effectuate the same change?
Thank you for the question. It's a good one. I don't think that the intent behind the proposal to procure managed care plans is not necessarily to hit a specified number of plans, which is more akin to what we did last year by changing the standards, as you said. But there's a lot more we can do to increase competition in the market. There are products in managed long-term care that are not available on a statewide basis, which is why we still have partially capitated managed long-term care plans. And I think we would take everything into consideration that has been done by the plans that have stepped up and acquired other plans and helped us implement this proposal into consideration with the evaluation in a way that would mitigate or minimize any impact to providers and or members.
Thank you. I'm tempted just to go back to C-sections for a moment because I feel like I have a forum to talk about it. And so I'm going to mention a few other things. We should be doing, I know the department supports this, more value-based as far as specifically birth is concerned, driving that a little more. I know that we're doing some of that, but we should be doing more of it. We should be informing women. I would suggest that physicians are not doing that. One staff member of mine, for example, former staff member, had 5 pregnancies, was never told that she could hemorrhage, did on the table of her 5th pregnancy because no doctor had informed her that having successive C-section was a problem. Educated, smart woman, never informed. She probably would have not had that baby if she had known. And also, there needs to be a little more analysis by the department to determine what are the causal factors. You might want to collect data on that. For example, a lot of midwives, for example, would argue, and I would agree, that giving an epidural in the middle of someone's labor could delay the birth and therefore cause a C-section. Is that what is happening in some of the places? We don't know. So if you just look at the number of C-sections without looking at the before, you don't get at the issue. So the department has to do more data collection, more analysis of the hospitals that have excessive rates. And if we really want to combat, the excessive number of C-sections that we have in this state compared to every other state but one, and as you pointed out, I don't know that it's Florida yesterday, but New York has to be better than 49. We need to do a lot more to enhance the governor's proposal. So I'm looking forward to the 30-day amendments. So with that, okay. Pharmacy questions. The department is also a year into last year. This was all about 340B, and about saving money. how does the actual savings look against the projections?
Thank you for the question. We are on track to achieve the savings we projected and enacted in last year's budget. There's a little bit of a timing issue with the way that our federal and state supplemental rebates come in, but we will be able to provide an update on that as we get closer in the budget process. We're going to hit those targets.
Great. Pediatric nursing homes, as we know, care for the most vulnerable and sickest children. And what was there an intention to include pediatric SNFs in the cut, or can we exempt? Was there consideration? I think they are included. Is there consideration to exempting them?
There are certainly considerations, and there was not any intention to make a targeted reduction to those pediatric nursing homes. There are some state plan issues with trying to exempt them, but we will explore that. And if possible, I think that's something that you could see in negotiations. But I would also say we have the young adult demonstration that we put forward that really does support young adults as they age above 21 to keep that pediatric rate, which is over $1,000 a day.
So I'm going to come back in my 3 minutes.
Back. Don't worry, it'll be quick. School-based health centers. There's the managed care. The carve-out for managed care expires on the 31st of this month. Y'all have continued to veto my bill to ensure that they continue to be reimbursed in fee-for-service. But I just want to know, for the record, what can providers expect on April 1st for the rates?
There are investments in this budget for school-based health centers.
Mhm.
You know, we did the 10% increase last year, but there's $1 million to restore our cut from 2017. There's $1.5 million in this budget to enhance oral health care. And then there's $1 million in there as well to help community health workers in there. So there isn't any plan right now to move school-based health centers into managed care.
Okay.
Did I get all of what you wanted there?
Kind of, but I'll follow up afterwards.
Okay.
There's to follow up something on 340B. There's one part that still is under managed care, which is provider dispensing, and but you're making some changes in this budget, if I'm not mistaken. So there's an elimination of it for provider dispensing in this budget. Is that not correct?
No, that is incorrect.
That is not correct. So
Provider dispensing in Medicaid is dictated by very clear federal rules that require acquisition cost-based survey to establish a professional dispensing fee. So we don't have the liberty of making changes to that component of the reimbursement without going through a process.
Then I am obviously misunderstanding a part of it. I will follow up because it was my understanding based on the language that we saw that there is a proposal to eliminate 340B benefits under managed care for provider dispensing. But if I'm mistaken, well, I messed up. Moving on. So we'll revisit that. There was money that was approved by the feds back in July that has not flowed to the distressed hospitals yet. Do we have a timeline on that?
I think, yes, I think you're referring to the state-directed payment.
Mhm.
As you see in the budget, we do have some financial pressures due to the subsidies that we've advanced to certain hospitals, but I think that's something we're actively discussing.
So no timeline that you can tell me now?
There's no timeline right now.
Gotcha. And last, you might be surprised by this, but I want to finish on a lighter note. And that is to say that the proposals that the governor has made on medical debt, there's a bunch of them that I'm a very, very big fan of. As I've said many, many times, the idea that medical and debt are two words that are next to each other is an obscene proposition. That's why we need to pass the New York Health Act, but we'll get to that a little bit later. At least for now, there's a bunch of proposals here, and I'm very much looking forward to working with the governor and the administration on getting many of these over the finish line, because it is incredibly important that we protect people from medical debt. And the Knicks are doing fantastic, man. 9-2 since they switched Anunoby. I'm telling you, now they open up the floor. It's a little bit different. You got, Brunson is playing. Don't worry about it. It's fine.
Thank you.
Yes, we have 3-minute follow-up from our insurance chair, David Warburton. You don't want it?
No, I'll do it.
And you turn.
Okay, I'm on. I'm green. Going back to the supplemental spousal liability reform, there is a sunset on that, I believe. Why is that?
So the sunset was part of the previous proposal, and so when these amendments were put forward in this year's budget, the sunset was there to match and make sure there wasn't a timing mismatch between the original proposal and the amendments that were just put forward.
Okay, and the sunset is when?
Sir, I don't have that in front of me, but happy to come back to you.
Okay, all right, fine. And you had mentioned with the insulin zero copayment, there would be about an 18% savings. Is that the number?
So there was a study in Louisiana that looked at zero cost sharing for medications for a number of chronic diseases, showed up to an 18% savings across the board. So insulin is certainly a big driver of that. Diabetes is a big driver of that, as your colleague noted, and those are some of the best studies we have on proposals like this one, sir.
Okay, and what would that savings be put to? Where would that? What would you do with that savings?
Oh, that is not my decision to make, sir.
Okay, and how much money are we talking? What do you think the dollar amount would be?
I don't have the dollar amount. It actually is a savings in the Louisiana study across the healthcare system. So it would be potentially with respect to overall insurance premiums, cost containment when we look at providers, but we don't have a breakdown of how that savings was allocated across the state of Louisiana when they did the study on this.
Okay. It's fine, yeah.
Okay, I'm just going to follow up with a couple of other questions. I think you guys are done, right?
I have 1 minute later for you.
Okay. I guess I was struck by how much it costs to close a hospital, the capital expenditures that are going to be needed for SUNY Downstate. And I also was just texted by one of my colleagues, it's the only midwifery program in Brooklyn. So it's just going to mention. But it's a lot of money. Not that those improvements to outpatient don't need to be done and all of that in order to shore up the community. I get it. But at the same time, there's a decrease in the capital overall for hospitals. And since the waiver is only going to address 12 hospitals, and we know we have 75 financially distressed and probably a lot more on the brink, is that, for hospitals that could make their own improvements and increase their own outpatient, isn't that I guess I'm asking why.
I need the question in a way that I can understand a little better.
Yeah.
I'm not following you right now.
So it seems to me that you need a lot of capital in order to close a hospital and transition them to outpatient, vis-a-vis SUNY Downstate. And yet at the same time, we have a lot of hospitals that we're not really dealing with in the budget because it's very expensive. So why don't we increase? Why is the capital decreased at a time when we know they have to transition to more outpatient universally across the board?
I'm a little uncomfortable talking about downstate specifically because, quite frankly, it just hit the news and it's in the regulatory process now. So I don't want to strictly address that.
I'm really not asking about downstate. I'm asking about the
fair
capital.
enough, but let's talk about it then. What do you say?
I don't know that there's necessarily been a reduction in hospital capital, but there are new things that can be paid for with the hospital capital, including transformative projects that may include, partnerships or things that are not traditionally funded through our statewide healthcare transformation programs. But I don't think it's a reduction, and we're happy to confirm that in writing with you. It's really another tool in the toolbox to support, safety net hospitals and trying to redesign the community-based care.
And just one last thing, going to what my counterpart in the Senate, Senator Gustavo Rivera, said about, and also right here, managed care is supposed to manage care. And I am, again, a lot of groups are coming and saying we want to go back to fee-for-service, thinking that's going to be a better system because care isn't being managed. It's just being administered. And so I don't know if there's a hard look at what that reality is. And this is the end.
I think I would be not on. Thank you. So I'm not saying you need to be able to answer it now. We have no time, but I would love for you to come in and sit with me and Gustavo Rivera and our staff and help us understand when we pay for managed long-term care, how do the contracts work? Do we pay X amount for the actual workers, Y amount for the managed care, Z amount for something else? And do we pay different amounts based on the level of need per patient? And who makes the decisions about how many hours per patient are being contracted for? And if we get 10 hours, do we pay less than if we're getting 20 hours? Or does the agency keep the difference if they're providing less number of hours? So you can't answer in 2 minutes, I know that, but I would love to be able to sit down and try to help the Senate and the Assembly, if they like also, to get our arms around what are we spending and on what pieces of the puzzle.
I would love to do that with you anytime.
Okay, thank you. Oh, no more Knicks. I don't know sports. I'm going to give up my 1 minute and 37 seconds to close us down. Thank you all. Pardon me. Thank you all for your time with us today. And you do have many questions already on your list to answer. And we will do the follow-up on the math in long-term care Medicaid. We'll find a time sooner than later. And I want to thank you all for your work every day and your time with us today. And I want everyone to, if they're following these 4 people out, to chase them down, bother them outside in the hallway, not here in the room, because you might have noticed, we're only going to panel A, and we have pages of panels. So I would like the Greater New York Hospital Association, the Healthcare Association of New York, and 1199 to join us here. Okay. And also, just because this happens every year, we run later than everyone imagined we would. And so if you decide you have to catch a train and go home before we're going to call you up at 9 o'clock tonight, we won't take offense. Everyone's testimony is up online and it will stay there available. And so just let somebody here in the front know if you're leaving. So we're not trying to track you down 6 hours from now when you really decided it was time to get on a train wherever. So thank you, the ending panelists. Welcome the new panelists. And let's transition quietly. Thank you. This is Thank you. Everyone take your conversations outside, not in here. You can come back when you're done chatting. Okay, great. All right, so I see some of our panelists. Where did the rest go? Okay, great. Okay, so great. And I guess we'll start in the order that you're in. Ken Rasky, then B. Grouse, and then George Gresham. And we do have new microphones, and if you weren't here earlier today, you don't know yet, you have to push the button very hard to get it to go from red to green, just when you're talking, so just letting you know that. Okay, Ken, shall we start with you? Absolutely. We shall defer to B. Grouse. Welcome.
Thank you. Good afternoon, Chairs Kruger, Paulin, and Rivera. I don't know where they went. Oh, they're gone. And other members of the Senate and Assembly. Good afternoon. Thank you very much for the opportunity to testify. You know, the ED backlogs, the unit closures, the lack of access to nursing home beds, the lack of access to home care, many of the comments and questions that you raised earlier today, they are all symptoms of a failing financial infrastructure for New York State. Given our aging population, healthcare workforce shortages, health disparities, and medical advances, we know we have to come together to find new, sustainable solutions to provide access, to improve health, and to achieve and maintain affordability. That is the backdrop that we are all operating, that we all must consider eventually. And there are no cheap, easy, or quick solutions to it. It will take years. That is the long-term backdrop. But right now, this budget, we must focus on stabilizing the healthcare system that New Yorkers depend upon today. I'm going to talk about two issues. There certainly are many, but the first one obviously is Medicaid. Woefully inadequate Medicaid reimbursement has been and continues to be central to hospitals and nursing homes. And the governor and the legislature must close the Medicaid gap and make a significant down payment this year. Last year's Medicaid rate increases were a good start, but the rate increases for hospitals in particular was largely offset by other reductions such as 340B, and for nursing home it was overshadowed by the staffing requirements. These rate increases, the 7.5% and the 6.5%, were also the first of significance in 15 years. 15 years. And they in no way resolve the gap that is widening as labor costs, drug costs, supply and equipment costs continue to rise faster than inflation. The executive budget, and you talked a lot about this morning and early this afternoon, the 1115 waiver also wholly fails to address the urgent need to stabilize all hospitals and nursing homes. And again, the 1115 waiver is largely not addressing stabilization, which, as one member said, really is akin for hospitals to throughput. In addition, the executive budget's proposals, both defined and yet to be defined, may in fact result in hospital and nursing home funding being cut by $1.3 billion. And again, I urge the legislature to make a multi-year commitment to close the Medicaid reimbursement gap and to maintain and increase supportive funding. Second, we must continue to build the workforce pipeline and bolster our current workforce. Hospitals and nursing homes statewide face tremendous challenges recruiting for a wide variety of clinical and non-clinical roles, as we've talked about today. Haney supports many essential workforce proposals advanced by the governor, including joining the Interstate Nursing and Physician Licensure Compacts and enacting many critically needed scope of practice reforms. I'll conclude by urging you to oppose any harmful policies or funding cuts that further threaten provider sustainability, including the cuts proposed within the executive budget. New Yorkers expect their local hospitals and health systems to be there when they need them, and without your support, they won't. Thank you.
Yes, Madam Chairman, thank you. As always, a pleasure to see the empaneled group of individuals and esteemed legislators. Today is a very special day. It represents a hallmark in healthcare policy formulation in New York State. George Gresham, my partner and fellow proposer, I was here today to ask for your help. We need your help in establishing a very simple but a very important policy position in healthcare in this state, and that is to eliminate the disparities in Medicaid payment to come up to at least paying the cost of care, and at the same time eliminate the disparities in healthcare indices in our communities of color. How simple of a request is that? And we look at that and we ask you, we are going to work on that proposal over 4 years to get it accomplished. This is the equivalent of going to the moon in a spacecraft, except that this is accomplishable in our own backyard. And we need to do this for the people of this state. We have gone to the executive branch and we have made this proposal. Let's work together and roll up our sleeves to do this. But as you can see, the budget that you have before you for consideration does not have one peep on this subject. And that is a tragedy for this state. We have many, many issues of our hospitals in fiscal distress. You can hear that. You heard it from B. You know about it from your own communities. And we also know that last year's budget, you know what I call last year's budget from the executive point of view? An inconvenient truth. Now, you maybe heard that before, an inconvenient truth. What does it mean? Yeah, they got 7.5% increase in rates, except, Amy, you know they wiped everything out with 340B and with a cut that was involved in the polls. So what kind of arithmetic is that? It's like 1.6%. So, ladies and gentlemen, we have the side of right on our side, this as we present this to you. Finally, I would make the point, gee, how are you going to pay for it, Ken? Well, the answer is you're sitting on a mountain of cash, probably the most cash, certainly in the history of this state and probably in the United States. And that cash is more than enough to cover the reserve requirements of all the entities that you're involved in. So let's use a smidgen of that cash to make a down payment, ladies and gentlemen, on this basic plan.
Thank you, Ken. Thank you. We would appreciate, actually, even when you agree with folks, if you just not applaud, because we can't keep going. This is a great way to show your appreciation. Thank you. Thank you so much. Next, we have George Gresham from 1199. Good afternoon.
Thank you very much. I would say that it's a pleasure to be here and to see you, but the reason why I'm here is not a pleasure at all. In 5 minutes, I'm going to try to tell you something that I hope will compel you to make changes in the proposed budget. You know, this is my 60th anniversary where my parents brought me from the South as a part of the Northern migration to take me out of segregation in the world that I was living in down South. And we've made a lot of progress over the years, only to see some of that being reversed back. What I want to talk about today is the Medicaid cuts. When I was asked by the Greater New York Hospital Association to get involved in this conversation, when I looked at the facts, I was like, this is not just about balancing the budget. This is a civil rights issue. When you look at the reduction of Medicaid when a person comes in, why is that make sense to give them the hospital 30% less care, the hospital and nursing homes? What does that mean to me? That means that the people that are being serviced are 30% less human. How can you deny the fact that the communities that primarily are being faced with these cuts are the Black and brown communities? How can we stand up and say that that's okay? It is outrageous when you look at COVID, and when COVID came to visit upon us, where were the highest fatalities? They were in the Black and brown communities. Why? because we are not the healthiest communities. COVID was clearly survival of the fittest. How long are we going to go with this? This is racism. From my perspective, I would hope that people understand that you can see it, that you say New York is better than this, and that we're not going to reimburse the hospital 30% less for taking care of the black and brown community. I'm going to raise my voice as loud and as long as I can because this is outrageous. But I hope that you're going to partner with me, that even if you were not aware of it before, that in the year 2024, this is absolutely unacceptable.
Thank you, George.
I think our first questioner is Zelnor Minery.
Thank you, Madam Chair, and thank you for taking the time to testify before us today. I have one quick question. Can you talk to us about what impact this has on the workers? We talk a lot about the service to the community. We talk a lot about the healthcare provision and the impact on the patients. But can you talk about how this discrepancy has affected the workforce? And that's for the whole panel.
Sure, I'm happy to talk about this speed up that it has caused in the workers. For example, the safety net institutions, on any given day, you can go into the emergency room and it looks like a war mass unit. People are taking care of patients on stretchers in the hallway. That has a tremendous impact. Think about during COVID when the workers did not even have PPEs. They could not protect themselves. They watched their families, they watched their co-workers die, and they were worried about taking these diseases home to their families. It cannot imagine how the workers had the courage to come in every day to fight and the resources that the hospital get. So in many of our communities, there aren't any clinics now. The family physician is the emergency room. And so in a more affluent neighborhood, when you would present with a cold, more than likely you're going to present with pneumonia by the time you come through the emergency room.
Yeah.
This is this really outrageous? Is this the best that we can do? Is this really what we feel about our black and brown and low income people? Because low income, black, brown, or green and yellow, if you don't have the means, you deserve quality health care. 60 years ago, Dr. King said, of all the disparities that exist in this country, the most egregious is health care.
I'll add.
I still have time? Oh, I thought I saw a light go on there.
I'll just add quickly. I worked for 10 years as an emergency room nurse in a county hospital, not in New York. And I would say the impact on health workers really has less to do about the physical surroundings than it has to do with the frustrations and challenges of not being able to refer patients to the proper care setting. So if they came in, they didn't have a clinic to go to, or there wasn't a physical therapist that would take them. So I think that frustration and not being able to provide the care to patients is really very wearing on healthcare workers.
Yes, hi. We have Assembly Member Josh Jensen, ranker on health.
Thank you very much, Chairwoman. When we're looking at our hospitals and kind of piggybacking on some of the things that Commissioner McDonald said previously, talking about entering different compacts, expanding scope of practice, as you look at, especially in Greater New York and in Haney's, your member hospitals, how critically important is it across the care continuum to ensure that we're right-sizing the workforce to meet the needs of all the patients who are entering in our nursing homes, whether they're or in our hospitals, whether it's in EDs, the acute care settings, surgical.
I'd like to begin, sir. Thank you. There is nothing more important in the healthcare community, and especially the hospital community, than our workforce. We have the best and most committed and most talented workers in the United States. And I say to every one of them, God bless whatever they have done in their lives to get to achieve that status. And to go further, the best investment that we can make is in our workforce for the future. There are no bad ideas in workforce development. Some are better than others, but there are no bad ideas. So as the community gets together working with labor, so often as we do, we like to come up with ideas, present them to the legislative body, to the Congress, at the federal level for development of our workforce for the future. And in that process, we can assure the finest in patient care, sir.
I would just add that I think, again, I think there are a lot of good ideas. The purpose of that is to financially for hospitals is to expand ability to recruit and retain, enlarge the pipeline and enhance scope of practice so that the costs of providing health care are reduced. So again, in light of the financial crisis, you want to make sure that you're reducing expenses as much as you possibly can without compromising care.
So, would some of these proposed changes or ideas not just help reduce the reliance on agency staff as a critical component of the staffing needs, but also help to meet some of the mandated staffing ratios that the legislature and the executive had signed off on a couple years ago?
Well, the agency staff dependence is a real problem, and that is the goal of the hospital community is to eliminate it in terms of our dependence on it. The only way to do that is to obviously invest in workforce development, sir.
Would it make sense to possibly look at geofencing where agency staff can work so they can't work in the same communities that they live in?
I think just in emergency situations is really what you should depend on it, but not as a continuum dependency as it is today in some communities, right, B?
Thank you. Senator Gallivan, ranker for 5 minutes.
Thank you, Madam Chair. Good afternoon.
Good
Appreciate,
afternoon.
as always, you guys being here and your testimony. I think you've made it very clear your thoughts, and I think we've heard your thoughts. And biggest concern, of course, is the Medicaid reimbursement gap. So I won't focus on that. But there are some specific proposals. Well, they're specific with the words, but not necessarily specific with details. Proposals in the governor's budget regarding increased financial assistance by hospitals and addressing medical debt that no doubt will have an effect on hospitals. So whoever feels most appropriate to answer, what impact will those proposals have on hospitals?
I think, as the commissioner said, we have not done any financial analysis on what the impact on hospitals would be. And I know that the commissioner did testify that they assumed that it would not be major. We don't know the answer to that. It does, I think, behind your question, Senator, is a question of who pays and what happens if, in the instance, if there is yet another reason why reimbursement, why hospitals are not receiving reimbursement that they need. So I think that it is a question of what the impact's going to be. We just have not done that analysis. I don't know.
Look, I'm going to be a little bit more clear. This budget stinks, and I could tell you why. It stinks because it's built on a shaky foundation, the foundation of which has this disparity and perpetuates it. Even worse, if you adopted this budget, it wouldn't perpetuate the 30%, it would increase it and make it worse. So therein lies what the real problem is. The investment, the objective that $11.99 of the Greater New York Hospital Association and our colleagues in the Haney's are talking about is very simple. Let's eliminate the disparity over 4 years. Let's work together, roll up our sleeves, and we can do it. And in the process of doing that, eliminate the healthcare disparities in our communities of color. My God, how much more simple can it be than to do that and say amen?
Remember,
I think I'm good. I think I know the answer to the rest of my questions. But thank you.
Thank you.
I'm good, yeah.
okay.
Thank you. Assemblymember Boris.
Thank you for being here, and thank you for fighting to close this gap this strongly and this passionately. I want to help sort of dispel some of the arguments we hear against this. So if you can just help with some of those. We want to be able to match the costs that hospitals have, but some people say those costs are not being contained appropriately, that instead hospitals are just investing in fancy rooms and all of that. Do you have a sense of how much hospital costs are going up from improving facilities or things that are more luxurious?
We have a really good idea. The hospital costs have increased substantially in the last decade, large and not offset by any revenue increases that come close to it. It is for that reason in the governor's state.
Sorry, I just want to be precise.
No. In the governor's state of the state, the governor said clearly that 42% of the hospitals in 2021 were losing money. If she would have done the same calculation,
I don't mean to interrupt. I just have 3 minutes. The question is, how much of the increased cost is investing in fancier facilities? Do you have a rough sense?
Well, let me just say this first of all. You're not talking about all of New York when you talk about that. And the safety nets, there is no increase. There is no fancy goddamn equipment. It is people that are suffering because of their zip code.
Thank you. That's what I was looking for.
That's what
Thank
you're
you.
looking for.
And so would you say that it's now become, say, standard in hospitals to have single occupancy beds and that's driving the cost? Is that what you see?
Yes, sir.
Okay. Is it become standard to have sort of larger emergency room departments that are not behind curtains or et cetera?
Obvious. I invite anyone to visit any safety net hospital ER on any given day. And then the answer will be obvious. This is not humane treatment that people are receiving.
Sorry, and you're saying that standard hospitals now, the standard is to have single occupancy, but we're not getting to see that in safety nets, right? That's the disparity that we're talking about? I just want to clarify.
I'm not sure defining.
Hospitals historically have had double occupancy rooms. There's now been more and more of a move, especially in fancy ones, of single occupancy. Are you saying that is now standard? Is that driving costs? I'm just trying to get at what the disparity.
I think without capital, I think another way to say what you're saying is that hospitals without access to capital and with inadequate reimbursement cannot upgrade their facilities in the way that others can, and that results in double occupancy.
The one thing you should know about this budget is this budget goes backwards on safety net hospitals on top of what we're talking about. It actually is a retrenchment on the contribution, even with the federal waiver, even with. It's like a bait and switch.
Thank you.
Thanks.
Senator Comrie. Senator Comrie. You hear?
Yes, thank you.
Yeah.
I have a similar question, but I just want to ask another question first. Do you have an understanding of the hospital's capacity for New York State and how the Berger report, which was 25 years ago, talked about underbedding, and we were trying to get a bill passed earlier. I heard to understand what the policies and practices for opening up new hospitals, or because we have a series of hospitals that are being opened in mid Manhattan, but nothing being done to save existing hospitals, and also in Queens, where we are severely underbedded to open hospitals, especially in Southeast Queens, which is a safety net area. We only have one hospital in Southern Queens that is doing all of the work. It's in danger of closing too. So the second floor talked about they would have to do $1 million study to ascertain those numbers. Don't you have those numbers on a regular basis that you can show people or show the state to prove where we need hospitals and resources now?
We can slice and dice any bit of information, sir, for you that you would like. We can give by service areas. We can do beds. Beds is just a proxy because the medical care system has advanced so much in the decades that certainly I've been involved in it. That beds is not necessarily a good measure for a lot of communities of availability of good healthcare services. You take, for example, I'm having an outpatient procedure and surgery this upcoming Thursday. 10 years ago, that very same procedure it's going to be done on me was done on an inpatient basis. So there is this great change that is going on, sir. But we can give you whatever you wish in terms of information. I know that's from B, it's from us. We certainly, our colleagues at 1199 feel the same way. Whatever you need, sir, we can provide you.
Thank you. And we also need to make sure.
And all of your colleagues as well.
Right. Well, thank you all for being here. And the issue of Medicaid reimbursement is major, as I recently had some work done as well. And to see that Medicaid is only paying 10 cents on the dollar is ridiculous. The rates are ridiculous. I hope that we can get Medicare equality, Medicaid equality. We did it for the campaign for fiscal equity for schools. We can get this done within 4 years. So thank you.
Thank you, Senator.
Yeah. Thank you, sir.
Thank you, Senator Comer. You still have 26. Oh, no, you don't. You had 26 seconds and you've lost them.
Assembly Member Gandolfo.
All right, there we go. My question is going to be directed at Haney's first and foremost. The executive, you referenced that the budget could reduce funding to hospitals and nursing homes by almost $1.3 billion. The executive is suggesting that there are greater investments. Can you explain your concerns? And this is my main question, so take all the time you need.
Sure. I think the commissioner said that that they have invested $984 million. That's actually a cut from previous years. And I think that's part of the $1.3 billion total that we believe is a cut in this budget. As Ken was saying, it's a step backward. It's the $200 million in long-term care spending, the $200 million in Medicaid. You gross that up to add the loss of federal matching funds. That's $800 million, and then you take the reduction in VAPAP spending. They diverted half to go into the 1115 waiver and get matched. Then they put the other 275 back into the general fund, and so that totals the cut to hospitals.
Okay, and what's the impact of a cut like that on the ground? How would that impact the average nursing home or hospital that you represent?
Well, no margin, no mission, right? And I think that the ability now, we have 5,600 fewer nursing home beds than we did in 2019. That is in large part due to the inability for not-for-profit nursing homes to be able to hire workers, and with the current reimbursement rate, actually have a margin. So the cut just makes that harder.
All right, great. Thank you very much. And that's it for me, Chairwoman.
Thank you. Thank you very much. The next is Pam Helming.
Thank you. I want to say thank you to our panelists for your testimony today. And George, if it's okay, sir, I want to give you a special thank you for your passion. And I want to ask you to consider adding on what people in my district, which is primarily rural, what they're facing, the challenges they're facing, because it's very similar to what you have shared. We don't have urgent care centers in many areas of my district. We don't have primary care physicians in some of our areas. As a matter of fact, this past summer, right before school was going to start, in Naples, New York, the only primary care physician they had lost his position. Our kids trying to get immunizations to start school, there was no one to help with that. High school kids who wanted to play sports, there was no one to do those mandated physicals. People who needed heart medications, who needed diabetes treatments, there was no one there to help them. In addition, our federally qualified healthcare centers, they're cutting hours, they're cutting services because they can't make it work financially because of the reimbursement rates. And our emergency rooms, which we don't have hospitals in every county, but the ones we do, some of them are saying, don't come here. We're full. We can't take anyone. So we're in just a dire position as the communities that you talked about. So feel free to add us to your conversations that you're having. Just wanted to turn for a moment. I have to say, for me personally, the last panel that we had when we asked questions about the budget and what's in there to right the ship, to turn things around so people could get access to the life-saving treatments and the care that they need, I didn't have a whole lot of confidence that there was anything that was truly meaningful. There are some good workforce development initiatives, but they're going to take a long time for us to get there. One of the assemblywomen asked the commissioner about what's in the budget to save our hospitals and our nursing homes. And what I took away from that is that we're going to save money with the workforce proposals. But again, that's going to take time. I just am looking for, from the three of you, any of you, in your opinion, is this really going to save our hospitals? Like, what can we do right now? Because sometimes I feel like in Albany, we use the word crisis too much, but it is a crisis. What are we going to do? What can we do?
It absolutely is a crisis. And when I speak of the black and brown community, I say the low income and black and brown community. And so I feel your pain. I understand what that feels like. Everyone deserves good quality health care. And to begin, it's not hard math to say we're going to pay 100% of care. How is an institution supposed to survive when they provide care and there's a 30% deduction for that cost of care? How are they supposed to provide good quality care, no matter where they are?
Thank you. Next up, Assembly.
Assemblymember Hunter.
Good afternoon. I'm going to follow up on the question that I had made to the commissioner that I don't feel was answered. And so specifically, I painted a picture of what it looks like where I live in central New York with the hospitals that represent my community. And I do have a safety net hospital that it is abysmal, how long people wait. And it is true that people are not getting the care that they need. Right. And I understand that we are in the staffing crisis, and it is a crisis. We can keep saying the word because we need to keep saying it because it's real. But knowing that we have these traveling nurses and they're talking about this expense, but they can't get rid of them because there are no backfill of staff on hand. So aside from staffing, because it really means that a hospital has to go bankrupt in order for the department to come in, and then they say, give us your books and we're going to cut spending. So until you get to the point, and I have a nursing home with 2 days cash on hand, I need specifics. Give me something specific other than staffing that says, if we cut X, this will save a hospital money, and P.S., main point, not cut quality of care. Give me some examples, please.
I can't give you a late example, except I could tell you that if you adopt this budget, it's going to get worse. And I'll tell you why it's going to. If you take a look at the budget that was presented by the governor, if you take a look at it, when they got into the healthcare section, it happens to be in one of our figures on page 4, I believe, of our testimony, but it's irrelevant. What you'll see is unmet need in the governor's budget actually increased this year. So the safety net money that you need is actually decreasing relative to.
But we keep hearing the conversation.
But they're
of
not
cutting
doing it.
We keep hearing the conversation of cutting spending, and they will come if you get into dire enough shape. They will come, they will open your books, and they will say, this is where you need to cut. And I would like to know in advance, before they come, before we are indigent, before we are in a situation where somebody has to stay 8 hours in a hallway, 10 hours in a hallway, or not even get care at all, what can a hospital do today in order to stop or put a a little bandage on this crisis that we're in right
The
now.
degradation of services, member of the assembly, is really what you're crying for. You're saying, what can we do? And what George and I were saying, and we're pleading with you, look, we're hitting the wall. We are hitting the wall. But it's now time that we can actually do something about it. Let's set some high-minded goals for a change. Let's don't deal with the band-aids that you're talking about. Let's deal with tackling the root cause of this problem. And we know what it is. And all we're doing is asking you to help us on that journey. That's all we're asking you to do. So let's work together. I'd love to work with you, and George would as well, and B as well. We look at we're the same people.
Ken, I'm going to cut
one
you
day
off
one
just
day
so-
we're going to be patients.
Thank you. We get your point, but we're going to let another question be asked. Okay? Senator Webb.
Yelling at me.
Thank you. Thank you, everyone on the panel, for being here. My question is for you, George. In looking at your testimony, one of the things I wanted to lift up is the proposed COLA for health and human service workers, and I know this was something that all of us in the legislature was pushing for more in last year's budget, and now what's been proposed in this budget is 1.5. And so I know in your testimony you lifted up that we need to be at 3.2% to match inflation. Could you expound upon what people are experiencing from what we did last year to this year as it pertains to this?
Yeah, one of the things that we said was, well, let me go back. The governor, when I met with her and said, I want to hear it from you before I put it out there. Is there really a $1.87 billion surplus? And she acknowledged that there was. And she said, but I want to save that for a rainy day. Those were her words, not mine. I said, I don't know what community you live in, but where I live in, it's a hurricane. It's not a rainy day out there. We said if that budget goes through, that hospitals will close. Well, Beth Israel is now closing. We've seen Kings
Downstate.
and in Brooklyn again, and part of One Brooklyn Health System, Kingsbrook. We've seen these hospitals have closed as predicted, and it's only going to get worse. That's the problem, and we're taking a situation. I'm highly offended because I've never imagined any governor would see that health care deserves to be cut for a rainy day. If you ask me what the consequences are, human lives. Maybe human lives that are not as valuable to some as others. And I'm not going to sit here. Listen, the first 9 years of my life, I was legally treated as a second-class citizen. That's something you don't forget ever in your life again. And for here in 2024, I have to believe that my 5 grandchildren may be treated the same way. I'm going to do all that I can to get the elected officials that understands what this is going through and how cruel and how inhuman it is. So what are we? 70% human? Is that what it is? Because that's all you're willing to pay for our care. And we are going to really sit around, and I'm appealing to all people of good nature. This is not right. And I can tell you right now,
No, I think I'm next.
if I have to lay down in the middle of the street until the cows come home, I guess.
Thank you.
I'm willing to do whatever is necessary because the lives are at stake here. This is not an academic, debate here.
Thank you. Next is Assemblymember Latrice Walker.
Good afternoon. I've heard a lot today about workforce development. And one of the things that I remembered about the federal Medicaid waiver is that there are significant dollars which get spent towards workforce development. Of the $7.5 billion in the present Medicaid waiver, how much of that is being dedicated to workforce development?
I think it's about 700 million. I want to say 684, but I would have to check.
Okay, thank you. Now, with respect to the closure of hospitals, whether they be safety net hospitals such as those in One Brooklyn Health or downstate hospital, do you know how much of those resources will be going to these types of safety net hospitals?
The allocation of that, there's five. Let me set the stage for you, please. There's $550 million that are available for safety net funding, and it is available, but given the varying criteria, to basically 4 downstate counties, and that would be Bronx, Brooklyn, Queens, and Westchester. Interestingly enough. Yeah, so as a significant player in an important part of the healthcare community in Brooklyn, One Brooklyn would be part of it, be part of that allocation. But herein lies the part of the difficulty, if I can add. You will see in this budget last year's commitment for safety net hospitals of $500 million was taken away.
Yep.
So here's what you got, and this is why I say this budget stinks. You put in 550 from the federal government, and then you take away 500. So you tell me what the number is going to be. Beats the hell out of me. I don't know.
Well, sounds like the old bait and switch. Secondly, I would also add that we should look at the Medicaid reimbursement rate as a public health crisis, and call it for what it is.
That's right.
And lastly, I just would like to say, is there any sort of conversation with respect to workforce housing as a part of sort of workforce development resources from your conversations with the second floor?
I'm not aware of any. I do know that many hospitals actually do have engaged in providing housing for their healthcare workers.
But part of the waiver is to address some of that issue, the social needs, and how much of that could be diverted is not answerable by us.
No.
But I do believe that there is some attention to that within this waiver.
Thank you.
Thank you, Senator Gustavo Rivera.
Thank you. Hey, folks. It's good to see you.
For 10 minutes. 10 minutes. Thank you.
Dang. I already spoke 46 seconds. Okay, I'm sorry.
I don't know.
All right. Thank you for being here today. First of all, just for the record, it's a battle that many of us have been waging for quite a long time. The notion that those institutions that serve the most vulnerable are the ones that are the least funded has always been the case, certainly for as long as I've been here. And I'm very glad to see that we're stating it clearly, and that we're talking about the impact that it is having on real people every single day. I'll also underline the utter frustration that Assemblymember Hunter was expressing earlier, which I share because so I've been here. Okay, somebody's phone. So I've been here for 13 years. I've been the chair for 6, I believe.
Yeah.
And I have consistently gotten calls from hospitals, like on a rotating basis, on a rolling basis. It always happens when they go like, hey, just so you know, we're 6 months out from being in the red, or a couple of months out from being in the red. And this is not something that is a surprise to the state, right? And so it seems to me, this is directly to Assemblymember Hunter, just to kind of let you know, it seems to me very clearly that the way that this has been, okay, so I do get 3. Okay, what have you? I'll make it quickly because I do want to ask you one question about the unallocated cuts. But just to state it for the record, the state unfortunately seems to operate the way that they do this is that they just let it happen. They don't commit to long-term investments Instead, they just figure that they're going to have expenditures eventually, and they're going to fall off the cliff. We're about to fall off the cliff, then we'll bring you back. And I'll just say, and obviously you can provide all sorts of evidence, and all my colleagues can do the same. And I'm telling the state, whomever might listen, whether it's the folks who are here or the governor on the second floor, folks, this is not the way to run a healthcare system. Please, we have to talk about how these places stabilize themselves. I'm not even talking about thriving. I'm talking about being able to stabilize themselves. And if you pay them accordingly to what they actually do on a daily basis, they can actually stabilize themselves. The one question I have for you folks, since I have so little time, have you ever seen this whole unallocated cuts thing? This notion, and I was kind of doing a little joke earlier, but this notion that they're asking you to choose which limb you're going to cut off, and it's because you're getting help. You're saying, well, we both cut it off at the same time, so it hurts less. Have you ever heard of that, and what is your sense about what that actually means?
Well, I think they're buying time. So, yes, I have heard of it, and I think that they haven't yet figured that out, and maybe hoping they're going to get some wisdom from the One House budgets coming back from you.
It's sometimes the answer is right under your nose. And we live in a very complicated healthcare system, but George and I wanted to make this as clear as possible. The solution is right before you. Let's pay the cost of the care and stop fooling around. That's all we're asking for. Pay the price of the care that we presented.
Thank
a
you.
lot of your problems will go away.
Assemblymember Ed Robb for 3 minutes. We all get 3 minutes. Rules change.
Thank you, Madam Chair. For Haney's, I was just looking through testimony you submitted, and part of it has, this chart in particular gets into as one of the global concerns, capital funding, and in particular, the lack of any new capital funding in this budget for healthcare providers. Just wondering if you can comment on that and how large the need really is out there for new capital dollars.
Sure, the need is enormous. I think all of you understand that healthcare is evolving as we speak, becoming decentralized. People are getting healthcare on their phones. They want healthcare in their community, and those capital dollars are essential as we decentralize from an enterprise system that really is focused on inpatient to having care out in the community. In addition, if you understand that patient care drives everything, and as we think about our aging population, we have a population that is going to need more cancer care. They're going to need more care for neurodegenerative conditions and as such. And those types of outpatient facilities are actually very resource intensive for both drugs and equipment to care for patients with chronic needs. So every hospital has a need for capital, and cutting capital is a step backwards.
Thank you. Good.
Actually, Senator Webb. And I apologize having to run out. Chairs still get 10 minutes. Oh, you already went?
Yeah, it's May.
Then Senator May.
Yeah.
Thank you.
Thank you. Yeah. Hi, everybody. And I'm sorry I missed your testimony. I just came for the questions, but I asked the commissioner this morning about the
chart said
cuts to long-term care. Like how many beds are we going to lose? How many facilities may have to close down? I didn't really get an answer, but I guess I want to ask you all about the jobs and what is the impact, do you think, on jobs in that sector from the cuts that we're seeing in this budget?
Oh, sure. It's getting more difficult. As I said before, there are 5,600 fewer nursing home beds today than there were in 2019. And I think without an investment in nursing home care and without a reset on the regulations and the administrative requirements and fines, it is going to be extremely difficult for nursing homes to stand up operations and keep those operations up. So it's going to get worse unless action is taken now.
And Are you all tracking the impact on regional economies of this kind of deficit that we're running in critical facilities like this?
No, well, I mean, I think you're obviously already paying attention to that. Healthcare is 20% of the economy, and I think an anchor to every community is healthcare. And I know that without good healthcare, you do not have businesses wanting to come in and invest in those geographic areas. So, and that's particularly, as you know, very, very prevalent in upstate New York.
Right. And if there aren't the facilities, then families are stuck with doing the care a lot of the time for especially older people, and may have to bow out of the workforce.
Senator, if I could just add, unless George, you want to add something?
Yeah,
I'll defer to George first.
Not only does it affect the economy, I've said this to every governor that I've worked with. Healthcare to New York is like the auto industry was to Michigan. If we continue to allow these hospitals to fail, not only are we going to lose the economy that it brings in, but we're going to lose the surgeons that people travel from all around the world to come and get the care of New York. And they're not going to stay with a sinking ship. Their skills are not comparable out there in the medical field. And they'll leave and they'll go to Cleveland Clinic. They'll go to anywhere where they can continue a robust practice. So we have a lot to lose, and it's beyond comparison.
Thank you.
Thank you.
Yeah,
Thank you.
You're welcome.
Ed, did you go? Yeah. Okay. Jessica Gonzalez Rojas.
These buttons are tricky. Thank you all for being here. I am curious if the cost to emergency Medicaid also experiences this 30% cap. Do you know the state spends about $500 million in emergency Medicaid for a community that could be covered by the 1332 waiver and use federal funds to cover their health care?
The whole healthcare community supports any opportunity we have to make sure that the burden of healthcare is picked up appropriately by the federal government. And it's interesting. If I can go back to our proposal, George's and my proposal as it relates to closing the gap, on the hospital side of things, the feds now pay close to 60% of the bill. So the investment that you make is leveraged by the federal government by a multiple, which is really significant. I think that should be part of the calculus that you look at as you entertain development of adopting our proposal within this budget. The federal money that is leveraged is high. And that is not true on the nursing home side of things. There it's back to 50-50, but the investment on the hospital side is significant, if that gets at some of the questions.
Thank you so much. And George, for you, I just want to thank you and your union. My mom is 1199, now a retiree. But I want you to elucidate what the inequity in Medicare cost and coverage, that 30% gap, what does that mean for our both current workers and future workers in the industry?
Well, what it means is that we're going to have a loss of jobs. A loss of jobs as the hospital cut services. Those services were operated by staff. Cutting services is cutting staff. It's cutting health to the community, where the community may have been able to walk up to a clinic and get health care. Now they can't. For example, me, I didn't grow up wealthy. I grew up very poor. And so I was raised by Jacobi Hospital in the Bronx. But my mother could take me there for clinic appointments. That don't exist in a lot of safety net institutions. Until you're ill enough to go to the emergency room, you are out of luck. I want to apologize too because you may see me screaming around here. It's not that I want to punch somebody, it's that I am suffering. If anybody ever suffered through sciatica, I'm having a super attack right now. But even sciatica was not bad enough to stop me from coming here because I can't look at my members, I can't look at my community and say that I did all that I could because I let a sciatic pain get in the way of me begging you. I'm willing to beg.
George, I'm sorry I have to cut you off.
Thank you.
I'm sorry you have to cut me off too.
I know. We can agree on that. Summer Brook.
Thank you so much, and thank you all for being here today. I just want to start where we just cut off George to say, I think both today and throughout the year, you and your members do such a good job to describe both passionately but also very effectively the realities of our healthcare system. And where I am in Rochester, I say if you've had a procedure, if you stepped into a hospital or most healthcare facilities, think 1199 member because the only way that gets done is with you all. And so really this is for the whole panel, whoever wants to jump in. But when we spoke with the commissioner and the Medicaid director earlier today, I described to them the fact that one of our hospitals in Rochester saw the most patients they ever have in history the other day, in one day. And that they had over 100 people who were ready to be discharged but could not be because there were not enough nursing home beds. And so we are in a crisis situation, there's no question, and especially where we are. And I couldn't agree more. We need to be increasing our Medicaid rates. I think, that's been a theme for some of today. But what I find troubling is that often what we're told by agency, by DOH, by Medicaid office, is that really the onus is on you all. You need to make the cuts. You need to figure out how you're going to recruit. And so I'd love to give, I guess, a minute and 25 seconds or so to share some of the things you are doing, because I think you are working within the system you have the best you can, whether it's about recruitment, whether it's about, locally, University of Rochester has free tuition for a nursing accelerator program. But I know that there's things that are happening, and I think we all need to get a holistic view of the fact that you are implementing many of these things, but that it's still not enough. But what small successes have you seen?
Sure. I think University of Rochester, we've been working with them for years, and certainly well aware how challenging both it is for UR and Rochester Regional in that particular area. They are doing everything possible. Rochester really leads the country and has for decades in terms of their ability and their infrastructure to work with other community providers to make sure that there is capacity both pre-hospital and post-hospital. So they're doing all of the right things. I think the challenge that they face is that the demand of patients who are coming into their emergency room is continuing to increase with an aging population, and then in particular the nursing home shortage in the Rochester area and Western New York is particularly severe. I think about 2,000 of those 5,600 beds that I was talking about is in that Rochester area. So there's a real lack of capacity, and they can't just materialize that capacity overnight.
So before I continue, Assembly Member Meeks, welcome. Joanne Simon is next. She's not. Oh, here she is.
I'm doing it. Yeah, okay.
Okay. Yeah. Hard button.
We have these new microphones, and they're sticky. So, thank you for your testimony and for identifying some issues. I have a couple of questions that I'd like to ask. Do you have a sense of the difference in the impact of the failure to increase the Medicaid reimbursement rate? The difference, how it impacts for-profit versus not-for-profit nursing homes. Because we're losing our not-for-profit nursing homes, and I know mine is really struggling mightily. And then the issue about this failure to address the wage parity issue in a constructive way could end up actually leading to more people needing nursing home care because the CDPAP program, if they're not able to have people actually working in that program, it's going to lead to more need for more admissions. And then also, if you have data on the deterioration of physical plants, we hear that because there's been no money, hospitals aren't able to invest. This primarily affects the safety net hospitals and how that exacerbates that situation. If you have a sense of that, I'd appreciate it.
I'll start with the last question first. I think the capital needs for safety net hospitals are, I would say, both longer standing and deeper. I think they need new boilers. They need, they need a new water system. So they need more basic infrastructure upgrades, I think, than other facilities. So it's not just building a new outpatient wing, for example, or outpatient clinic. So I think it's a lot more basic needs on top of trying to modernize their facility to meet the needs of their community. I think on the nursing home issue, I would suggest talking to Jim Klein from Leading Age. I think they may have a better answer. I don't have the distinction between for-profit and not-for-profit.
Thank you.
Madam Chairman, can I make a comment, please? I want to say that at a recent board meeting at Greater New York Hospital Association, I turned to my chairman and I said, I want you to know that George Gresham is my personal hero. Ladies and gentlemen, as you could see that George is under a great deal of stress here, and I think maybe this matter should come to some sort of conclusion, because I love him dearly, and I don't want to see him going through this pain.
Just double checking on the assembly. I'm sorry, we're not over. There's no more senators to ask questions. Let me clarify. We're here, we're strong, we're not going anywhere. Thank you, Gustavo.
Assemblymember Khalil Anderson.
Thank you, Chair Paulin, and thank you to all of the panelists who are here today. I know I missed your testimony, but I do have some pointed questions to ask. Hopefully I have enough time to ask them. I mentioned to Commissioner McDonald earlier the piece of making sure that hospitals who are geographically isolated can benefit from some of the positive things that are in the governor's executive budget as it relates to the different pots of money, including the 1115 waiver. So I'm wondering if Greater Hospital Association can answer what resourcing those hospitals that are geographically isolated would look like.
I'm not sure I understand your question, to be honest. What research? What do you mean by geographically isolated?
So I gave earlier last year, Commissioner McDonald visited my district, and there's a hospital that is in my district that is far away from the mainland of Queens, and so I was wondering, when you have a type of hospital like that, there's a need for more resources for that hospital because it's serving a large region. So I'm wondering if, in these different pots of money that the governor has proposed, including the 1115 waiver, is there a way that would help move some of your member hospitals forward in that regard?
Yeah, I think normally geographic isolation is under federal law and state law is a factor. It's certainly a factor in certificate of need in terms of approving new services and new funding for services. So I think it's normally a factor. I'm not aware of anything in this budget that addresses the particular needs of geographically isolated hospitals.
Interesting. Okay. There might be a way.
I don't have anything more on that, though.
Okay. Next question really quickly. When we're dealing with the distressed hospital fund, I know that there was some money set aside for distressed hospitals, and through y'all's advocacy, we're seeing that slowly come to fruition. Is there an itemized list on what projects either were eligible or had moved forward from the first pot? And I think the second part of that question is this next cycle of money that's being papered over. I'm not sure if there's
Do you mean the transformation dollars, the capital dollars? Are you talking about the capital?
The capital distress funds, yeah.
So,
Do we know where that is?
There's a long queue. I don't know personally, but
The one thing that you should understand is there's $1.5 billion in the governor's own budget of unmet need. Unmet need. That's going to be distributed across all the communities, and that's going to show up in your doorstep.
thank you. And again, just thanking, as I close out in my last few seconds, I want to thank 1199 for their advocacy. George Grisham, it's good to see you here. And thank you for your members being so active on the issues.
Thank you very much. I think I'm the last one. I just have one question. Everybody's asked so many of the important questions. Thank you really for being here and for your advocacy. On the governor has proposal on medical debt. I wondered if you've had a chance to review it. And
We're evaluating it now. We don't have a position on it at this point. Obviously, we're very concerned about. Some of our hospitals actually go pretty far in the forgiveness of it, but we're Chairman Pollan, what we're trying to do is get a consensus out of the community. So I don't have an answer for you at this point, and probably within a week or two I will.
we'd want to specifically know any financial harm that might be done to any specific hospital vis-a-vis any specific one of the proposals.
Okay, well, I think we'll give you a written proposal that analysis that you could sink your teeth into.
I think we all have a desire to do something. So it would be great to see us all work together to make sure that we get something done at the end of the day. Thank you. With that, I think that's it.
Joining us today, panel.
Okay, well, thank you, and we need
appreciate it. Thank you. We're going to ask you to leave. Everyone take their conversations outside, and we're bring up the next panel, B, New York Health Foundation, Primary Care Development Corporation, and the Community Healthcare Association of New York State. George? I just called you George. Hey, David. Oh my God.
Thank you. Who wants to go first? Proceed.
Okay, thank you for the opportunity to testify. I'm David Sandman, President and CEO of the New York Health Foundation. We are a private, independent philanthropy dedicated to improving the health of all New Yorkers. I've submitted written testimony on two crucial primary care issues: rebalancing our healthcare spending to emphasize primary care and enhancing the role of medical assistants on primary care teams. So I'll just hit the key points here. I'd like you to imagine that you found a nickel on the floor this morning on your way here and ask you if you would stop to pick it up. And the answer is probably not. It's too small, it's too little, it's too insignificant. But that small amount is exactly how we value primary care. We only spend about 5 to 7 cents of every healthcare dollar on primary care. And that's despite the fact that primary care has the best return on investment of any type of healthcare service. There are mountains of evidence that tell us that. It's the rare win-win that's associated with both better health outcomes and lower costs. So New York should devote a greater share of total health spending to primary and preventive care. That does not require spending more. It requires spending in smarter and better ways. And New York is behind the nation. Primary care spending is less in New York than in the rest of the country, and it's been decreasing over the past 5 years. At least a dozen other states have rebalanced their healthcare spending to emphasize primary care. The legislature gets it. Here in New York, both houses previously passed bills to establish a primary care reform study commission, but they were vetoed by the governor, who asserted then that we already know we underspend on primary care. In this session, Senator Rivera, Assemblymember Paulin have each introduced bills to require healthcare plans and payers to gradually have a minimum of 12.5% of their total expenditures on physical and mental health annually be for primary care. Investing in primary care is the fundamental way to both improve health and save money. Workforce, we've talked about it a lot this morning. We can also improve primary care access and address workforce shortages by elevating the role of medical assistants, or MAs. MAs generally perform administrative and very limited clinical duties under the direction of a physician. But New York isn't making the most of MAs. For example, Connecticut, New Jersey, they allow MAs to administer vaccinations, and that's prohibited in New York. The proposed executive budget aims to bring us on par with other states, permitting MAs to administer vaccinations under the supervision of a clinician will make a big difference and free up other clinicians to practice at the time of their license.
Thank you very much.
Thank you.
Next.
Go ahead. Okay, that's a good follow-up. Thank you. Thank you very much to Senator Krueger, to Chair Paulin, and to Chair Rivera and the rest of the members of the committee for giving me the opportunity to testify today. My name is Jordan Goldberg, and I'm the Director of Policy at the Primary Care Development Corporation. We're a nonprofit that offers capital financing, expertise, and policy advocacy to expand access to primary care and advance health equity in the communities that need it the most. And I want to say we're very grateful for the legislature's support for both PCDC and primary care over the years. As we just heard, primary care is critical. It saves lives, it improves community and individual health. It's central to health equity, and it has the uniqueness of being both able to lower healthcare costs and decrease disparities. At the same time, it gets 5 to 7 cents on every healthcare dollar, which is less than half of what experts think it should. Many New Yorkers live in communities without adequate access to primary care as a result of this underinvestment. There are some proposals in the executive budget and the 1115 waiver that we think will help to some degree with some of these things. One particularly important proposal I wanted to draw attention to is the commitment New York State has made to increasing Medicaid rates to 80% of Medicare for primary care, behavioral health care, and obstetrics care. This is critical because research has shown that when you increase Medicaid rates, you expand access and you improve quality of care. The PCDC really wants to urge the legislature to ensure that those rate increases reach primary care providers, all primary care providers who see Medicaid patients, and that it actually gets to the practices as opposed to third parties or intermediaries. One of the other biggest obstacles to primary care in New York is the lack of access to providers. There's a shortage. We all know this. About 6.5 million New Yorkers live in areas where there is not enough primary care, and that's expected to grow in the next few years. About 50 years ago, 70% of physicians practiced in primary care. Now it's 30%. And more are leaving every day. They're overwhelmed with the administrative burdens and with not enough time to see their patients. And we have other healthcare workers in primary care leaving as well. There are a couple of workforce proposals in the budget and the 1115 waiver that are targeted to primary care providers who work with Medicaid patients. We support those. But we think that a more systemic answer is necessary. I think David already mentioned this. We think if New York State set a firm target of 12.5% spending on primary care out of total overall healthcare spending and held private and public payers to that target, we would improve situation in underserved populations. Thankfully, Assemblymember Paulin and Senator Rivera have introduced a bill that would do that, would require payers to measure their spending on primary care and increase it to 12.5% over time, rebalancing, not spending more. Finally, in my last few seconds, I just want to emphasize that PCDC is supportive of all efforts to expand access to insurance coverage, and particularly highlight the proposal to have continuous Medicaid coverage for 0 to 6. These are critical times in a child's life when they need ongoing preventative care that will impact their entire life. Thank you for your time.
Good afternoon. I'm Rose Duhan. I'm the CEO of the Community Healthcare Association of New York State. We are the statewide association for community health centers, representing 75 member organizations that serve 2.3 million New Yorkers at over 800 sites statewide. On behalf of our members, I want to express gratitude to the legislature for its unwavering support last year to ensure health center patients were protected from significant loss of access to services that would have resulted from the elimination of the 340B drug discount savings when the pharmacy benefit was carved out of Medicaid managed care. We understand funding is included in the governor's proposed budget, and we ask the legislature to continue to champion health centers by ensuring the inclusion of this critical funding. The 340B funding restoration protected community health centers from what would have been a devastating loss of funding on top of Medicaid reimbursement rates that have long been inadequate to cover the costs of care delivery. As a down payment towards needed investment in health centers, we are requesting an increase in health center Medicaid rates in this year's budget. Health centers have not had a significant investment in their Medicaid rates since the payment methodology was developed over 20 years ago, longer than any other provider type. We ask that you insert the language in Senator Rivera's bill, S. 6959, and Assemblywoman Paulin's bill, 7560, into your budget legislation to update health center reimbursement rates and reflect current costs so that community health centers can meet the demands of today's care models and emerging public health crises. We are grateful Senator Rivera's bill was reported out of the Health Committee yesterday. Chicandy's further requests the legislature make permanent Medicaid telehealth payment authorization and make a technical amendment to existing statute. Under current rules, Medicaid pays health centers only 1/3 of the in-person reimbursement rate when providers and patients are both outside of the health center walls for a telehealth visit. Because of this, health centers are at a competitive disadvantage in recruiting workforce, particularly for behavioral health providers that can work fully remotely in Article 31 and 32 licensed facilities. We ask the legislature to include Assembly 7316 and Senate 6733 in the final budget, which would make the necessary technical correction. Chicandy supports the governor's scope of practice reforms and has been mentioned already, specifically the governor's proposal to allow providers to direct and oversee medical assistants as vaccinators. Doing so will ensure health center care teams can work at the top of their licenses and training while expanding access to needed vaccines, which will keep New Yorkers protected and advance the state's public health goals. I refer you to our written testimony for further details and additional comments. Thank you for your time, and I'm happy to answer any questions.
Oh no, you said you're good. I'm so
Thank you.
sorry, I misunderstood.
We're all good.
Anybody questions?
You have a question? All right. Assemblymember Jensen.
I gotta use my muscles. There we go. So when we talk about community health, and I asked a question earlier of the health commissioner and the Medicaid director about Medicaid reimbursement rates for different areas of medical practice, and certainly when you look at dental health in our state, how critically important is the state in prioritizing coverage and proper reimbursement rates across the state to ensure that regardless of urban, suburban, rural, New Yorkers are actually getting the care they need across the continuum of care to ensure that we have healthy communities moving forward?
Yeah, coverage for everyone is critical in terms of ensuring access, and it's also critical for providers in terms of ensuring that there's in terms of ensuring their financial sustainability. So something that we are certainly very supportive of is expansions of coverage.
Okay. And is that when you're looking at that expansion of coverage and certainly looking at not necessarily having the state pick up the entirety of that cost, but just making sure that we have the access and provider base, correct?
I believe you started off with oral health care.
Yep.
That one of the most serious shortages that we have. I mean, there are counties where there are virtually no dentists who accept Medicaid, especially pediatric dentists, which hasn't really been talked about today. There's actually been a new settlement that expands coverage for dental services like bridges and dentures and other interventional dentists. The problem is we have no dentists to provide those services to Medicaid beneficiaries.
So I guess and maybe this isn't your area of expertise, and I apologize. if it's not. But when we talk about that, when we talk about areas of the state where we don't have practitioners, whatever the case may be, I guess from your perspective, whether it's primary care physicians or other community health providers, I mean, guess what is the solution that we're working with right now for those communities?
I would look at some broad public health interventions, such as fluoride, hailed as one of the most important public health interventions, over the last century by the CDC. Yet there are still counties in New York State that lack fluoride. And if you look at a map of Medicaid expenditures on dental care in counties with fluoride and those without, there's a huge gap there.
Okay.
And I would say that the workforce initiatives that the department is seeking are really important in terms of expanding that workforce to make sure that there are healthcare providers that can provide care across the state. As has been mentioned, there's a severe shortage of dentists, but as has also been mentioned, we've seen fewer and fewer people going into primary care, and so that really impacts access. When there's no providers, it doesn't matter what you pay them. So we really want to make sure that there's programs that are encouraging people to go into primary care, that are encouraging people to go into community dentistry, so that there's a sufficient workforce.
Thank you.
Senator Rachel May.
Thank you, and thank you for your testimony. I don't know if this question is actually applicable, but I'm very interested in school-based health centers and community schools, and I'm wondering, are any of your organizations involved in that, and what can we do through the budget or through legislation to make them stronger?
Yes, absolutely. School-based health centers, most of our community health centers also operate school-based health centers, and it's a critical source, a critical point of access to care for children that would otherwise not be able to perhaps see a provider, have their dental care needs met, have their mental health needs met. So they're incredibly important in terms of the role that they play in the healthcare system. Continuing support for school-based health centers is essential. We're pleased to see that there is some expansion of support for school-based health centers, and we certainly support that.
And if I could just add that support for primary care across the board would also support the ability of school-based health centers to get the providers that they need and to be able to treat the patients and the kids that they see. Because the part of the shortage problem that we're having is people just won't go into primary care anymore because of the burden on them, because of the insufficient pay, because of all the other issues. And so even if you have a school-based health center, if you can't staff it properly, it's not going to be able to support the schools.
So are there ways to, say, raise the pay for primary care doctors so more people will go into that profession? Is that something you're thinking about?
What we believe is the proposal that Assemblywoman Pollen and Senator Rivera have offered, Assembly Bill 8592, Senate Bill 1197 that you passed out of committee yesterday,
right.
It's going to have an impact over time. It's not going to happen immediately. But part of it's been attrition over time as well, as people have left the profession. We need to attract people by showing them that the state, that governments care about primary care and are willing to put the money there.
Certainly in terms of the community health centers, having Medicaid rates be sufficient to be able to attract and retain workforce really makes a difference in making those providers available in community settings.
And then I know there's at least one school in Syracuse that has a health center that's not just for the kids, it's for the families as well. And I'm wondering if people are tracking the impact of those kinds of innovations to make sure that they're having the kind of impact we hope they will.
Yeah, that's a good question. We don't have the data on those community-based schools, and it's something that we could look into, although the department may have some more information.
Thank you.
There's going to be a joke made about these things. Assemblymember Forrest.
Thank you so much for your testimonies. As an ambulatory care nurse, I understand I've seen in my own experience the closure of diabetic clinics and then replacements with bariatric surgical centers, right? I've seen people go to ED and spend 8 hours there and then get the Band-Aid only to wait 3 months out. When the last time I was in the hospital, I had to wait from July to October to see a specialist for the care that I needed. What are some of the suggestions you have on prioritizing primary care. I mean, the cost savings are enormous. Bariatric surgery or diabetic clinic to help you. I think it's quite clear to me as the health practitioner where the savings are, but can you paint it for us as legislators what that could look like?
Yeah, absolutely. We agree 100% that it's a much smarter investment to pay for prevention upfront and to pay for care management so that people are able to remain healthy so that we can avoid that expensive emergency room diversion, and making sure that there's that investment in primary care is really critical, making sure that there's the workforce so that when people come for care, there's providers that can see them.
Diabetes is a manageable chronic disease that, if properly managed, should never result in an emergency department visit or an admission. So we have to look at primary health care, and we also have to look at the behavioral aspects. Access to an affordable, appropriate, nutritious diet, promoting food as medicine programs, promoting opportunities for physical activity are equally important to managing your diabetes as being in a clinic.
And, just to say, the days that I spend in the ICU bringing down a patient's blood sugar level, when that could be easily dealt at home by just taking the insulin and going to the doctor every, 3 months or so? But that DKA patient costs thousands of dollars in the ICU setting.
And
blindness, amputations, and worse.
And I would just add, PCDC is a community development entity, and one of the things we do is invest in creating new points of primary care access. And one of the problems in a lot of places in the state is there's no place to go. There's one clinic. It's very far away. And so one of the things, this is a little bit to the side, but one of the things that we've encouraged is to use more of the healthcare transformation funds for primary care. They were not earmarked for primary care last year, and that could be something that the legislature could look at for this year.
Thank you so much.
Senate.
Thank you, Senator Krueger. Thank you for your testimony this afternoon. I apologize because I wasn't here for the very beginning, so if you already spoke about this, please cut me a little slack. But one of the things that I've heard from one of my federally qualified health centers is that in the governor's proposed budget, there is an expansion of the billable providers, but that expansion, which would include doulas, community health workers, certified substance use counselors, and peer workers, isn't extended to the community health centers. Do you have any information on that or any thoughts on it?
Yes, that's correct. Given the way that community health centers are paid, there are certain billable providers, and so even if health centers were to hire doulas and community health workers, which many health centers have, there's no additional reimbursement for those services. So really wanting to look at how can we make sure that those services are really adequately reimbursed to ensure that there is the ability for health centers to financially sustain those services and to make sure that there's access for patients.
So that would be part of your advocacy to have that included in the budget?
Yes, absolutely.
Okay. Thank you. And then the conversation about how do we attract more primary care physicians. Maybe you heard me speak earlier about, big topic of discussion in our rural areas. In the budget proposal, I've noticed that there is the primary care medical malpractice section. And the way I interpret it, and I think based on information I got this morning during the hearing, it's going to increase the cost of malpractice insurance for primary care physicians who already pay more than anyone else in this nation. I think the statistic I read was that we pay 68% more than the second state, which is Pennsylvania. So given that, what are your thoughts on increasing insurance costs to primary care physicians? Is that going to help us attract more or detract?
Health centers have certainly seen increases in costs across the board in a number of areas, and that's one of the challenges that they have in terms of rates that haven't increased over time. That pertains to workforce labor costs that have increased and other administrative costs. So that is certainly a challenge. I'm not familiar with that specific proposal, so I'd have to get back to you.
Okay, thank you. And just real quick, I'll toss this out there. We've talked about a lot of the great scope of practice. Changes that are in the budget, workforce development initiatives that are all great things, but to me they're long term and we need some short term solutions. But one of the things I don't think I saw in the budget was anything about expanding the scope for mental health care providers, which I think is a big concern. Do you have any thoughts on that?
We certainly want to make sure that there's access to behavioral health providers in the community, and something that health centers have struggled with a bit. As I mentioned, in terms of the telehealth fix, we're looking to ensure that there is access to behavioral health in health centers through telehealth.
Thank you. Assemblymember Gonzalez Rojas.
A challenge.
Oh, again. Okay. Thank you, Zomer. Thank you so much. This question is for Rose at the Community Health Care Association of New York State. So, faculty at both Rutgers and Columbia University published a recent study of about 45,000 individuals that suggests that providing insurance to immigrants costs the healthcare system approximately $3,800 per person per year, which is less than one half of the corresponding costs for U.S. born adults, which is estimated to be about $9,428 per person per year. Can you tell us more about the benefits of the state providing this coverage? I know the community health centers are the one often absorbing the communities that are uninsured. So can you talk a little bit about that?
Yes, absolutely. As you noted, community health centers provide care regardless of people's insurance coverage or ability to pay. So when people show up who are uninsured, health centers are going to provide care, and they have to financially ensure that they can cover those costs. The expanding coverage, we absolutely support expanding coverage to all New Yorkers, regardless of their regardless of their status. And it's a big, as was noted earlier, insurance coverage is a huge indicator of access. Health centers, especially in certain areas, have seen a huge influx of migrants, people who've come up from Texas and from crossing the border. And as was mentioned earlier, people have different status in terms of what they're eligible for, but for the most part, those individuals do not have coverage, and they have experienced significant trauma. They have significant needs. Many people have not ever seen a doctor or a provider or nurse practitioner, and so there's a lot of needs that they have. Significant mental health needs, and in terms of children, providing vaccines, making sure they're ready for school. So it's incredibly important that they can get access to care. Thank you.
Thank you so much.
I'm going to get us all those little balls that help strengthen your hands for the budget hearings. Sorry. So this question, a variation was asked. So since people don't want to seem to go into primary care medicine for a variety of reasons, do you think we should be expanding the scope of practice for physician's assistants and nurse practitioners to be able to ensure that they're both trained and licensed correctly to provide primary care in settings where they really don't have the doctors?
And we believe anything that's going to expand the primary care workforce, we support, because the workforce shortage is so critical. We would like to see more enhancement of primary care physicians. We also think that physicians' assistants can serve at the top of their scope, and nurse practitioners have been incredibly valuable at health centers, so we would certainly support those.
Yeah, I would add, I don't think that they're substitutes for physicians, but everybody supports the notion that everybody should practice at the top of their license. Doctors should do what only doctors are trained and ready to do. Nurses should do what only nurses are trained and ready to do. The same for PAs, the same for medical assistants, of course. Provider after provider in the field has said if the medical assistants could have just done immunizations, vaccines during COVID, it would have been a lifesaver. I had my director of nursing doing vaccines all day. That's not the best or appropriate use of my director of nursing. This is scope of practice has historically been a third rail issue here in Albany, but
Yes.
a crisis is a bad thing to waste, and I think there's a receptivity, to visiting those issues, and there are some very intriguing proposals in the budget this year.
But I would also just add that almost all primary care providers, whether there are PAs, NPs, physicians, RNs, they're all burnt out because the structure of the system is not supporting them. And what we really need is to rebalance the way we're paying for the care so we can have full teams with community health workers, with medical assistants who can do things like vaccines, but also with care coordinators, which you can't pay for the way that we pay for primary care today. If we move towards value-based payment and we had team-based care, all of the people who are providing the care would be less under stress. So I worry that if we just point to a scope of practice and think that it's just a solution to just add more of one kind of provider, we're missing the picture that the whole system is under too much stress.
And yet the shortage of people to work in the system certainly adds to the stress. And I think I heard the answer before. People just don't want to even go into primary care medicine, although I think the medical schools will be testifying later. And I believe at least one or two of the medical schools downstate had said they were opening up separate medical schools with a shorter time frame specifically for primary care doctors. Do you know whether any of those got off the ground?
I don't actually know. I'd love to find out more, though.
Okay, stick around because they'll be on another panel. Okay, thank you very much. Anyone else?
Just me. Just one quick question to Rose. The capital needs of the community health centers, neighborhood health centers. Talk about that. Talk about what's in the budget, what's not in the budget, what the needs are out there, and what you're seeing.
Sure, significant capital needs. Many aging facilities in terms of needed investment in IT and other kinds of technology. The significant infrastructure needs, as Jordan said, we would love to see a set aside in future capital or in current capital allocations for set aside for community health. That was not in the most recent appropriation of that. But it's really a need that we see in terms of health centers wanting to expand. They know that there's more need out there than they're meeting now, and a lot of health centers are looking at some places where there are some primary care deserts and looking to expand, but that capital need is critical to make sure they can build those facilities.
Thank you. That's it.
Well, then, thank you very much for your time and your testimony today. Appreciated.
Thank you.
Thank you. And as
Panel C.
Yes, Panel C for people who are following along with their TV guide sheet. The New York Health Plan Association, the New York State Coalition of Public Health Plans, and Healthcare for All New York. Oh yeah, we have those ropes making it an extra challenge. Sorry about that. And I feel that many people did take me up on my earlier statement that if you really need to get on a train and not stay here all night, you should just let us know, and we have your testimony. Or maybe just everybody's taking a break outside. Okay, shall we start with Eric Linzer, then go to Aaron Drinkwater, then to Mia Wagner? Okay.
Great.
Good.
Thank you. Thank you for the opportunity to testify on several provisions related to healthcare and the proposed FY25 executive budget. I'm Eric Linzer, President and CEO of the New York Health Plan Association. I'd like to highlight 3 items from our written testimony. First, our opposition to the health plan rate cuts in Part H. Second, our request to restore the funding for the Medicaid Quality Incentive Program that the executive eliminated. And third, our opposition to the Medicaid managed care procurement in Part H. With regard to the health plan cut, Part H of the executive budget includes a provision to eliminate the 1% across-the-board administrative rate increase provided to Medicaid managed care plans in the current year. This would result in a cut to plan rates of more than $400 million in the upcoming fiscal year. And while we recognize that the budget challenges facing the state are significant, this is a significant cut that will make it more difficult for plans to make the investments necessary to fulfill the goals envisioned in the recently approved 1115 waiver that was discussed earlier today. Next, the executive budget would completely eliminate the quality incentive funding, totaling more than $223 million. The QI program is an essential tool in advancing quality for New York and Medicaid. Health plans only receive this funding for achieving results that meet or exceed state metrics, and the funding helps to support a broad range of programs that health plans partner with providers and community organizations to improve health outcomes for underserved populations. Combined, these cuts total over $600 million and run counter to the efforts to advance health equity, reduce health disparities, and enhance coordination in New York, and we urge you to restore these cuts. With regard to the managed Medicaid procurement in Part H, this would direct the Department of Health to choose no fewer than 2 plans per product line in each region with an effective date of October 1st of next year. This will effectively result in the elimination of health plans from the program, taking away options and disrupting provider relationships for more than 5 million New Yorkers who rely on these plans for their care. And many of these individuals have multiple health conditions that require coordination of numerous services, including both physical health, mental health care, as well as help coordinating social services such as housing, employment, education, and food services. It's important to recognize that this procurement is would take place in the midst of both the recertification of the public health emergency unwind, as well as the significant investments the state's going to need to make related to the 1115 waiver. And it's also important to note that 2 years ago, the legislature rejected this proposal in large part because of the disruption that this would have for low-income Medicaid members in New York. For all these reasons, we hope that you'll reject this and certainly appreciate the opportunity to testify.
Thank you. Wow, perfect. That was good. Can you beat him?
Good afternoon. Thank you for the opportunity to testify on behalf of the Coalition of New York State Public Health Plans, also known as the PHP Coalition, and the New York State Coalition of Managed Long-Term Care Plans. My name is Erin Drinkwater, and I'm the Chief of Government Relations at MetroPlus Health, a not-for-profit health plan fully owned by New York City Health and Hospitals, with more than 700,000 members in New York City. The PHP Coalition represents 7 plans that collectively serve more than 5.5 million New Yorkers enrolled in the state's government-sponsored healthcare programs. The MLTC Coalition includes 11 plans serving approximately 165,000 individuals with long-term care needs in New York's Managed Care, Long-Term Care Partial Capitation Program, and the Medicaid Advantage Plus program. The coalition plans are committed state partners. Over the past year, we played and continue to play an important role in helping New Yorkers maintain their healthcare coverage as the COVID-19 public health emergency ended. This involved close partnership with the Department of Health to support the redetermination of all Medicaid enrollees' eligibility and assist with changes in coverage. We look forward to continuing to work with the department on the implementation of the state's 1115 waiver program to support the delivery of services addressing health-related social needs or social determinants of health. For all these reasons, we strongly support the governor's efforts to provide continuous eligibility in Medicaid and CHIP for children 0 to 6. We are similarly supportive of proposals to enhance affordability of coverage in the Essential Plan and Qualified Health Plan programs, as well as much-needed investments in mental health and maternal health. Coalition plans are eager to do more in these areas, but we need the resources to do so. To date, plans have largely relied on quality funding they receive when they meet certain metrics. These programs, called the Medicare Managed Care and MLTC Quality Incentive Programs, have been critical to funding investments in provider quality and community-based initiatives. Initiatives that we know improve health outcomes for New York's most vulnerable populations. But these funds are at risk. Despite the positive impact, significant value created by the Medicaid Managed Care Quality Incentive Programs, and the governor's own stated priorities to improve health and well-being of vulnerable populations and reduce health disparities, the state fiscal year 25 executive budget proposed eliminate all Medicaid quality funds. Coalition plans are also concerned about the executive proposal to procure the state's Medicaid managed care programs. This proposal, which was put forward and rejected by both houses in the FY23 budget, could reduce plan choice for low-income New Yorkers, significantly disrupt enrollee coverage and care, a risk that should not be taken lightly given how vulnerable some of our enrollees are, as well as negatively impact local economies where plans and our provider partners are key employers. There's also a concern that the procurement could have unintended consequences for nonprofit plans leaving the market. Thank you for the opportunity to testify.
You only got half a letter grade off for going. And how
Tried my
about
best.
you? Good afternoon.
Good afternoon. My name is Mia Wagner. I'm here today to represent Healthcare for All New York, a statewide campaign of over 170 organizations dedicated to achieving quality, affordable health coverage for all New Yorkers. The executive budget includes many positive proposals that will help protect consumers from medical debt and enhance their ability to access affordable health care. The campaign urges the legislature to adopt said proposals in the budget and include reforms in 5 key issue areas. First, the executive budget includes several provisions to better protect New Yorkers from medical debt, including expansion of eligibility for hospital financial assistance up to 400% of the federal poverty level. The coalition urges the legislature to go further and expand eligibility up to 600%, as well as incorporate time-limited debt repayment plans as would occur if the Ounce of Prevention Act, S 1366B and A 6027A were enacted. The executive budget prohibits hospitals from suing patients with incomes below 400% of the federal poverty level. We strongly support this prohibition and urge the legislature to additionally prohibit state-operated hospitals from suing patients for medical debt by adopting the provisions of the Stop SUNY Suing Bill, A 8170 and S 7778. Second, the governor has included a nation-leading proposal to eliminate cost sharing for insulin for state-regulated health plans. According to the DOH, 1.6 million New Yorkers have diabetes, of whom 538,000 use insulin. The coalition strongly supports this proposal as research shows that eliminating cost sharing for chronic illnesses results in increased medication adherence and overall healthcare system savings. Further, there are significant racial disparities in prevalence and mortality of diabetes in New York. Improving access to insulin is an important step towards improving health equity. Third, the executive budget includes guaranteed continuous public insurance coverage for children up to age 6, a proposal we strongly support. Fourth, the executive budget includes premium and cost-sharing subsidies for qualified health plans using 1332 waiver pass-through funds. We strongly encourage the legislature to authorize these premium subsidies in addition to using the remaining surplus funds to offer coverage up to 150,000 low-income immigrants who are otherwise ineligible. The governor's proposed cost-sharing subsidies would cost around $1.4 billion, and coverage for low-income immigrants would cost an estimated $4.9 billion. Together, these provisions total $6.35 billion out of a $7.1 billion 5-year surplus fund, leaving $790 million in surplus funding to spare. There are sufficient federal funds to cover both programs. Lastly, the Community Health Advocates Program helps New Yorkers navigate complex healthcare systems by providing individual assistance, outreach, and education to communities throughout the state. In fiscal year 23, their helpline experienced a 172% increase in calls. However, the program received an unexpected $468,000 funding cut last year. The governor's budget includes $3.5 million, and we urge the legislature to allocate an additional $2 million to fully restore the program's funding to $5.5 million. Thank you again for the opportunity to testify.
Assembly.
You have a question? Yes. Okay,
All right. Thank you, Madam Chair. Mr. Linder, I just want to follow up with something you talked about when you brought up the Medicaid managed care procurement proposal. How would a competitive bid process impact the managed care marketplace?
Well, I think a couple of ways. First, there's the potential that you could have plans that are not chosen end up no longer being able to participate in the program. That would have a significant impact on the individual plan members who would then have to choose a different plan. It's terribly disruptive when a plan ends up leaving the market or no longer is able to operate in the state. And I wouldn't want to understate the significant disruption that would cause for patients, particularly having to choose a new plan and whether or not that it would then ultimately change relationships that they may have with particular providers. Second, from the delivery system, that likewise is going to be very disruptive for hospitals, physicians, other providers if a plan is not chosen. And I think the third piece is that at time, as I mentioned in my testimony, at a time when the state needs to make significant investments both in continuing the recertification as a result of the public health unwind, the investments around the 1115 waiver, having to undergo a procurement which is time consuming, costly for both the state as well as for market participants, is not really the right investments that we ought to be making when we've got much bigger and much more significant challenges and investments that need to be made.
So I'm going to take a guess at what the answer is, but do you agree with the executive budget proposal on what the projected saving estimate would be as a result of this proposal?
I mean, I think that that's really to be determined. I think the important thing to recognize is that in a year when policymakers such as yourselves are grappling with really big challenges around potential cuts to services, not just for health plans but certainly throughout the delivery system. This proposal doesn't generate any savings in the upcoming fiscal year, but it's going to require significant investments among market participants to be prepared when when an RFP or a procurement goes out into the market.
And very quickly, you kind of touched on this, but how would care be impacted for the Medicaid members if this moves forward?
Yeah, so you potentially have individuals who are in one plan, and if their plan is not an entity that's picked, they have to transition to another plan. And these are individuals, as I mentioned, who have oftentimes have complex medical conditions, having to coordinate not just their care but social services and other supports would require a significant undertaking for the provider, the plan, and the patient.
Thank you. You have no more?
Do you have a question? No. No, the Senate said no, thank you.
Okay, we have a few.
Okay.
Assemblymember Weprin.
Thank you all for your testimony and your work all year. I'll address this to Ms. Drinkwater. What type of work would be prevented, by some of these cuts that are currently, provided by Metro Plus and other companies along those lines? What type of specific services would be directly affected?
Thank you for that question, Assemblymember. One of the things that I'd like to highlight in regards to the Quality Fund is some of the work that we do at Metro Plus that's critical for closing health disparities and closing outcome gaps. These dollars are used for our providers and community-based work. And one of the areas that we are focused on at Metro Plus is really using those dollars to address housing insecurity. We worked directly with health and hospitals, the Department of Social Homeless Services, and community-based providers in New York City with members of ours that are experiencing homelessness to work with them to get them connected to housing and really follow them on that housing process from completing their application, whether that be a supportive housing application or an affordable housing application, and then ultimately seeing that member get into housing. And the elimination of the quality funds in the governor's budget is very concerning. We appreciate the legislature's restoration last year, but each year coming hat in hand for those dollars creates a lot of instability in the program for our providers and community-based organizations who are trying to do this work to close those outcome gaps for individuals who are on the Medicaid plans.
Okay, well, we'll be working on trying to do that again this year, I
We appreciate
suspect. But don't go away. Don't go on vacation.
Assemblymember Gandolfo.
Thank you, Chairwoman, and thank you all for your testimony. My questions are going to be for Mr. Windsor. In regard to the proposed 1% rate cut for plans that participate in Medicaid, how will that translate? How will services be impacted by a $400 million cut?
Yeah, I mean, I think the biggest thing has to do with similar to the cuts that we're seeing in the QI program, or the investments that plans are going to make for things that might be beyond the typical benefit. So things like social supports, transportation, outreach, things that you would typically need some dollars to be able to invest in, just aren't going to be possible as a result of that. And again, at a time when the focus and much of the conversation today from the state has been around steps that they want to take to address equity, eliminate disparities in care, and much of this work gets done through health plans as partners with the state. But without sufficient dollars, it makes it really difficult to make the necessary investments that will have a meaningful impact for providers and patients.
Thank you. And with regard to the QI program, what do plans currently spend on quality pool dollars now?
Well, the total amount's about $223 million. Full funding would be about $268 million, as Aaron mentioned. This is something that every year the executive either reduces or eliminates. We appreciate the fact that the legislature has made has supported this on an ongoing basis. But the types of things that get funded through the Quick QI program, things that we want to see happen, in the Medicaid program, beyond sort of just going to the doctor. But we're talking about things like preventative visits, wellness checks. In the MLTC program, going into members' houses, making sure that they get, their flu and pneumonia, vaccines, but also, other things. We've got programs in the upstate, region where we're working to, we've got plans and community partners working to address housing insecurity. We've got, programs out on Long Island. Plans and providers are partnering to extend office hours so that patients can get in and get the care that they need. So there's a wide array of different programs that are going on across the state that only happen because of the QI dollars. And as Aaron pointed out, it makes it really hard that to have to do any kind of meaningful long-term planning. If each year what you're facing is the prospect of cuts, where's the incentive for community groups and providers to want to partner on a long-term basis?
All right. Thank you very much.
Assembly Member Jessica Gonzalez Rojas.
Oh, there we go. Thank you. Now I have two mics. So I want to thank you all for your support of Coverage for All, and thank you, Mia, for talking about it. I will ask a different question. Erin, I appreciate your support, Metro Plus's support of the 0 to 6 proposal of continual enrollment. I have a bill 8146, and the executive proposal would provide continual coverage for children in Medicare or who are enrolled in SCHIP, not just Medicaid. Sorry, Medicaid or SCHIP, not just Medicaid. So can you share like what's the benefit of having just Medicaid or the Medicaid and SCHIP option, and why that's important?
Thank you for the question. We're very pleased to support this. Metro Plus spoke a couple of weeks ago at your press conference, and both for the Medicaid and CHIP continuous coverage 0 to 6. The benefits, there's a handful, and I think we learned from the COVID pandemic some real lessons in terms of the easements that were made as it related to the necessity for people to redetermine their eligibility during the pandemic. We saw increased rates of coverage. We saw decreased burden on individuals. And the reason for that was because we knew that medical care and coverage was so necessary during that pandemic. And it would be a shame for us to take those lessons learned and turn our back on that. So knowing that children 0 to 6 are, some of our most vulnerable New Yorkers, access to, school-based care, vaccines, early interventions are all very important. But it's not just for the child, their family, their caregiver. It also relates to the benefits to the state as it relates to the burden that this churn presents in related to administrative costs for the state, for the local social service departments, as well as the plans. So the benefits really far outweigh the cost, and we hope that we can get this across the finish line.
Great. Thank you so much.
I believe that's it. So thank you very much, Panel C.
Thank you, Panel C.
We're up to Panel D.
Yes. So Empire Center, Leading Age New York, Housing Works, and the Center for Elder Law and Justice. Oh, a nice diverse set of topics. Oh, yeah. Charles King.
Unless you have a preference, we could just go down the order of our sheet.
Right.
Doesn't
we
look
just
like
gotta
you do.
grab one more chair for 4 of you. No, we're getting one. Don't worry. Thank you.
Yeah.
To write for the Daily News.
Yeah.
Used to do
Thank
a
you,
fabulous
Ian.
job.
And you need a very strong finger to press from red to green, just letting you know.
You have a question?
And so let's just go down with Bill Hammond first, then Jim Klein, then Charles King, then Lindsay Heckler. Hi, everyone.
So good afternoon. I don't have to tell you, you've heard a lot of talk about crisis in New York State's healthcare system. One witness after another has testified they're critically short of money, desperately short of staff, and they want Medicaid to come to the rescue. I'm a data guy, so I feel like my value added is to put some of that in perspective. I'll start with a statistic you've probably heard before. We spend more per capita on Medicaid than any 70% more than the national average. And that number has been growing pretty rapidly in the last few years, 62% in 3 years. That's probably an unprecedented amount for 3 years in New York's Medicaid program. We also spend more per capita on healthcare generally, public and private. And so if you think about it, the U.S. spends more than the rest of the world. This is probably one of the very richest healthcare systems there is. And then finally, I'll just add that our healthcare workforce is bigger than it's ever been, and we have more healthcare workers per capita than any other state. So we have a lot of resources available to us. So the issue seems to be, if there are shortages, and I believe that there are shortages, the issue seems to be a question of allocation. As David Sandman said before, we should be spending smarter. It's a tight budget year, so this is a good time to think through those things, to squeeze waste out of the system, to spend smarter, not bigger, and to reinvest savings where you'll get the most bang for the buck. One area that I would really like to highlight, where I do think there is a very small investment that can get great returns, and that would be creating a pandemic investigation commission. There's a bill introduced by Assemblymember Gonzalez Rojas and Senator Salazar. I think it's an excellent bill, and I think you should pass it. And it would do an investigation of the pandemic so we can learn lessons and improve our public health response. And it would need some small amount of funding to operate, and I think that should be in the budget. If you're looking for other examples of places where you might find savings, I guess I have to be the skunk in the room and point to the funding for distressed hospitals. Because some of these hospitals, if you were assured that a few years of extra help would turn them around and they'd stand on their own feet, that would be one thing. But some of these hospitals have been getting hundreds of millions of dollars a year, year after year, and they're not becoming any more financially viable. And that's money, that's healthcare dollars. That should be going to pay for care for patients and not going to subsidize an underutilized facility. So I know that's a very politically difficult subject, but that's an example of the kind of hard thinking that I think our healthcare system needs. So thank you.
Thank you. I represent over 400 not-for-profit and government long-term care providers across New York State. Although the governor acknowledges New York's growing older population and rising need for long-term care, her budget fails to make the investment to address the dire need. Not only does the budget proposal fail to invest desperately needed funds to ensure access to care for older New Yorkers, it imposes significant cuts. Even worse, only older adults and others who need long-term care are targeted for these deep cuts in the governor's budget. The executive budget demands that older adults and long-term care needs bear the brunt of the Medicaid cuts. In fact, the executive budget Medicaid scorecard shows 633 million state share reduction in Medicaid for long-term care services. The rest of the Medicaid budget only has a $112 million reduction. This is at a time when nursing homes are being paid 74 cents on the dollar for care. We've done the math. The state does not dispute this. They know that they are underfunding, yet they include no new dollars for staff in nursing homes. At the same time, we're being faced with penalties for not having enough staff. The result is my members have closed beds and closed units. That's why in the Rochester Press, as the elected officials have already noted, there were 110 patients in one hospital waiting for nursing home care. I'd just like to touch on the VAPAP program. It was interesting that the department said that it wasn't needed. The only reason it's not needed is because they haven't used it. Just in the last 3 years, there's been 11 hospitals or 11 nursing homes that have closed, 9 are not for profit. And this is at the same time that the hospitals are desperate to get people discharged. I'm not going to be redundant on the long-term care procurement process, but we've seen what happens when a long-term care plan goes out of business. Just one plan going out of business and the resulting difficulty in placing the people that they serve. Doing a procurement where you could have 100,000 people with disabilities being disrupted from the provider makes no sense to us. And finally, I just want to note that on the adult day health care program, as a result of the pandemic, there were 115 that we had in the state. They are now, most of them were shut down. There's only 55 that are open. In the borough of the Bronx, there is one medical adult day program operating. This is a community-based program that helps people stay out of nursing homes and is something the state needs to invest in. Thanks.
Thank you. Next, Charles King.
Thank you, Senator Krueger and Senator Rivera and Assemblymember Pollen for inviting my testimony today. On a positive note, I want to commend the governor for including in her budget a proposal that would streamline testing, opt-out testing for HIV in emergency rooms and primary care centers. This is a really critical step, and I want to acknowledge Assemblymember Pollen, who introduced a bill almost identical to what's in the budget in the Assembly that passed in the Assembly yesterday. We're looking forward to seeing similar activity in the Senate. I want to speak to expanding enhanced rental assistance to people living with HIV outside of New York City. There are some 2,500 households outside of New York City living with HIV who are presently homeless or unstably housed. You can't take medication and adhere to treatment if you're unstably housed or homeless. You all have passed a bill that the governor has put forward 5 years in a row that has not housed a single household. It's time to do something different. We have repeatedly proposed put forward a proposal that would ensure that everyone who is homeless living with HIV has access to enhanced rental assistance. I also want to commend you for your comments throughout the day around universal coverage, particularly for undocumented immigrants. You all have noted the savings to the state. I want to emphasize the impact on consumers who are presently uninsured. So right now in New York State, 1 out of 5 people is diagnosed with HIV simultaneous with receiving a diagnosis of AIDS. That percentage is actually significantly higher for undocumented immigrants. Why? Because they don't go to primary care because they don't have health insurance. They only go into a medical facility if they need urgent care. They are not being tested, and consequently, they only get tested for HIV when they have an AIDS-defining illness that takes them into the emergency room. Similarly, they are not getting tested or treated for hepatitis C at the same rates as many other people. And then lastly, with my time running out, I urge your support for overdose prevention centers. We have reduced deaths significantly from HIV for people who use drugs, but we now have over 5,000 people dying of drug overdoses in this state every year. Thank you.
There we go. So thank you for the opportunity to be here today. I'm with the Center for Elder Law and Justice. We are a civil legal services organization that provides legal representation to older adults in Western New York. We were quite a bit disappointed, to put it mildly, at this budget with all of the work currently going on with the master plan for aging and the soon to be released at some point Olmsted plan. There is no investment in aging services and supports in this budget to help older adults age in place in their homes, which is the least integrated setting possible. Other groups later on are going to talk about home and community-based services. I wanted to use my time to briefly touch upon assisted living residences and nursing homes. The governor, again, is proposing quality measures for assisted living residences. We're not necessarily against that. We just think it needs to be expanded across all types of adult care facilities. So your adult homes, your enriched housing programs, your Medicaid ELPs. Each level of care has its own services, needs, and requirements, and needs to have their own metrics. Along those lines, we really urge the legislature to push strongly by mandating inspection reports of assisted living and adult care facilities to be published online. One proposal we are strongly against is the governor's proposal to allow assisted living residences to attain accreditation. And so long as they have that accreditation, they do not have to be inspected by the Department of Health. Accreditation must never be a substitute for oversight. So with that, Assemblymember Paulin, you have an amended bill out there that we would support that language over the executives. As my time runs out, I do want to touch upon the governor's proposal to stop the Equal program. So we strongly oppose this proposal to discontinue the Equal program because while it does not make sense that the state would subsidize the cost for persons with dementia to remain in their special needs ALR, which we fully support, it's aging in place, but then pull away money to help other adults who are lower income to have access to services and activities in their home, in adult homes. It's a bit ridiculous. Lastly, with the time, I do want to put out there, we need to increase the personal needs allowance for persons living in nursing homes. $50 a month? That is ridiculous. What can you buy for $50 a month? I know that's not a hot topic in this year's budget, but if we're talking about helping to empower older adults' quality of life, increase that $50 to at least $150. Thank you.
Well, I do, so I'll start. Thank you. I guess Bill Hammond. So when you talk about that we spend so much more money than anyone else, and yet you also agreed we don't have enough workers in various categories, what are we spending the money on? Are we just spending it wrong?
We have quite a few workers statewide, but it's not allocated as evenly as you would want in an ideal world. Downstate has way more workers per capita than upstate, and some industry. So Jim's industry still way down in terms of employment since the pandemic. Home care is way up. Hospitals are a little bit up. So it's uneven. Home care is the number one example I would give of an area where we spend a lot of money. I quote the statistic a lot. We spend as much, as of a few years ago, we were spending as much on home care through Medicaid almost as the other 49 states combined. So we have 6% of the population, and we have 45+% of the Medicaid home care spending.
And I'm
I,
assuming, okay, I have to be quick. So I'm assuming you were listening when DOH was getting all kinds of questions from many of us, including on home care issues and the cost. Do you agree with a number of people who argue we're putting a lot of money in home care into the administration through middle people as opposed to actually spending it to pay workers to provide care? Have you done any work on that?
there is definitely money that goes into administration, and I have to say it doesn't seem like if that spending on administration was helping to contain the cost, if it was helping to slow the enrollment, it would be earning its keep. But it doesn't seem like that's what's happening.
Thank you. And then very quickly, Lindsay, about care and quality of care in nursing homes and assisted living. So I'm writing a bill that probably everyone will yell at me about to add them to the Justice Center portfolio, so that when there are complaints, that somebody is actually looking at them as opposed to this sort of voluntary ombudsman per system, which clearly doesn't have the authority or the teeth to do anything when they're discovering problems. Do you have an opinion about that?
I think it's an intriguing idea because I like pulling the potential civil action outside of the Department of Health because it's investigating its own policies, if you will. I do caution, even though I don't have a lot of experience with the Justice Center, I have been hearing with my colleagues who work with residents in the OPWDD system that the Justice Center is not living up to its full potential. So I like the idea, but we need to make sure the Justice Center is doing what it needs to be doing as well.
Thank you. Thank you.
Assemblymember Jensen.
Thank you, Chairwoman. Mr. Klein, you brought up the VAPAP program. Is the cut to VAPAP, is that included in the $200 million cut to the Medicaid long-term care?
No, that's on top of it.
So it's multiple cuts, not...
Yeah, there's a 10% cut to capital, there's a VAPAP cut, and then another $200 million on top of it.
So what, in your understanding, what's the total cut?
To long-term care, not to just, it's over $622 million state share.
Okay.
So over $1 billion cut out of long-term care.
I asked the commissioner, and I don't remember if it was the commissioner or the Medicaid director who answered the question, but in fiscal year 23, in the enacted budget, $187 million in staffing assistance was allocated. They believe that money is going out the door. For your 400 plus members in leading age, is that an accurate statement?
Well, there's three pots of money. There was originally $120 million for staffing. None of that was spent. The next fiscal year, there was $187 million for staffing. The last bit of that money was just allocated. The next year, there was $187 million that had been appropriated the previous year. That money got wrapped into the increase to the rate last year. So that money never existed and they never spent it.
So as nursing homes are complying with the safe staffing mandates that were put in place, what is the current situation with your membership as it pertains to being able to meet those mandated numbers, kind of referencing to what Mr. Hammond said, where you see upstate nursing home employment numbers lagging behind downstate?
Yeah, if you look at the two mandates that the legislature passed, one was that we spend 70% of our funds on patient-facing care. 40% of that had to be on direct care staff. 97% of my members meet that standard. So they're meeting the 70-40. Only 44% of them can meet the 3.5-hour mandate. We are spending the money where you have told us to spend it. It's just not enough money.
So of the facilities that are meeting the 3.5, ballpark, how many are having to do it through the use of agency staff rather than their own organic staff?
Well, the ones that can pay better because they have more private pay and maybe they have a higher case mix, those are the really only two things that change the rate. They can afford to pay the staff more, so they're actually using less agency staff.
but that's ensuring that the ones that have higher Medicaid population in their census are paying a greater share,
Exactly.
but getting less reimbursement from the state.
Yeah, exactly.
And has the state done anything to alleviate the administrative burden through the HERD survey requirements?
They did a brief relief, but if you ask my members, it's not much because it's still 19 questions that give jump data to them.
Thank you.
Thank you. Senator Gustavo Rivera.
Bill, so you're suggesting I want to dig a little bit deeper. You're a data guy, and I certainly know that you come from a perspective that of a fiscally conservative mindset, and I get that. But you're suggesting that we should spend less in institutions that are falling apart in many instances. In this case, for example, I'm let's say St. Barnabas Hospital. So St. Barnabas Health System is in the middle of the Bronx, just south of my district. It used to be in the core, but now it's just south of my district. 95% of the people are Medicaid patients, so they basically lose money every time somebody goes there, and they have all sorts of capital improvements that lagging behind. And this is a story just all around the state. So and they have to keep up their operational costs because obviously they have employees that they have to pay, contracts that they have to meet, and they have capital needs consistently. Many of them, like for example, an emergency room right now that is like out of date by more than a decade, and that's a story of one institution. We have many institutions around the state. It seems nonsensical to me what you're saying, not from the perspective of being a fiscal conservative person, which obviously you are, so you just believe spending less money is better. But what we're trying to say, and certainly what I've been saying for a long time, is that paying them better as far as the Medicaid rate is concerned means that they don't have to come to the state when they're going off a cliff, which happens constantly. And we spend more money when they're almost off a cliff. And that's a constant thing. So help me understand what you're suggesting that we do here to fix this.
I would agree with you that the situation is nonsensical in the sense that the numbers, I'm not making these numbers up.
And I'm not saying you are.
These are the dollar amounts that we're spending, and this is the size of our population. And yet, I'm not familiar with the details at St. Barnabas, but I am familiar with the fact that we have some of the worst average hospital quality ratings in the country. We're consistently at the bottom of all the report cards. And we have other problems such as the ones you outlined. I don't know whether St. Barnabas is getting the operating subsidies. I don't know what percentage of capacity they're operating at. One kind of structural thing that would help is if you had more people who weren't on Medicaid, more people who were in commercial insurance, which, as everybody knows, pays higher rates. We've had a policy in this state for a generation now of expanding Medicaid further and further up the income chain. More than half of the people on Medicaid right now live above the poverty level. It was originally designed to be a safety net for a relatively small...
Lower conversation because it's too sad. We need to pass the New York Health Act. That's it. That's the basic ethics. But we will have debates more.
Yes, Assembly Member Boris.
Thank you, Madam Chair. Bill, in your testimony in 2022 and in 2023, you talked about spending that you did like, which was on public health and preventing pandemics like the Wadsworth Center. Do you stand by that? Do you think there's more spending needed there?
I don't feel like we have a good handle on what our public health budget is. It's such an afterthought. It's not even.
Let's say Wadsworth in particular in that lab.
I'm sorry?
Wadsworth in particular in that lab.
I haven't had a chance to look at what their number is this year. They're about to put a lot of money into capital at the Wadsworth lab. I think it's over $1 billion. But if I looked at the staffing in this year's budget and it was flat.
Okay. We'll get back with your opinion on that. We'd love that. And then, Lindsay, in your written testimony, you mentioned the problem with discontinuing wage parity. You didn't really get to do that in your verbal, but I'd love to, if you could just talk about, I know that's not directly related, but since you brought it up, what do you think the impact of that could be?
Yeah, and that impacts downstate New York, not Western New York. It just
Totally.
does not seem to make sense. it seems to take away wage increases that were hard fought for. And quite frankly, the only way to rectify that would be to pass fair pay for home care.
Great. Thank you.
Yeah, thank you. Lindsay, I just wanted to ask you a little bit because you didn't say anything about racial disparities in care in long-term care. And I'm just wondering what the data are showing. Are any of the measures we have taken up until this point making a difference? Is this something we can do more on?
I think it's definitely something we can do more. In a very small study done with our office, so it's not published, our hypothesis that persons of color were more going to be admitted and reside in extremely subpar nursing homes was accurate. And these certain nursing homes in Erie County are the ones that have been bought out from out-of-state operators who made active determinations to not invest. They've been underperforming for years and nothing has changed. So something needs to be done to do targeted investments to make sure these individuals, these people, are getting access to safe and quality care and, quite frankly, getting back out into the community, because we have a lot of folks that I am seeing personally in nursing homes in these underperforming facilities who don't need to be there, but they don't have access to the services to get them out. I think the state could be doing more data-wise, looking at race, ethnicity, disability status in the nursing home data, and see who is coming into these specific facilities. Along those lines, some operators are doing the right thing by not continuing to admit more residents when they're short-staffed, but these nursing homes, from my observations, continue to admit more residents and more residents. That's a problem, and there needs to be targeted investigations and actions on those operators.
Thank you. And for Charles, also about how well we are doing or badly we are doing about public health in senior housing, and whether it's lead exposure. I know we don't worry about that as much with seniors, but some of the water quality issues, a number of other things about the housing, the healthiness of housing for seniors.
So I'm sorry, we don't do senior housing per se. We primarily focus on housing people with HIV and very low income housing. I will say that there is a growing need for senior supportive housing for people who are living with HIV. More than 50%, actually more than 60% of the population is now over 50.
Okay, thank you. I apologize.
That's all right.
Before we go on, I'm just going to announce we have one special guest that I just want to bring everyone's attention to, and that is former Mets pitcher Bartolo Colon is right to my right, your left. You can wave. I won't mention because it's a hearing what your nickname is. And joined by Assemblymember Amanda Septimo. So if anybody wants a photo, they can sneak out to that side for a few minutes. And I assume bring your cell phone. I don't know if there's a cameraman out there, a camerawoman. And the next question person is Assembly side, right? Did we do Democrat or Republican last? So then it's Assemblyman Godolfo.
Thank you, Chairwoman. Mr. Hammond, I am very happy that you brought up the need to investigate and analyze New York's pandemic response. I seem to remember that the governor announced that there was an ongoing review and investigation of New York's pandemic response. Are you aware if that has produced any public results?
We're still waiting the report back. It was assigned to a consulting firm called the Olson Group out of suburban Washington, D.C. I think it's $4-something million, and it was going to take a year, and it started. I think we might be I've lost track of when it's due. My point about that would be that this group is answerable to the governor and to her cabinet, not directly to the public. This group does not have subpoena power, so it doesn't have guaranteed access to witnesses or documents, and it has no mechanism for having a public hearing. I think this was the worst natural disaster in modern history in New York State. It deserves, and the state mechanisms that were supposed to be protecting us had a lot of trouble managing, and by some measures, we had the worst outcomes during that first 6 weeks of anywhere in the world. So I think it warrants the whole government to get involved, the public to get involved. It warrants bringing in outside experts, and that's what Ms. Gonzalez Rojas's bill would do.
Yeah, and just building off of that, I know the legislation, it brought a response, which was the Reimagining Long-Term Care Task Force. To date, are you aware if that task force has met?
No, I'm sorry, I'm not aware.
Yeah, as far as I know, that task force still has not met, and it was the purported response.
There is a long-term care panel that is meeting, though, right?
Yeah, the master plan on aging process is going through, but that has been so far an unsuccessful process, we think.
Okay, I appreciate it, and I have to agree we need a full and thorough review with subpoena power that is not tainted by potential conflicts of interest. So thank you very much.
Thank you. Assemblywoman Gonzalez Rojas, perfect timing for you.
Okay, thank you so much. Thank you, Mr. Hammond, for raising the COVID-19 Commission bill. Assemblymember Gandolfo just kind of stole my thunder, but I did want you to underscore really the differences between the study that was commissioned by the governor's team and the bill. If you could just make those poignant differences.
I mean, it's really hard. I mean, I'm sort of interested to see what this consulting group comes up with, but it's a consulting group. The state commissions reports like this all the time, and they end up in a drawer. I'm hoping this is something more than that. But as I say, they don't have subpoena power. So if, say, for example, a former governor or somebody like that doesn't want to cooperate, they're not going to be able to force that. It doesn't have a mechanism for holding public hearings, so it can't solicit public input, but also it can't report directly to the public. It's going to submit the report to, I believe, the Emergency Services Commissioner. The governor says she'll make it public, but often reports get massaged before they come out. Mm-hmm. I just think this needs to be much more transparent. It needs to be more powerful, more persuasive. And that's not to say I think the health department and the rest of the administration needs to be involved. They need to buy into it. And I don't think it should be about blaming. I think it should be about being constructive and finding systemic reforms that will protect the public health.
Great. Thank you for your partnership on this. And Mr. King, I do want to thank you for humanizing the people who are impacted by HIV and AIDS and the undocumented community that is disproportionately impacted, often without that care. So thank you for raising that. I do want to ask you about rest of state housing. Besides funding, what else can we do? We are in a housing crisis. There's urgency. But if you can share in 50 seconds any other steps we can do towards achieving rest of state housing.
So, right now, enhanced rental assistance outside of New York for people with HIV is capped at $480. You tell me where in New York State someone can find an apartment for $480. What our proposal would do is it would cap rental assistance at 110% of the fair market rent for any particular jurisdiction. Localities do not like having to contribute to this. The states, the bill that has been passed 5 times over requires them to pay half the cost. This would put the full cost on the state, capping the tenant's contribution at 30% of their income. This has been very successful, housing 37,000 households in New York City, We just need to house 2,500 households in the rest of the state.
Thank you.
Yes, thank you. Next is Assemblymember Raw.
Thank you, Madam Chair. Sir Hammond, I'm just wondering if you have any thoughts on the uh, managed care procurement proposal in the executive budget.
Um, I mean, I've heard both pros and cons. I'm still trying to figure out exactly how it would work and what it would mean. Um, I mean, in principle, it's always good when the state can be careful about how it purchases things and contracts out. I was starting to read the report that was done, which indicated that the market seems to be over fragmented. There's a few plans that are really small. Maybe it would be better if we didn't have those. But I don't have a strong position.
Okay. Thank you. Yeah, we're all trying to digest the report. Obviously, it's difficult when it comes out so close to the hearing. I think you have a little experience with that particular agency, though. So thank you for being here, and thank all of you for coming today.
Okay, we have two more. Well, three more. Assemblymember Joanne Simon.
There we go. Excuse me. So, Mr. Klein, I had a question that I had asked an earlier witness. I don't know whether you heard that question, but I'll sort of repeat it. And that is the failure to increase Medicaid reimbursement rates affects both for-profit and not-for-profit nursing homes. My question is, what is that differential in impact? It seems to me it might affect the not-for-profits more significantly.
Well, I think it affects both, but I can tell you what's happened to not-for-profit and government facilities, and that's 75 of them have closed or been sold in the last 9 years. So we used to have over 250 not-for-profit and government nursing homes, and they have closed or sold to a for-profit.
And then the other question that I had asked, because about this issue about the unallocated subsidies, and I had asked why were they unallocated, and he didn't seem to have an answer for that. So my question is, do you know why they have been unallocated? Is it something in an application process that becomes a barrier, and or if you know where's the money?
Well, there's an application process, and many of my members have gone through it. Sometimes they don't hear anything and they're still waiting. And I know of some cases where applications have been not approved, including one in Rochester, which made no sense to me. We've been talking about the inability to get people discharged out of a hospital in Rochester, but the department did not want to help a not-for-profit merge with another not-for-profit in Monroe County. I don't know why. It made no sense to us. The process is very opaque. We can't really see into it. We just know members are applying and not hearing about it.
Do you get some sort of response telling you why it didn't get approved?
You get a response sometimes, but again, we have many applications that people are just waiting on, which is why it's strange they're saying they're cutting it because it's not being used, but it's not being used because they're not using it. And as I just said, 75 places have closed or been sold. They could have used some of that money for that.
Do you know what the average time is before you hear back after making an application for those funds?
I don't think there is an average time. Again, it's all anecdotal. Sometimes I'll give them credit. There's a few times they've acted fast when I think they saw an emergency. Maybe they thought it was a political issue or something. But in general, it's quite a lengthy process.
Okay. Thank you very much.
Yes, Assemblymember Forrest. Oh, thank you. Then me. So, unless there's somebody else that I didn't recognize. Okay. I have a question for Jim and one for Lindsay. So, for Jim, what would you recommend for this year's budget in order to address some of the concerns that you have talked about?
We were seeking a 2-year phase in to fill the gap. It's $810 million. We were looking for $510 million this year. We appreciate the ad that happened last year. It was a large ad, but the reality of the market is it had a very limited impact. 400 beds came back online as a result, and you still saw places closing. One facility in Jamestown that's been serving people for over 100 years closed, or put in their application. They haven't actually closed yet. So there needs to be a substantial investment, or you're going to see more problems like you're seeing in Rochester right now, which is they can't discharge people and the ERs are backing up. I had a relative 36 hours in an ER here in the Capital District. It's just all the facilities do not have enough the ability to discharge people.
Thank you. And Lindsay, what specifically would you recommend for investment in aging services?
It has to be multi-pronged. First, we need to really support our caregivers, both the informal, so your family caregivers, but also your paid. Because without a workforce that's paid a living wage, so they can actually own their home, buy their groceries, pay for gas, vehicles, you're not going to have any workers. We have had clients who have been denied or had for increased hours or had their home care hours cut, told us don't pursue the case because at least someone shows up for 5 hours a week. Strong investment in the workforce and the housing, quite frankly.
Since I have a little time, Bill, so what is you're saying we are spending so much more than other places. Is it labor costs? Is it, as you pointed out, workers in some areas but not others? Like what is your, in 31 seconds or less, what is the problem that you see?
With respect to Medicaid, it's we have high enrollment and we have a broad array of benefits and we have high spending per enrollee. So it's the combination of all those three.
So what would you eliminate?
I mean, as I said before, I think one goal should be to shrink the roles, like to have more people in commercial insurance self-supporting.
Thank you. That's it.
Actually, we had one more.
Okay.
Sorry. Senator.
Thank you, Madam Chair. Mr. Klein, in regards to the stopgap increase, this a topic that's been coming up over the last year and really for, I think, the greater part of a decade is rebasing. And, we see this push for it each year, and then we see it put out of the limelight, and then it comes up again. Does this concern you at all? Do you think this is something that we should continue to strive for? Do you think that it would be a longer-term solution than just continuously fighting for an increase each year?
Well, the system should be rebased because then the money would be going to the places that have the costs. And the state, in discussions with them, they're talking about rebasing and moving to a new system of how you review the needs of the residents that we serve. The problem is you can rebase with no money. If you rebase and don't put money into the system, all you're going to do is move the money around the system. There's still going to be a giant deficit. So they need to rebase so the money goes to the right places, but they have to add money to the system. New dollars have to go in.
Would you see that as an investment that could potentially save money?
It'll be matched by the federal government.
Correct.
So through the Medicaid system.
So when we talk about long-term reducing the cost and scale of Medicaid, it could potentially do so.
It'll cost a little bit more, but my members work all the time to get people out of nursing homes, and there's lots of alternatives in New York on the community-based side to get people discharged. But there is a group of people that need to have nursing home care, and it's just unavoidable. And as far as the cost of care, the one thing that we see on the nursing home side is it's expensive to do business downstate. Everything is more expensive down there, and the workforce is completely unionized. So That's the difference between us and other states on the nursing home side. If you go to some of those other states, way cheaper to do business, and they don't have a unionized workforce.
And they usually have a clause to where they rebase every 3 to 5 years.
Most states rebase every couple of years. Yes, we are definitely an outlier. We haven't rebased since 2007.
Correct. Thank you.
Thank you. I think that's the last of the questions for this panel. Thank you very much for being here with us.
Thank you.
Appreciate it. And our next panel is Panel E, New York State Association of County Health Officials, New York State Health Facilities Association, Community Pharmacy Association, and the Nassau Healthcare Corporation. So let's just go down as you were listed on the sheet. So first, Dr. Irina Gelman, then Stefan Hans, then Michael Duto, and then Megan Ryan. Still afternoon, right? Yes, still afternoon. Good afternoon.
Thank you very much. Good afternoon, and thank you for this opportunity to present testimony today. My name is Dr. Irina Gelman, and I serve as the Commissioner of the Nassau County Department of Health. I am here today testifying as President of the New York State Association of County Health Officials, which represents all 58 local health departments in New York State. Public health officials understand that lean times require strict application of two key budgeting measures, impact and value. We must ask, where will our investment of limited public funds be most impactful, and how can we ensure the taxpayer is getting value from that investment? Every dollar we invest in public health has an extraordinary impact on preventing illnesses and reducing expenditures associated with the medical and clinical care necessary to treat those illnesses. Evidence clearly shows an ounce of prevention is worth a pound of cure. Local health departments serve as the first line of defense for population-based prevention strategies, including communicable and chronic disease response, community outreach, food and water safety, environmental health services, emergency preparedness, and so much more. Our challenges in public health are considerable. Key among our issues is the ongoing historic depletion of our public health workforce. Many elements within the proposed budget would exacerbate this crisis by reducing funding in key public health programs and increasing statutory obligations that are not funded, more unfunded mandates. There are several elements of the executive proposal that we support, including changes to how we combat hepatitis B and C, HIV and syphilis, expansion of professional immunizers, new tools to address infant mortality, and efforts to address the overdose epidemic. Other elements of the executive proposal will further strain local public health infrastructure and must be reconsidered. Those include inadequate funding provided to implement our lead poisoning prevention laws, funds to fight rabies and tick-borne illnesses that have completely eliminated from the budget, funding for HIV/AIDS prevention, cancer screenings, tobacco prevention, and other programs are also reduced. The governor's initiative to expand access to swimming does not fund local health departments who in most cases are directly responsible for ensuring the safety of these facilities. We urge the legislature to restore these programs. Further, we hope the state will embrace the goals of the 1115 waiver by finding ways to better partner with local health departments to achieve our collective goals around health equity and reducing health disparities. The early intervention program for children with special health needs has been challenged by provider shortages, growing provider wait lists, and underfunding. While we support the provider rate increase outlined in this proposal, this solution is not enough to truly help the families impacted by this program. We urge the legislature to help us by ensuring funds owed to counties through the Early Intervention Covered Lives Assessment enacted in 2021 are released to us and the intended original legislation. There's more details available in written testimony. I thank you.
Good afternoon. My name is Stephen Hansen. I have the privilege of serving as President and CEO of the New York State Health Facilities Association and the New York State Center for Assisted Living. The theme of my written testimony is where have we been, where are we now, and where are we going? Starting with where we have been. For the past 15 years, the state of New York has disinvested in the most vulnerable population. the seniors who rely on Medicaid for their long-term care needs. These past years of disinvestment, coupled with the statewide healthcare staffing shortages and unrealistic 3.5-hour staffing mandate, have led to long-term care crisis. New York's long-term care crisis is rippling across the healthcare continuum, contributing to backups in hospital discharges to nursing homes and compromising access to essential care. Where are we now? Today, the statewide average Medicaid reimbursement rate covers only 74% of costs, resulting in a reimbursement rate of $11.45 per hour for 24-hour skilled nursing care. This rate is well below the state's minimum wage, resulting in the inability of providers to compete in today's labor market for essential direct care workers. Moreover, nursing homes are now faced with the unrealistic requirements of the 3.5-hour staffing mandate. A staggering 478 out of 610 nursing homes statewide are currently unable to comply with the state's unrealistic 3.5-hour staffing mandate due to severe labor shortages. The executive budget proposes to cut the capital component of the Medicaid rate for skilled nursing facilities by 10%. The executive budget also seeks to cut at least $200 million of long-term care sector, reversing most of last year's progress on top of the VAPAP cuts. What we need now are not cuts, but a commitment by the state to stop the failed Medicaid disinvestment policies of the past and fully cover the cost of Medicaid residents in nursing homes and assisted living facilities. To this end, it is critical that the state include a $510 million state share investment in this year's state budget and set in motion efforts to invest and rebase the nursing home Medicaid rate to truly effectuate the state's commitment to high-quality nursing home care and jobs. NYSCAL strongly supports the governor's proposal to authorize medication aids in nursing homes. Where are we going? The long-term care crisis in New York we are facing can be understood looking backwards, but it must be addressed going forward. We must act in the present. We must aspire to make decisions guided by the adage, to care for those who once cared for us is one of life's greatest honors. To this end, New York must cover the full Medicaid cost of residents in nursing homes and assisted living facilities to fulfill its commitment to serve the state's growing population. Thank you.
Good afternoon, honorable chairs and members of the committees. I'm Mike Dutel. I'm a licensed pharmacist, and I'm president of the Community Pharmacy Association. Thank you for the opportunity to testify today and for your strong past support of local community pharmacies. I will summarize our positions regarding the proposed health budget. First and foremost, we oppose the Department of Health's proposal to require pharmacies in Medicaid to submit annual cost reports. Currently, 46 states, including New York, utilize NADAC, or National Average Drug Acquisition Cost, for Medicaid pricing, and approximately 95% of covered outpatient medications have NADAC values. Excuse me. NADAC is a federal CMS survey that collects data from 60,000 pharmacies across the country, and the prices are updated weekly. For any drugs that do lack a NADAC value, New York uses another nationally recognized benchmark known as WAC, or Wholesale Acquisition Cost. All covered outpatient prescription drugs currently have a WAC value. For pharmacies to take this on, for something that we already provide at a national level and is supplied to Medicaid, would be a huge undertaking. It would be unnecessary, it would be duplicative, and it would be extremely labor intensive. While discussing Medicaid, there's also an urgent need to include New York State OMIG audit reform in this budget. For too long, OMIG's practices have been threatening the financial viability of providers and programs serving those enrolled in Medicaid. Most often, these practices are not targeting fraud, waste, or abuse, but rather clerical errors. So, for example, a real-life current pharmacy was actually filling a prescription for a new patient. Everything was correct. At the very end, the pharmacist had to manually enter an NPI number. Incorrectly entered the last 2 digits of the NPI. Everything else was correct. Right patient received the right medication at the right time. Unfortunately, OMIG was able to extrapolate that into a 6-figure recoupment. That's not fraud, waste, or abuse. That's something that should be correctable. We need this audit reform reintroduced in this budget. We also support the proposal to make pharmacist COVID 19 and flu testing permanent. We also recommend expansion of the testing. Senator Rivera and McDonald have introduced a bill that would do just that and include new tests like RSV, Strep A, hepatitis C. Finally, we support the proposal to expand pharmacist vaccine administration to include Mpox. That just makes sense in our current environment. Pharmacists are able to administer all CDC recommended vaccinations for adults. We also support the proposal to allow unlicensed personnel like medical assistants and EMTs to give vaccines. Currently, today, under the PrEP Act, pharmacy technicians can do this also and need to be included. Thank you for your consideration.
Good afternoon. I'm Meg Ryan, Interim CEO and Chief Legal Officer of Nassau Healthcare Corporation. Thank you for your time. Nassau Healthcare Corporation is the public benefit corporation that was established in 1999 by New York State statute. It oversees Nassau University Medical Center, NUMIC, the only public safety net hospital in Nassau County that has 530 beds, is designated as a level 1 trauma center, home of Long Island's only multi-chamber hyperbaric, and is a designated overflow center during natural disasters. We also house the county's Medcom, EMS, and Fire Police Academy. NHCC also oversees A. Holly Patterson, the skilled nursing home and rehabilitation facility, the only public nursing and rehab facility in Nassau County, which has 580 beds. NUMIC oversees the inmate health care at Nassau's correctional facility with 2 infirmaries. Additionally, NHCC runs an ACMG residency program with 350 residents, educating our future medical professionals, which there is a global demand for. NHCC co-operates federally qualified health centers as well as school-based clinics. Our employees are New York State employees. We currently have 3,640 employees. 66% of our staff are female, 70% are minority. We have 1,500 retirees enrolled in the New York State pension system currently. NUMIC and A. Holly Patterson render high-quality health care to all, regardless of a patient's legal status or their ability to pay. Our payer mix is 90%. It's 90% Medicare, Medicaid, which means we are set up to have losses, and those losses must be offset by state funding. 65% of our patients are minority and female. NHCC serves nearly 260,000 patients annually, including 67,000 emergency department patients. NHCC is the only medical facility that provides quality health care to Nassau County's underserved communities. NHC was created by state statute for the benefit of Nassau County and its residents, and it has relied upon New York State funding since its creation in 1999. NHCC has lost New York State funding in the total amount of $267,647,382 since 2020. There's been a steady decline in funding year after year. We have submitted sustainability plans, multi-year cash projections, and applied for grants, including VAPAPs, to New York State. I am respectfully requesting the restoration of funding for 2024 to ensure that we may continue providing the necessary health care our surrounding communities rely upon and deserve. Thank you for the committee's time today. I appreciate it. Thank you.
Thank you so much, Madam Chair. First question is for Ms. Ryan. I know you indicated that the hospital or New Health has actually lost $267 million since 2020 in funding. What type of funding was that?
Sure. That was through DSRIP, through essential healthcare provider support, statewide healthcare facility transformation grants funding, also VBQIP grants, and there's different grants throughout the state.
Was there any explanation given as to why the hospital has been losing so much of the state funds that it relied upon since 1999?
We have not had a discussion as to why we had lost these funds. We are under NYFA control, and we are in constant communication with New York State, DOH, and NYFA weekly. We have submitted our cash projections, and our patients don't pay. They're Medicaid, Medicare. So
Right. And I noticed that in the governor's proposal, there are a number of medical debt proposals that she's put out, including expanding um, expanding the financial assistance program to 400% of the FPL. Um, is there any idea of what an expansion like that would actually cost Nassau University Medical Center?
we have not been in discussions regarding that.
Okay. And I know that you indicated that the hospital has applied for VAPAP
Correct.
funding. When did that application go in?
Sure. We started submitting last March. We've submitted 3 VAPAP applications, one for Newmick in the amount of $120 million, a separate one for A. Holly Patterson, the nursing home, in the amount of $40 million, and then a special projects VAPAP in the amount of $46 million.
Because we did have the health commissioner here earlier, and we asked him about funding
Correct.
specifically for Newmick, and he said all they have to do is apply. Well, you did apply.
We've applied. We've had discussions regarding the Newmick VAPAP where they have asked us for more information, but as of yet, we have not had any discussions regarding any amount of funding being given to NHCC, Newmick, or A. Holly Patterson.
And that first application went in
March of 2023.
So last March?
Yes. Correct.
Okay. Thank you.
Thank you.
Yes, Assemblymember Jensen.
Thank you, Madam Chair. This is for Mr. Hands. The health commissioner talked about how their enforcement of the safe staffing mandate is now in effect, and penalties will start to be adjudicated, for lack of a better word. Has there been any clarity that you or your membership have received about how these penalty fines may or may not be reinvested into nursing homes or the nursing home workforce?
To date, no. So the state has finished the second quarter of 2022. As I indicated, 478 of the 610 nursing homes could not meet that staffing requirement due to the workforce crisis. The Department of Health has the authority to issue a $2,000 per day fine. We have requested of the governor that any fines, first of all, fines shouldn't be issued to providers who've done everything they can. And the Commissioner of Health has declared for 2022, all 62 counties of the state of New York are facing a healthcare workforce crisis. But we have requested of the governor that if any fines are issued, they be totally redirected back into workforce recruitment efforts at nursing homes.
Okay. So how are long-term care providers currently handling their worker shortage? And where are you seeing and hearing from your membership the shortage is most being felt? Whether is it with RNs, LPNs, CNAs, other support staff?
Sure. We're seeing it across the state. We're seeing significant shortages upstate. You heard earlier talking about Rochester, Western New York, the Adirondacks, but we're seeing it throughout the state. And what we're seeing are LPNs leaving skilled nursing and going to hospitals. Hospitals can always pay more than nursing homes. With 74% of our payer mix Medicaid, we can't afford to compete against hospitals for those LPNs. So what nursing homes are doing, they are limiting admissions. They are closing units. They are hiring agency staff at exorbitant rates that are unsustainable. So that's where they are right now.
So with any increase in Medicaid funding for long-term care, what's your belief on how those dollars should be divvied up to the providers? Is it based on geography, case mix, quality levels?
What we're proposing is for the 510 million state share for this to bridge us to rebasing. That would allocate $44 per provider per Medicaid day across the state. So depending on what your Medicaid rate is, it would be an equitable increase. It would be a bigger percent if you had a lower Medicaid rate. It'd be less if you had more. So basically, it's a uniform across the state.
Thank you.
Thank you.
Assembly.
Next one is Nikki Lucas. And welcome to the hearing.
Good afternoon or good evening to everyone. I think this one is for Mr. Hans. Um, could you share with me how much do NAMI deductions contribute to nursing home revenue?
I'm sorry. Could you say
The
that?
net available monthly income that's deducted from uh, patients at nursing homes.
Oh, the NAMI, the net
Yes.
available. How much? It's
How much does that contribute to the overall nursing home revenue? How does that
sure.
affect overall revenue?
That helps offset the cost of a Medicaid resident in a nursing home.
And what percentage would you say contributes to the overall revenue?
I would have to. I would have. I'll circle back with you, Assembly Member, and get you that number.
Would you say that that is significant to the overall revenue? Because that should actually be
Actually, I would
included
not
in.
say it was significant.
Repeat
I
that.
would say it's not significant, but I'm going to go back and get that data for you.
Okay. I just thought um, as part of the testimony, it should definitely be included because it is part of revenue for the nursing homes.
Correct.
And there has been some significant concerns around the calculations, some being too high, some being too low. But I'd be interested in making sure that that's included in the conversation and in the testimonies moving forward as well. But if you could get that information back to me, I greatly appreciate it.
Sure. We run into situations actually where unscrupulous family members don't allow that money. So I'll get you all the information.
Thank you. I appreciate it.
Sure.
Yes, Assembly Member McEwen.
Thank you so very much. This question is going to be for Ms. Ryan. We were speaking regarding NUMC beforehand. Can you just explain to me, we were talking about the VAP app. Now you have applied, correct?
Yes, correct.
What has the process been like?
We had to fill out a state application. We had to go back and forth, and they had more data that they requested. We submitted that. We had on the New Mix side, we did have I think it was 2 phone calls already, and that's on the New Mix side. On A. Holly Patterson, they requested more data. To my knowledge, we have not had a discussion regarding the A. Holly Patterson application.
And how has the response been from the Department of Health in the state?
While we are cooperating with them, and from my knowledge, we are told that there are other hospitals that are in the same or worse situation. So it does not look hopeful on our side.
So there are many hospitals, but how many people do you serve in Nassau County?
We have 260,000 visits, outpatient visits annually. We have 67,000 emergency visits annually. We have 480 residents in our nursing home right now. We have 345 patients in the hospital right now.
And if you do not receive this money, what would you say would happen?
It's going to impact our operations. We're not going to be able to continue our operations and continue to provide this necessary health care to our county residents.
And is there any other revenue streams? Because you said most of it's from Medicare, Medicaid.
Well, we do collect that, and we are increasing our net collection patient revenue each month. We've done a whole bunch of financial reforms since September. We hired a consultant, so we are seeing an increase in the net patient collections. But again, the majority of our patients are uninsured and are not commercial payers, so it's a payer mix.
So without state funding, it's going to be extremely difficult in order for you to continue.
It's a healthcare crisis without the state funding in Nassau.
So now we have many employees and we have many people served. Now, but how many people come in and, let's say, are migrants or are people that you have to serve, but you don't receive any money from the government from?
Well, 90% of our patients, we do not turn anyone away regardless of their ability to pay or their legal status.
Okay,
That's our mission.
So there are people that come in that you will receive absolutely nothing for.
Correct.
And what is the projection? So explain a little bit more how it's going to affect services. What is it that you believe that you're going to have
Sure,
to
we're a
cut?
level 1 trauma center. We have first responders coming in all the time. We have the burn unit. We have.
Well,
Thank you.
Thank you so
time's
much.
up, but thank you very much.
Assembly can continue. I think that's me. So I have some questions about Nassau as well, just to drill down just a little bit.
Sure.
So I know that the county pays for your non-federal share of DISH, and that the state is paying off some of your pension payment. But you didn't refer to that. Is that steady?
So from my knowledge, the county does not pay our dish payment. We put up our dish payment, which we're waiting for the dish payment to come in. Usually it's the end of January, so we are awaiting that, and that money will go to our pension payment. That's
So is
due
that a
February
change?
1st.
Did Nassau stop paying your non-federal share of DISH?
It has decreased since from federal cuts, and again since 1999 we became a state
So
entity.
part of this is a county problem, right?
No, I believe it's a state problem. I think it's everyone's problem.
No, I
I
understand.
think it's everyone's problem.
But in terms of the absolute dollars, part of the decrease is because of the counties not paying for the
data reflects it's definitely due to the state funding. We receive $40 million from the county every year.
I just want to understand it so we know how to help, right?
Thank
so the BAPAP money, is that what you're worried about? Like, I'm not sure exactly what funding source specifically is being cut at the state level.
All of them.
No, I say, if you could just name them and give me the amounts. Yeah.
Yeah, I submitted this. It's my Exhibit A. Yes, our DISH funding has been cut.
DISH not from the state, though. That's
DISH
from the county.
The
So
DISH funding has been cut from the state since 2017. Our the CREP funding from New York State has been cut. The Essential Health Care Provider Support Program.
So is that in this year's budget, or you're saying that in the
I'm
past
going
few
back
years?
every year since 2017, every year. In 2021, 2022, and 2023, District and CREP just went away completely.
So I guess what I'm asking is, in this budget, what's different and changed that you're advocating for this budget? I get that you've been cut as everybody else, right? You know, so what is in this budget that we would need to restore to bring you back at least until last year's level?
Right. I think we need a line item on the budget for Nassau Healthcare Corporation as a New York State public benefit corporation, whether that's in conjunction with the other two public benefit healthcare corporations, Erie County Medical Center and Westchester Medical Center, which we have been in discussions with at local levels and above at the state level. So that would be helpful as also a determination of our VAP applications with funding from either of those avenues. But I think we need to go on the budget as a line item. I think the county
Thank you.
deserves
I
it.
just wanted to really
Sure.
understand it. Thank you.
Thank you.
Yeah.
Thank you. Anyone else?
Anna Kellis.
Thank you so much for being here, and my apologies if this has been asked before. I was specifically interested, Michael. Thank you. Could you talk to me a bit about the fiscal impact for you from pharmacy benefit managers?
Yeah, absolutely. So we fully support PBM reform. I think an easy way to quantify it right here is what happened with Medicaid, where we moved from managed care to fee-for-service. And just by removing the pharmacy benefit managers from that process, pharmacies were losing much less money. So,
What percentage save do you expect that we would see if we did this across the board?
that's hard to quantify. I can get back to you with some real numbers, but I know when we looked at the regulations that were originally introduced, there would be substantial positive impact for the pharmacy industry in whole, more importantly for our patients, everywhere from a reimbursement standpoint at point of sale to copay management and prior authorization management on the patient side.
And I've heard some concerns that that the profit motives and priorities of the pharmacy benefit managers has led to crises for a lot of pharmacies staying open. There's been closures. I've seen money in my district. I'm curious what if you could tell us a little
Yeah,
bit about that.
that is absolutely accurate. So there are numerous levers that the PBMs have been pulling that negatively financially impact pharmacies. Medicare, which is a little bit outside of this conversation, but they have DIR fees, which have been retroactive clawbacks. They've had other programs with similar levers where pharmacies have actually filled the prescription and then several months later learned that they actually lost money on not just the first fill, but each subsequent refill.
Mhm. If you know of the reforms that you've seen, do you think are the most effective ones? If you were going to make specific recommendations.
So I think obviously we need to start with, licensure, registration, make sure that we have parity. Health plans are licensed, pharmacies are licensed, health systems are licensed. The PBMs haven't been. They've been able to operate behind this curtain that makes it hard not only to detect what's going on, but also to regulate and enforce those regulations. So that's the starting point. And then from there you look at fair market practices. What's in the best interest of the patient that allows the pharmacist and other providers to really care for that patient in a way that doesn't negatively financially impact them.
Great. Thank you so much.
Thank you.
And release you. And we're, so to speak. Of course, you can stay and listen to more. And we're jumping to panel F. Agencies for Children's Therapy Services, Children's Health Home of Upstate New York, the Children's Agenda, 1330 Cancer Connect, and Alliance of New York State YMCAs. We might need a fifth chair, someone. Oh, thank you, Ian. Okay, why don't we just go in the order I just read your names under? Agency for Children's Therapy first. Scott Mesh. You have to press the button down hard until you see the green light go on. Push harder. They require serious pushing.
No, it just needs to be right in the middle, bro. Like right in the middle of the push. Hold on. Don't tell me that one's already broken.
There we
you
go. Strong
Okay.
finger is good.
So sorry.
It's okay. If you need a little time, we can jump to someone else and come back.
I am ready.
Okay, good.
Thank you, Chairs Gustavo Rivera, Kruger, Weinstein, Paulin, and committee members for allowing me to testify today on behalf of the Agencies for Children's Therapy Services, ACTS, an association of 31 agencies providing early intervention services to 25,000 children, over a third of the EI children in New York State. Members also provide pre-K, special ed, and school-age special ed services. I'm Scott Mesh, an ACTS board member. For the last 25 years, I've co-owned and operated an early intervention agency, Los Niños Services, with Adita Diaz, school psychologist, serving New York City and Westchester. We thank you so much and are so grateful to Senator Gustavo Rivera and supporters for approving the Senate bill yesterday to increase EI services 11%. Finally, please keep this simple and support Senator Gustavo Rivera's bill. It's critical and urgent to get the overdue increase this year to avoid further devastation of the EI program. Kids are not getting services. Agencies are closing. Perhaps these points will help secure increased reimbursement this year. My overall message is simple. Albany, we have a problem. EI has been decimated, especially in recent years. 2,000 teachers and therapists have left EI just in recent years. Over 50% of children don't get any or all EI services, according to the controller's report 2 years ago, and the situation is worse. Commissioner McDonald commented this morning that many families get no services at all. Commissioner McDonald gets it, and as he said, the low rate of pay to therapists due to the low EI reimbursement rates without significant increases for many years is the main reason providers have left EI in droves. One of the largest agencies in New York State that has operated for 30 years has now closed Westchester all early intervention services just in the last couple of months. That same agency has closed most of the New York City services. Our own program serving 2,000 infants and toddlers is now at financial risk. Finally, a niece of ours who graduated speech pathologist was with us 2 years, and she just left us to earn $20,000 more for hospital. Preschool, special ed schools, clinics, and hospitals pay much more.
Thank you.
Thank you so much.
Thank you. We have everyone's full written testimony, even if you can't speed read it. Next.
All right, good afternoon. I'm Nicole Brill, CEO of the Children's Health Home of Upstate New York. We also refer to ourselves as CHUNY. I would like to thank the members of the Senate and Assembly for the opportunity to provide testimony today. I am here for one reason, and that is to request that the children's health homes be exempt from the proposed health home restructuring cost savings of $125 million. A cost savings of this magnitude, in addition to the $100 million in last year's enacted budget, will end the health home program for children in New York State. We are confused as to what 30,000 children and families will do when these services go away. CHUNY is a health home designated to serve only children and youth under the age of 21. Our health home serves over 12,000 members each month in 55 upstate counties through a network of over 80 care management agencies. The population we serve primarily consists of children and adolescents with mental health conditions. We also serve children with developmental disabilities, medical complexities, and social care needs. We understand that there is a significant Medicaid budget gap that needs to be addressed, but decimating a program's funding without any plan in place is irrational, and the unintended consequences will result in more costly alternatives. A full year of health home services for a child and family is far cheaper than an average 4-day hospital stay, a 6-day residential program placement, foster care placement, or a permanent placement in a long-term care facility for our medically complex children. Not to mention, these systems are already taxed and at capacity, as we've heard today. Preventative care is more cost-effective and provides better outcomes for children and families. Over the last 7 years, care management services for children have been consolidated under the health home model to streamline and simplify the children's system of care. OMH targeted case management in 2016, and then in 2019, 6 state waivers through OMH, OCFS, and OPWDD, all consolidated under the health home model. We are the pathway to HCBS and CFTSS services for children with serious emotional disturbance. We are the early intervention ongoing service coordinator for children who require the children's waiver and early intervention services. And most recently, we are the solution for OPWDD for children under the age of 5, as it has become increasingly difficult to qualify for those services. For our members, ED visits have decreased, inpatient stays have decreased, primary care visits and annual dental visits have increased. We have worked closely with our managed care plans to close gaps in care and have been so successful that CHUNY is the first health home to engage in a risk-based contract for value-based care. Without a plan in place at DOH to implement this cost savings, we question how the integration of health home services within the overall children's system of care will be addressed. The result would not be a restructuring, but rather a complete destruction of a program and infrastructure we have worked so hard to optimize.
Thank you very much.
Thank you for your time.
Next.
Thank you.
Children's agenda.
Thank you. Sorry.
I think your microphone.
Put on your mic. Yeah, green.
Right.
Oh, hi, I apologize for that. I wasn't tracking what order we were going in. So I'm Bridget Hurley from the Children's Agenda and the Kids Can't Wait Coalition. I thank you for the opportunity to speak with you today. As you know, across the state, infants and toddlers with developmental delays and disabilities are languishing. They're regressing as they wait for EI services that an evaluation has determined they need, and federal law says they have a right to. They wait and sometimes, as you've heard, don't ever receive their services and they age out of the program. I'd like to share a few parent testimonials with you. A mother of a 3-year-old who waited months and months for EI services and only got one of the several that he was supposed to receive says developmental milestones could have been met if the services were met in a timely manner. It's a federal right for services to be met in 30 days, so I don't understand why this isn't happening. I just ask you and urge you to think of my son when he wasn't able to get his services for early intervention, and also countless other families in New York State who are still waiting for these crucial services, and how agonizing and frustrating it is when these services are not able to be met. A mother of 5-year-old twins who benefited from early intervention services says, I am so passionate about these services and fervently believe that my twins are doing as well as they are because of the work that their therapist did with them from when they were only a couple of months old all the way through when they were 3. We put in the work. We worked with the therapist, and the twins are doing just exceptionally well. I can't imagine how it would have looked different if we had had to wait any longer than we did. There's plenty of evidence that New York State's early intervention program is in dire need of significant investments. A couple of pieces of evidence. The most common EI services are reimbursed now at a rate that is lower than they were in 1994. The percentage of families receiving services on time has dropped from 78.3% in 2014 to 53.9% in 2022. As of August 2023, at least 7,360 children were waiting for services, reflecting a 28% increase since 2022 and a 500% increase since 2020. The Kids Can't Wait Coalition is pleased with the executive budget that includes a 5% rate increase for in-person services and a 4% modifier for services delivered in rural and underserved areas. It's a good start, but it's not enough.
Thank you so much. Next is Lauren Spicker.
Good evening, and thank you for your continued attention after this very long day. Today, I actually hope to generate more questions than I have answers for. I am Lauren Spiker, the founder of 1330 Cancer Connect, a nonprofit based in Rochester, New York, representing the 90,000 teens and young adults who are diagnosed each year with cancer in the United States. That's one young person every 6 minutes who hears the words, "You have cancer." Every 6 minutes, a young life is interrupted, and for far too many, that interruption is forever. 23 years ago, our 19-year-old daughter, Melissa, was one of those young people. Yesterday was her birthday. Despite 2 years of aggressive treatment, Melissa lived an extraordinary, albeit far too short life. I don't have nearly time enough to describe her, so I'll skip ahead to just 3 nights before she died. Late that night, I told her how proud I was of her and thanked her for all I had learned from her. In response, she issued me a challenge, which brings me here before you today. If you learned anything from me through all of this, she said, do something with it, something to make a difference, to make things better. I founded 1330 Cancer Connect to keep the promise I made that night. And we are making a difference. With 2 physical centers in Rochester and Syracuse, we help AYAs, adolescents and young adults, between the ages of 13 and 39 develop a new peer community of others who understand, who get it, something Melissa never had. Our mobile wellness apps and virtual programs help AYAs across the globe better manage the debilitating effects of their cancer. Our clinician and educator workshops help providers deliver more effective care, and our advocacy efforts heighten awareness of the unique challenges facing this group. But much more needs to be done as the incidence of early onset cancer is projected to rise by 31% by 2030. Today, on behalf of the over 5,500 teens and young adults diagnosed each year in New York, I ask you to allocate funds to bridge the gap into which AYAs still fall. Specifically, funding is needed for AYA research, widespread public awareness campaigns, more effective continuity of care protocols, and additional community-based support services like those provided by 1330. I urge consideration for changes regarding insurance coverage and reimbursement, educational and employment protections, expanded tax credits, and perhaps new health-related incentives. For my organization, I ask for funding for a project that we are in the middle of to coordinate services in our community.
Thank you very much.
Thank you.
Maggie Dixon.
Good evening, Chairs Kruger, Pollen, and Rivera, and esteemed members of the legislature. Thank you for the opportunity to testify before you today. My name is Maggie Dixon, and I am the Director of Public Policy at the Alliance of New York State YMCAs. We represent 36 YMCA associations and 140 YMCA branches across the state to provide Ys with the resources necessary to make the greatest impact on their communities. At the heart of community, you'll find your why. We focus on empowering young people, improving health and well-being, and inspiring action in and across communities. The Y has a long history of deploying programs and services to meet the needs of communities, including childcare, after-school, and out-of-school programs, such as camp and swim sports and play opportunities, housing for low-income individuals, and evidence-based health interventions. The primary purpose of our testimony today is to highlight the role YMCAs play as a community-based partner. In proposals included in the executive budget, such as New York Swims and school-based mental health clinics, we emphasize the role YMCAs could play in robust implementation of the governor's proposals. CBOs would help to ensure every child has year-round access to programs. We are grateful to the legislature for the $1 million line item we receive every year, which enables Ys to continue their community-based programs, including childcare, water safety, and public health initiatives. This year, we are requesting a $4 million increase for a total of $5 million to ensure Ys can continue to support communities across New York State. Finally, previous panels have discussed the cost of chronic disease and the overwhelm hospitals are facing. YMCAs implement evidence-based chronic disease prevention and health management programs, which are listed in my written testimony, and we look forward to partnering with other CBOs in assisting with social care service navigation and health-related social needs in accordance with the 1115 Medicaid waiver to achieve collective goals to reduce health disparities and improve health equity. The Alliance appreciates the support of the New York State Legislature and looks forward to continuing to act as a partner. Thank you.
Great. Is it evening? Good evening. Thank you all for your patience today. I just, my Rochester folks here, I have to just give a shout out and say, Lauren, you did an amazing job. And I think we all agree that your daughter would be very, very proud of the way you represented that. And I think it's a lot that we need to think about in terms of where we can put some more priorities and allocate some more funding, especially for our young people. So I just want to say thank you so much for making the trip. I also wanted to ask a question around the early intervention. So I think I saw some of you in the audience. You spent some time listening today. And, you know, when we brought this up to the DOH commissioner, he said, we're lucky that there's an increase at all in a year like this year. And of course, the first thing I thought of was, well, I don't know if we're lucky because it's not exactly what we need. I think there needs to be more of a reimbursement rate increase. But also, there's the lack of consideration of what this will cost down the line when we fail to offer these early intervention services. So I would love for you, and I open this up to anyone up here around early intervention, of talk about the costs that we end up inevitably incurring later down the line when we fail to actually provide these services to young people when they need them.
So I don't have the numbers in front of me right now, but could get those to you around the cost of preschool special education, and then K-12 special education. But I can say that it's far more than the cost of a year or 6 months of EI that might prevent a child from needing those services. And I think we also need to take into account what I'm hearing from preschool teachers and preschool special education teachers is that children are coming to them with much greater needs, many of them because they have not had sufficient EI services. So they're needing even more resources than they might normally. It is penny wise, pound foolish to not be funding these services fully.
Thank you. You want to add?
If I could just add, we pay now or we would pay much more later.
Yeah.
I don't have staff to give you, but I'm a psychologist and I've evaluated many children. I can think about one child who was severely autistic at age 2.5, and the mom called me 3 years later. There were no signs of autism. Kids do get better, and they can get a lot better with the help early.
Thank you all. I'll give you those 20 seconds back.
Thank you. Assemblymember Rodney's Bishant Hermelin.
Hello. Thank you all for coming here today to testify and advocating on behalf of all of our children. Thank you so much. I am a new mom, and I've also had concerns in terms of the resources as it relates to early intervention. Very often, all of us, when we're born children into this world, hospitals, and then trying to get them childcare, we just don't know what stage they're in. We don't even know where to get the resources because the topic of early intervention is just not mentioned at all. And as we're talking about reimbursement, and my colleague Senator Brooke mentioned addressing the vital concerns about that, I had a question about the racial and geographic disparities as it relates to early intervention and reimbursement and services. Can you tell us a little bit more about that? I know for me, literally, I'm having my child being evaluated, and I didn't even know to do or how to do. It was just a referral. And so in my community, which is a community that's majority Black and Brown, low income, the vast majority of the members of my community just don't know anything about early intervention. So can you tell us a little bit more about the racial disparities as it relates to the reimbursement?
Yes, the Bureau of Early Intervention released a report in August of 2021 that described the data that they had collected on racial disparities, and children of color are referred at lower rates and wait longer for services and are more likely to not receive services. So it's an area of great concern of ours. One of the things that we want to make sure is that the services are delivered in person whenever that is appropriate for the child, which is most of the time. And right now, there are a lot of children, particularly children in certain areas of our metro areas, that have no opportunity to receive services in person. They're only offered telehealth, and part of that is because providers, preferring to provide telehealth rather than travel into some of the neighborhoods. So there's definitely disparities. We are happy to see that the executive budget includes a rate modifier that would incentivize providers an additional 4% on top of the 5% for underserved areas and rural areas, and we think that will help.
Thank you.
Assemblymember Gandolfo.
Thank you all for your testimony, and Ms. Spiker, thank you for sharing your story and what you're doing to honor your daughter's memory and your advocacy. We've seen it in many different areas that the peer-to-peer kind of connection really does help people get through some tough times. You were cut off a little bit during your testimony about the capital, some of your capital needs. Can you expand on that a little bit and how we might be able to help?
Thank you for giving me a few extra seconds. One of the biggest problems that we see with the kids we serve is their challenges are so unique and they cross so many important transitions in their lifetime that services and programs for them are not coordinated. They fall into lots of siloed pockets, and nobody really understands what their very unique challenges are, especially as they transition from pediatric to adult care. So one of the projects we are currently working on in collaboration with University of Rochester Medical Center and Rochester Regional Health System is to build a coordinated and comprehensive delivery of care service by which our AYAs and their caregivers would have access to providers who understand their very specific challenges. And for that, we have just started preliminary needs assessment. But I think that is the biggest thing that I would ask for from this body is to help us fund a widespread needs assessment, because we really don't know what the unmet needs of our adolescents and young adults in our communities are, because we just have never studied that. So this pilot program that we're starting in Rochester, I would love further support for.
Thank you very much.
Senator Cooney. Green. Yeah, press hard.
That's my Rochester. There we go. Hey, yo. Thank you. Bridget, thanks so much for making the trek here, and we appreciate all the work that the Children's Agenda has been doing. Wanted to focus in, of course, on my passion, which is the child tax credit. I know last year we finally made that sensible change to make sure that children under the age of 4 were included in the tax credit. We're starting to hear some positive things on the federal side. We'll see. But hopefully you could share with us the impact in upstate cities specifically if we were able to increase that benefit to families with one or more children, what that would look like in terms of their quality of life and reducing poverty rates across the state.
Sure. So we are Children's Agenda supporting the broader tax credit that's now been introduced, and are hoping that implementation of that will produce the effects that we've seen over and over again, both in Rochester and around the country and the world, in terms of the increase in family well-being when they have an increase in income. So that's going to affect children's health, children's social emotional well-being, and we are very hopeful that this year we'll be able to get even more significant gains in the tax credit for children and families.
And has there been studies that have shown how families have utilized those dollars? I know that it's a little bit awkward in terms of the fact that it comes from a tax credit side versus, cash flow throughout the course of the year. But have you done research in terms of how families have utilized that money? Is it for rent stabilization? Is it for healthcare needs? Could you comment on that briefly?
Right, sure. So we had our own little experiment really in the United States, right, with the pandemic and the increase in the child tax credit. And what we know from that is that it was spent on food, it was spent on housing, it was spent on enrichment activities for children. So it's exactly what you would imagine if you were given, if you had a child and you were given money for, to invest in your family. Families invested in what's best for their long-term health of their children. So,
But we're certainly hoping that New York families will have that opportunity this year. So we thank you for your support. Yield back my time, Chair.
Thank you very much. Um, Assemblymember Kellis. No. Oh, Josh, I keep looking at you. Sorry.
It's all right.
Yeah. Assemblymember Jensen.
Thanks.
Keep skipping him.
We look very similar.
Yeah, very similar. So
At
my
this
question,
hour, you do.
my question is for Ms. Spiker. In your oral testimony, you talked about seeing a increased incidence of cancer for the AYA population. What are the causes for that increase, and what can be done to mitigate those risks?
The first part to that question is we really don't even have a clear idea of what causes adolescent young adult cancer to begin with. And as for the increased incident, which is projected, most of it is lifestyle causes, diet, sedentary lifestyle, perhaps environmental exposures. Some of that projected increase could be because we have done a better job of early screening, so perhaps we are identifying some cancers earlier. But within those suspected causes, there are lots of opportunities for public awareness, for the folks in our age group to be more aware of those kinds of challenges, for primary care physicians to better understand some of the late effects that challenge our kids even post-treatment. So there are opportunities with regard to primary prevention, early detection, and then also survivorship issues that would hopefully try to mitigate some of those risks.
I know in previous conversations you and I have had when we look at the care continuum and where medical research is being conducted, there's a focus on the youngest ages, the middle ages, and elders. But yet there's a dearth of medical research going on with the AYA population. Is that something that, whether it's at the state level or working with our federal partners, we should be encouraging greater amounts of research, especially as we see the increased incidence?
Yeah, absolutely. It wasn't until not too long ago that we thought about teenagers as being different from young children and young adults as being different from older adults. So there has been very limited research with regard to the cancers that our kids get. So there are great opportunities for us as a community-based organization to partner with our academic research partners. Really, I think has the best hope for us to really get at what are some of the issues and how can we best support this group. So we would love support for AYA targeted research.
And certainly right now your organization doesn't receive any state funding for any of your operations. Would even a little bit of allocation help to not just meet the needs of this population in Rochester and Syracuse, but also set new goalposts for how we can affect this population for the better statewide?
Yeah, absolutely. I'm really new to this whole state funding process. So yeah, a little bit would go a long way. Thank you.
Thank you, Lauren.
Now, Assemblymember Anna Kellis.
Thank you. Thank you so much for all of the work that all of you are doing. This is so important. EI I am particularly passionate about because we do know, of course, child development, the brain development during the first 3 years of life is, sets the stage for the rest of our lives because that's when a lot of the synaptic connections are being built, the 0 to 3 period. So, incredibly important. So thank you so much for that. One of the concerns that I have, well, two things. One, do we have a geographic layout of where kids are being served and where there are the greatest gaps in those who need it, who are not currently being served, who would be eligible for EI? Do you know, does that exist? Has that map been created?
I believe that exists within the Bureau of Early Intervention and Department of Health. It's not publicly available because we have asked for it.
That's why we haven't seen it. All right,
Yes,
I will ask for that. That was one question that would give a really good sense of how to target. My second question is actually continuity of care. What I am seeing in my district, there was a case that was just brought to me recently that was very disturbing, which is that even if kids are able to get EI, because of the different ways in which they are funded once they hit pre-K, because the EI is state state, but pre-K then shifts into both district and county. And if it's just county, then the providers can't provide if they are in the school. And in rural areas, they don't exist outside of the school. So you end up with a tremendous lack of continuity of care. Have you seen with all of the children that you have in EI, have you been able to create a transition for them or continuity of care? Are you seeing as well as I am in my district, particularly in rural areas, a tremendous disconnect where a lot of them fall off, even of those who do get EI? So it's an extension question.
Right. I don't want to speak as if I'm knowledgeable about different areas of the state and how those transitions happen. I can tell you that there are that it is an issue. I speak with families all the time who have trouble making the transition because you're going from Department of Health to state to the education system, and there are families who just, as you said, don't make it through because you have to have an entire new evaluation.
So you are seeing that.
So there's definitely an issue with transition. Yeah.
I don't know if you had anything.
The answer is yes. There's a lot of issues with transition. We're in New York City and Westchester. Absolutely needs more to be done to smooth that out.
Just wanted to see if you were
all over
seeing
the
that.
state.
Great. Thank you.
Yes, Assemblymember Roth.
Thank you. Thank you all for your advocacy on behalf of our state's children. Ms. Spiker, you started to get into this with Mr. Gandolfo a little bit, but just, the continuum of needs that this, a population like young adults with cancer have in terms of, their education, their development socially, I'm sure mental health. So what can the state be doing to help make sure that those needs are met with that population, in addition to obviously the obvious treating the illness, but there's all these other things that I'm sure they're missing in their development.
One primary solution that would definitely help would be provider education. If we could do a better job of educating primary care physicians, both at the pediatric and at the PCP level on the adult side, of the very unique challenges facing our teens and young adults, that would go a long way to help as they transition through different levels of care. With regard to mental health in particular, I oftentimes will have one of our members say, I really need some help because this is really hard, and it's really hard when you're this age. You haven't got your life figured out to begin with, and everything gets turned upside down and interrupted. I would like to be able to refer through some sort of a coordinated network, as I spoke about earlier. I would like to be able to refer our kids, they're always kids to me, to a mental health counselor who understood that kid's unique challenges. I would like to refer them to a primary care physician as they transition into survivorship care, to someone who is aware of the late effects that they might suffer. So provider education is one very, very big area of need.
And your written testimony, you talked about there's increased likelihood for secondary cancers in this population. So what is the kind of, how should we be approaching that? Does there have to be more clear guidelines of what else these patients should be screened for after a certain amount of time?
Yes, and yes. There needs to be guidelines. There needs to be standards of care. Like I said, until recently, we really hadn't even. There wasn't even a discipline called AYA oncology. So we really need to start from the ground zero, especially at the New York State level. We could really kind of set the pace for trying to identify and assess what are the needs and what should we be doing. So the task force that I suggested before would be a really great start.
Thank you.
Good job, everybody. You too. It's nice to meet you.
Oh, it's green. It, thank you up there. Medical Panel G, Medical Society of the State of New York State Nurses Association, New York Society of PAs, Physician Assistants, and Associated Medical Schools of New York, and CWA District 1. Okay, so I think we do have 5 chairs. We'll let everybody get here, and we will go in the order that we have called you up in. Oh, sorry. The paper. Making a mistake, Gustavo. Sorry, everyone. I am trying to wake everyone up. Okay. And then for people who are still here to testify at the panel after this, panel H, you might want to head down towards the front. So we'll just move things along. Good evening, everyone. And I guess we're calling on the Medical Society of New York first, Dr. Jerome Cohen.
Thank you. Good afternoon. I am Dr. Jerome Cohen, Senior Attending Gastroenterologist for the Bassett Healthcare Network in Cooperstown. I am also President-elect for MISNY, which advocates for more than 20,000 physicians practicing across New York. Thank you for the opportunity to testify. Our written testimony highlights several positive items in the budget to expand access to care, including investments in the patient-centered medical home program, further medical student loan repayment, telehealth payment parity, and expanded health insurance subsidies. However, our testimony also reflects strong concerns with other proposals counterproductive to maintaining patient access to community-based physician care, including eliminating MISNY's Committee for Physicians' Health program, imposing $40 million in new costs on physicians for excessive medical liability insurance coverage, and a series of proposals to remove physician oversight and collaboration. Some of these proposals will actually make it harder for physicians to remain in practice to deliver patient care. At a time when physician burnout is continuing to rise, it is senseless to repeal the Committee for Physicians' Health program. This long-standing program has helped thousands of physicians suffering from behavioral health challenges or addiction and has been routinely extended by the legislature in 5-year increments over the last several decades, including last year's extension of the program until 2028. In fact, the governor's initial budget proposal last year was for a 10-year extension. It is important to note that CPH is not funded from general appropriations, but by a $30 surcharge paid by physicians themselves in their biennial registration fee. We also urge the legislature to again reject the proposed requirement that the 15,000 physicians enrolled in the excess medical malpractice insurance program bear 50% of the cost of these policies. This would thrust nearly $40 million of new costs on the backs of our community-based physicians, many of whom are struggling to stay in practice to deliver needed care at a time when they are already face staggeringly high liability premiums. The end result is that many physicians will simply forego this coverage in order to avoid these new costs. This proposal has been rejected in previous budgets because of its adverse impact on the patients who are the ultimate beneficiaries of this program. Again, there are numerous concerning items in this budget that will reduce patient access to community-based physician care and remove important oversight and collaboration provided by physicians that better ensures patient safety. We urge you to prioritize expanding access to skilled primary and specialty care physicians instead of imperfect solutions that seek to replace them. Thank you. Those are my remarks. Thank you.
Thank you for the opportunity today to weigh in on the budget. NISNA has 3 or 4 priorities in terms of the budget. Obviously addressing equity issues, expanding coverage, addressing the funding problems, especially of safety net providers, and of course addressing the staffing crisis. The budget has a lot of measures that take steps, positive steps, in addressing some of those core concerns for NISNA, but it doesn't go far enough. Obviously, we join in with the other unions and other providers who testified very eloquently and forcefully today about the need to increase, to deal with the Medicaid gap, for example, particularly for safety nets. But I want to focus, and there are some positive measures to expand coverage. Again, it doesn't go far enough. We would advocate that the state consider the New York Health Act, which would address, I think, not only universal coverage, but also quality of care and also the funding problems. But I want to spend the last minute and a half that I have left focusing on the staffing shortage issue. And I want to clarify right at the beginning that New York does not have, when it comes to RNs, but I think this applies more broadly, New York does not have a shortage of RNs. What we have is a shortage of RNs who are willing to put up with the atrocious working conditions, the lack of pay, the lack of respect, the mistreatment that they face on a daily basis, and the frustration that they can't do their jobs properly because they're understaffed. And I think the data is pretty clear on this. When you look, for example, at the number of active RN licenses in New York, in 2018, there were 305,000. In July of 2023, there are 394,000. That's a 30% increase in active licenses over the last 4 or 5 years. The workforce, though, is pretty stagnant. It's only gone up by about 4%. So what that tells us is that your nurses are coming in, they're getting licensed. We have licensed nurses. But as soon as they come into the workforce, they go out the back door because the high turnover rates, high levels of frustration, poor pay and benefits are all contributing to this. At the end of the day, the two proposals that the governor aims to address the issue. One is the Interstate Compact, which we've already been doing it for the last 3 years, and it had absolutely no effect on the nursing workforce, right, during all the suspensions.
Sorry,
All right.
move on. Thank you. Next, we have Edward Mathis.
I'm just going to break away for a moment and echo what this gentleman had to say. My wife is a nurse, and this is what I hear every day when she comes home. Good afternoon. Thank you for having me today. My name is Ed Mathis. I'm a practicing PA in Rochester, New York, and I currently serve as president of the New York State Society of PAs. I would like to address the pressing issue, as everyone else has today, of the workforce shortage, but also advocate for crucial reforms that will enhance the role of PAs in addressing the challenge. Governor Hochul, recognizing the vital roles PAs play in the healthcare delivery, included provisions in her HMH bill that will allow PAs who have met a high standard of education, training, and experience to opt into, not required, opt into working without the administrative construct of physician supervision in primary care settings and Article 28 facilities. It would also remove limitations on the number of PAs a physician can supervise in certain settings and clarify prescription privileges and allow school districts to hire PAs as directors of school health services. The shortage of primary care clinician adversely affects patients statewide, but is felt more acutely in the rural and marginalized communities of our state. PAs offer a valuable and readily available source of highly educated clinicians with a long history of serving in these communities. Under the auspices of Executive Orders 202 and 4, which removed physician supervision during the course of the pandemics, PAs showcase their ability to practice at the highest level, collaborating seamlessly with the entire healthcare team, including our physician colleagues. This flexibility empowered PAs to meet challenges and provide high-quality, safe patient care in diverse settings under extreme conditions. It also allowed healthcare systems to more efficiently and effectively deploy PAs where they were needed the most without the administrative burdens associated with identifying a supervising physician. With the expiration of EO4 in July, all those obstacles were reinstated, creating challenges for patients, PAs, and healthcare institutions. The number of phone calls I get a week from PAs out in practice who are meeting these is tremendous. New York hosts 30 PA programs and faces challenges in retaining graduates, removing administrative barriers, and allowing PAs to practice unencumbered by administrative rules that have not kept pace with the PA's evolving role in healthcare is crucial for recruitment and retention. In conclusion, Governor Hochul, recognizing the vital roles of PAs in healthcare, proposed reforms in her fiscal year 2024 budget and would remove barriers to providing safe, efficient, cost-effective care.
Thank you
The New
very
York-
much.
Thank you.
Next is medical schools.
Good evening to the chairs and members. Thank you for the opportunity to testify this evening. My name is Jonathan Tangen. I'm the CEO of the Associated Medical Schools of New York and our sister organization, the New York State Academic Dental Centers. Collectively, these two organizations represent and work on behalf of the medical and dental schools in the state. I really wanted to focus on two areas with my comments, one having to do with our physician workforce and the other having to do with our scientific workforce. And we had a lot of very good conversation today about health equity and addressing health disparities, and I think rightly so. This is clearly an area, particularly coming out of the pandemic, which really uncovered and highlighted for many folks the need to address health disparities and the sort of uneven and unequal kinds of care that many communities get. And so I really wanted to focus on one program that has worked exceptionally well in helping to address this for many decades, and that's the Diversity in Medicine program. This program's now, we're in our 33rd year, and I was really pleased to see that the executive, Governor Hochul, in her budget proposal, has allocated $3.6 million for the Diversity in Medicine program. This is level funding from last year, but actually represents over the last 2 years, effectively tripling the state's investment in this. And what these programs do is really provide a pathway for really talented students who have faced adversity on the path to medical school. And so, this may be socioeconomic disadvantage. This may be having come up through under-resourced school districts. They may be first-generation college goers, but they need supports. And so these programs, we now have 19 programs around the state supporting more than 950 students to come into medical school and eventually graduate and practice medicine in New York State. The legislature has also has taken the lead on funding the scholarship, the Diversity in Medicine Scholarship Program. Increased funding last year to $1 million. We are now supporting 33 students with the equivalent of SUNY Medical School tuition. And so we really just want to firstly thank the governor for her investment and urge the legislature to continue to invest in these programs. And very briefly, with my 15 seconds, I would just highlight the importance of, again, our scientific workforce. The executive budget actually did propose to eliminate the Empire Clinical Research Investigator Program, ECRIP. We think it's a very valuable program, which we'd like to see included in the enacted budget.
Thank you very much. Last but not least.
Hi, everyone. Good evening. Good to see all of you. Thank you so much for the opportunity to testify this evening and going on over 8 hours. I appreciate your attention. My name is Rebecca Miller. I'm the New York State Legislative and Political Director, and I am here on behalf of the 15,000 healthcare workers that we represent in New York State, 65,000 members overall. Primarily in Western New York is our healthcare membership. We're the largest union in Western New York, healthcare union. I'm here today. We've heard about a number of issues, many of which are intersecting. There's two I want to focus on. The first is the significant underfunding of our hospitals. I think we've heard it all day. The healthcare system is broken. We need additional funding. This is true. We agree. But I want to come at it from the perspective of the workforce. And I want to echo my colleague from NYSNA. We are not dealing with a workforce shortage. We don't have a lack of bodies. If you can get a traveler in for 3 times the pay, a body is available. But people don't want these permanent jobs. They're not willing to stay in these conditions because the jobs are very difficult. They cause moral injury. And it is extraordinary that we have a healthcare workforce in existence at all, given the conditions our members are forced to work in day after day. So when we talk about a workforce shortage, we often focus on the fact that there are vacancies, which leads us to think that these are hard to fill positions and that there are not enough workers. But I want us to switch the framework to understand the conditions we're asking our healthcare workforce to work under and think about what we can do there. This is a circular problem. The number one issue forcing healthcare workers away from the bedside, a job that folks go into because they care and because they love it, is short staffing. And it's circular. The more short staffing, the less staff, the more short staffing. And so there needs to be an immediate infusion of cash to stabilize the workforce. Unfortunately, the proposals needed are not included in the budget this year. There have been many attempts over the past few years to increase the workforce pipeline. This is great. We should keep investing in those programs, loan forgiveness, for example. But we need to add an immediate infusion to stabilize this workforce, or you're going to continue to see that spiral downward. Part of this is driven by an economic incentive of hospitals that are not being reimbursed for care. So if they don't have enough funding, you heard it all day long. What did they say was the biggest cost? Labor. So the incentive is to continue to reduce labor, which reduces care. Not good. So what I would like to suggest today is, of course, the full funding of Medicaid. That 30% gap, it needs to be closed. It is the way to structurally fix this for the long term, so you're not constantly putting in these one-time buckets of care like FAPAP, right? These are things that are one-time infusions of cash. We need something stable. In addition, there needs to be additional proposals that will work for the workforce. Lots of ideas on this, but I only have 7 seconds, so we can talk about it offline. But thank you all so much.
Thank you very much. Any senators like to ask questions? Yes, I see an arm down there. Is that Zelnar Myrie?
Thank you, Madam Chair, and thank you to the panel for your patience and endurance. I know that it is not easy to have the uncertainty of waiting for many hours, so thank you for that. I wanted to ask the medical schools, but firstly, thank you for the support of the Diversity in Medicine program. I will give a shout out to my brother, Senator Bailey, who has been a champion on this issue within our conference. I'm wondering if you have heard or if you personally hold any concerns about what we have seen out of the Supreme Court of the United States and whether that will have any implication for the program, and subsequently if we should be acting as a result.
Yeah, thank you for that, Senator. So right, the Supreme Court decision in June of 2023 really changed the landscape for admissions in higher education. A little bit less concerning on the medical school side because medical school admissions has really focused on holistic review for more than a decade now, which is looking at the totality of applicants and relying less on sort of checkbox kinds of information. But I will say that we have been looking and working on this intently for the last 6-7 months on making sure that the way we approach our diversity in medicine programs and the way I think we collectively approach making sure that we're providing pathways for all sorts of folks into medical school is that we are being holistic and we're looking at larger factors. We're not simply looking at things like race and ethnicity, but we're considering the entire, the obstacles that students have overcome. We're really looking for resilient students who have faced obstacles, and that resiliency really is going to impact how they practice medicine. So we've been working on that intently, and I would say also that we have seen other states begin to scale back similar sorts of initiatives. And I think we have an opportunity in New York to really sort of, galvanize our position that we think that this is important because this really does result in better health outcomes for New Yorkers when we have a diverse physician and healthcare workforce.
Thank you for that. And I know I'm going to sound like a broken record, but certainly SUNY Downstate in Brooklyn that produces the most medical professionals of color in the entire city of New York. There's no other institution that trains more. And so I think it's just incredibly important that we keep that context in mind. And thank you again to the panel for your patience today.
Thank you. Assembly?
Assemblymember Ed Brock.
Good evening. Thank you guys for waiting around. Um, on the diversity in medicine scholarship, you talked about that $1 million providing. You said 33 students.
Correct. Yes.
So, based on your experience in this program over the years, what does that mean? What types of things and where are these students practicing? I'm sure they're having a great impact on our state.
Yeah. We have some data. The program was actually launched in 2018. So many of the students are either in medical school or they're in residency, and so they're not. We have a few students who are now they're not students anymore. They're out practicing medicine. But there's a commitment by everyone who receives this scholarship to stay in New York for at least 2 years and practice medicine in an underserved area. And so we think this is really important. The longer people stay in an area and they start to put down roots. Our goal here is we look at students who are New Yorkers. They're domiciled in New York. We want students who are obviously in medical school in New York. We'd like them to do residency in New York and then stay and do this service commitment and then really put down roots. So our long-term goal with this program is that we're taking care of kind of the debt obligation that looms over so many students and affects their career decisions, and we're providing them with an opportunity to practice in shortage areas. So we think this is a long-term investment in a homegrown physician workforce.
Excellent. And you got into right at the end the Empire Clinical Research Investigator Program.
Yeah.
So if you can give us just a little bit more of, more about the program, the benefits that it provides, and the reasons why we should be restoring it.
Yeah. So the ECRIP program it supports young, early career physician scientists and gives them an opportunity to really get deep experience doing clinical research. We think that this has a long-term benefit in their development. We see many physicians who both practice, who do clinical work, but they're also doing research throughout their careers. And we think this has a tremendous benefit. We heard earlier the importance of having a scientific workforce in New York to address issues like cancer. Having a robust scientific workforce leads to better health outcomes, provides access to clinical trials for New Yorkers. So this program is fairly small, $3.5 million, but very targeted, and we think is an important way of growing our scientific workforce.
Thank you.
Okay, thank you. Any other senators? Then me. Hi. So representing the medical school. So I'd asked a question earlier. Are we? Oh, okay. After me, sorry. Are we doing anything to increase primary care physicians being produced, so to speak, by our medical schools?
Yes, I think you actually referenced the NYU Grossman Long Island School of Medicine earlier, which is a 3-year program specifically for students who know they want to go into primary care. This was launched in 2019. I think they enrolled their first class in 2019. And it's a great way to both get students through medical school. They're very clear that this is the path they want to take. It gets them through and into the workforce sooner. And programs like these, there aren't very many of them. This is a pretty innovative model. There are a couple around the country. It also is a way of reducing student loan debt so that they can come out and practice primary care, which is not as lucrative as other types of specialties or subspecialties. And so having that loan debt, not hanging over them allows them to go and practice primary care. And so that's a great model. And I think clearly a lot of our institutions are very focused on producing primary care physicians.
Thank you. And I guess many people talked about nurses, and I thought that the data on the fact that we have more nurses than we've had, they just don't practice as nurses. So I'm just curious with all of you. I'm always confused about this growth in the traveling nurse concept, because again, as you're pointing out, we actually have nurses, and perhaps they don't want to do these jobs because they don't feel that they're being paid enough or treated correctly. But we pay the traveling nurses much more, don't we? Is that my
Yeah,
understanding?
the traveler nurses rates were 2 to 3 times more than a regular staff nurse. The other thing with the compact proposal, I didn't quite get it out in my few
Yes.
minutes, but the compact, it's only good for increasing the use of travelers because it allows people to come temporarily, or it's good for outsourcing healthcare to non-union, low-wage states through telehealth. It would allow Texas nurses to treat New York patients under contract with for-profit providers. That's all the compact's going to do. It's not going to have any impact at all on the actual problems people are having recruiting.
So if we took that money, oh, I'm sorry, I didn't want to cut you off. But if we took that money that we're paying, two and a half times to traveling, and we use that money instead to improve wages and conditions for what we hope are permanent unionized nurses in our world, wouldn't that work better?
Yeah, I think what you're pointing to is that there is a subsect of the healthcare workforce that is willing to do these conditions. You know, they see the opportunity out there. You could do it for 3 times more. Why wouldn't I? In addition, you have a lot of the reason they do it is for the shorter temporary contracts. So yes, what you need is a model that stabilizes the workforce by using travelers until you're able to level out into a permanent staff.
And I have to cut you off. But again, everyone is welcome to give us more information after this hearing and would be appreciated. So thank you.
Thank you.
I have one more sound. You have one more sound?
I have two assemblies.
Go ahead.
Yeah. Assembly Member Jessica Gonzalez Rojas.
Just got to the top.
There we go.
Okay. Thank you all so much for your testimony. My question is both for Mr. Bell and Ms. Miller. Two things. Mr. Bell, you were cut off before you started talking more about the interstate compact, so I do want to hear your position on it, and as well, Ms. Miller, any thoughts? I know it's in the budget, and we want to see. I'd love to hear your position. And two, I'm curious how the safe staffing bill that we passed, I think 2021 or 2022, has rolled out, has it impacted? Sounds like conditions haven't been improved amongst the patient care and the overall stress in the job. So I'm just curious what was missing from that, or the rollout's been slow. If you can share some feedback there.
We could start there. So I will say that it's a new law. It has a phased implementation. The last phase was actually making these staffing plans and enforceable in 2023. So this has been the first year that it's been in full effect. I think, therefore, it's early to tell. I can tell you that there have been some places that we have seen the theory of the law where you collaborate between management and healthcare workers for adequate staffing work. And there have been a lot of places where it hasn't. I think at this point, in November, you may have seen CWA filed 8,000 violations of the clinical staffing committee law. This is probably an absolute small fraction of the number of violations that occur every single day, including the sickest of the sickest in ICUs with, instead of 1 to 2, you're talking 1 to 3, 1 to 4, 1 to 5. So, and these are happening in hospitals that we would go to. So, in our areas, in our communities. So, I think it's a little early to tell on the efficacy of the law, but staffing is an enormous issue. And I think what the state's role needs to be in that particular context is ensuring robust activist enforcement to make sure that law works. There's still opportunity to do so, and that's critical. Great. Mr. Bell?
Yeah, I would just add, I think it's very important in looking at especially from nurses, which is what, our perspective, but in terms of the staffing issues, it's very important to take a page from the doctors and not do any more harm, right? We have all these stressors on the workforce, and a lot of what's in the budget is just going to add to it. For example, the medication aids. If you look at the text of that medication aid proposal, forget about the patient care issues and other issues, the labor issues. Look at the text of that and look at how many of the oversight functions fall on the nurse, right? It's they have to train them, they have to assess them, they're responsible, they're legally liable for what those people do in terms of administering the meds.
That's not acceptable. That just adds to the stressors and that adds to turnover.
Thank you. Thank you so much.
Simply.
Yes, Mr. Jensen.
Thank you. So this question is for whoever wants to answer it. We've been talking about the nursing workforce, and one of the things that talking to folks in the Rochester community is that we have to increase the nurse pipeline, but we're also seeing a lack of nurse educators. Where can the state be more helpful in ensuring that we actually have the nursing educators to train the next generation of nurses, especially when you see nurses who are working in an acute care setting are losing a substantial amount of income to leave that setting to go into education? Is it increasing the Senator Patty McGee nursing faculty scholarship? What should the state be doing?
Yeah, I think there's a lot. We have a lot of concrete proposals, and we could certainly share some of them with you. I think one of the issues with the issue you're raising regarding educators. First of all, for example, public sector nurses who retire have an income cap. They can't, they could be a crackerjack nurse. They can't go and teach because they'll have to stop their pension in order to take a full-time or a part-time teaching position. The other issue is, I think, flexibilities, right, in terms of allowing experienced nurses who may not have a master's to teach because they've been doing it for 30 years and, they know how to do it and they know how to teach it. So the other factor I think that you need to look at is not just the education pipeline in terms of the formal training, but also the pipeline, the other side, the continuum of training and, maintaining and increasing the workforce is to cut into the turnover rates once people have graduated from school and they take these jobs in the hospitals and they burn out and you have 50, 60, 70% turnover rates in the first year. That means mentorship programs, that means support to keep those nurses in that transition phase, and and also clinical placements, right? Maybe looking at legislation to require hospitals and nursing schools that operate in the state to partner to provide clinical training spots so that we have the nurses who are still in school actually touching patients and getting some hands-on experience before they get thrown out onto the floors of their hospitals or their nursing homes.
So we talk about burnout, we hear burnout a lot. Are we seeing with the introduction of BSN in 10, where you have nurses who are actively working, yet having to fulfill that educational requirement, having to do them simultaneously and leading to even more burnout than just the working environment?
Yeah, that's a factor too. I mean, the BSN in 10, we had warned about some of the repercussions of this on the workforce, that it would add more burdens, and that's sort of played out to some extent.
Thank you.
That's what I keep. Thank you to all of you on the panel. I just have two quick questions. One for Naisna. So, in looking at your testimony, I wanted to lift up specifically your concern that you raised about the interstate nurse licensure compact. My understanding is that there's been some revisions to it, so I wanted to know kind of where things stood with that. And then my second question is for Rebecca from CWA. I wanted to get clarity on the number of complaints that you mentioned that have been filed with respect to the clinical staffing committee law.
Yeah, I'll just briefly on the compact. They did make a revision, I believe, in the last year or so that, interestingly, requires a state, if they move here to practice permanently, they have to reapply for an interstate license in the state to which they move. So that's the one change they made. Before, you could just sort of hop around and you never had to change your primary state of license. But that, again, it's really meaningless because at the end of the day, the licensure compact for nursing, and it's a little different for physicians, but for nursing, it basically will have no impact on the problems that we've heard described all day today. It's just meaningless in terms of addressing the workforce crisis that exists because people are leaving the profession, leaving the bedside jobs. And turn it over to.
We had 8,000 violations that we filed. That was for about 4 or 5 months statewide. And like I said, that was about a fraction. And we have additional ones that are continuing through the committee process and will be filed subsequently.
And if I could add just one comment on the compact, this isn't very discussed very openly, but it also gives attorneys general, state nursing boards, and other potential, elected officials in in other states, a foot in the door, not only to our nursing practice and our nursing standards, but also to such things as access to abortion, contraceptives, things like that, which in Oklahoma or in Texas are illegal. And a fetus may have personhood status, so that someone that performs an abortion under an interstate license in New York, are they liable to the foreign jurisdiction stepping in and saying, you've violated Texas law, and we're going to bring disciplinary charges against you and try to suspend your interstate license because of what you did in New York without having set foot or practiced in Texas. You're letting these foreign jurisdictions get their foot in the door on policy issues that they should not be involved in our state.
Thank you.
We're not allowed to ask them, so just under our own rules. So thank you all very much for being with us.
Thank you.
We know how to find you. You know how to find us. That's the best I can offer right now. So thank you very much. And our next panel is American Cancer Society, Cancer Action Network, Planned Parenthood Empire State Acts, or Empire State Fights Back, which is what I thought the name should be, and Hospice and Palliative Care Association of New York.
And you can speak in that order.
Yes.
Maybe not.
Right.
We're
Hello.
missing someone.
Okay.
We're missing American Cancer?
I think so. Okay, let's just start with Georgiana, please. Hold that button down until it's green. Nope. Press a little harder. You got it.
This really isn't my first rodeo, but I guess it is. Good evening. Thank you for the opportunity to provide testimony today. My name is Georgiana Hansen. I'm the Vice President of Public Policy and Regulatory Affairs for Planned Parenthood Empire State Acts. I'm here on behalf of our board chair, Tess Barker, who's unfortunately unable to attend. PAPESA is proud to represent the 5 Planned Parenthood affiliates who provide primary and preventive sexual and reproductive health care services to more than 200,000 individuals in New York each year. Yesterday would have been the 51st anniversary of the U.S. Supreme Court landmark decision in Roe v. Wade. As with any anniversary, it's an opportunity for reflection and an opportunity for action. We know that Roe, while critical, was a right in name only for far too many for far too long. We must continue to fight for a future where access to sexual and reproductive health care is a reality for all, where every individual has the power to shape their futures and control their own body. New York has an opportunity and an obligation to lead in this fight, to be bold and innovative in building systems of policies and care that are anchored in equity, to make strategic and critical investments that support providers who are burdened by the rapidly rising costs of care, and to ensure unfettered access to care for all who need it. It is in that frame that I want to briefly uplift 3 key issues for your consideration in the enacted budget. First, we respectfully request an increase to the Medicaid reimbursement for the office visit associated with the provision of medication abortion. Last year's budget made critical investments in reproductive and sexual health care services, but it failed to include a significant component of abortion care, medication abortion. Medication abortion comprises roughly 64% of the abortion care New York Planned Parenthood affiliates provide. For 3 of our upstate affiliates, it's over 70%. Unfortunately, the reimbursement providers receive in Medicaid for this service falls significantly short compared to what it costs them to deliver this care. This widening gap makes it incredibly challenging for providers to invest in expanding access to care, let alone meet present need. Over the past several years, many states have raised Medicaid rates for abortion services, recognizing the need for intentional investment in the face of sustained attacks on abortion access. As a result, our reimbursement levels for medication abortion are out of alignment with these access states like California, Illinois, Vermont, and Oregon, all of which reimburse significantly above New York's rate. An increase in the Medicaid reimbursement rate for medication abortion is necessary to ensure providers can not only continue to deliver, but expand access to essential health care. Additionally, we ask the enacted budget include $35 million in grant funding for abortion providers and $1 million for abortion funds to increase access. We strongly support the $35 million grant investment in abortion access proposed by the governor. Further, we ask the legislature to include an additional $1 million to be directed to organizations addressing the practical support needs of people seeking abortion care in New York and ensure passage of the Reproductive Freedom and Equity Program. Thank you.
Thank you. Next.
I must have strong fingers, first time. I just want to thank all of you for what you do every day. Thank you to the senators for offering an opportunity for the Hospice and Palliative Care Association to be here today. And so much time has been spent today discussing the crisis of the hospital systems, and I have to say that's a rightful use of the time here. But what I also want to say is the answer is not allowing the expansion of hospitals into the home. And right now, we are going through something that's not theoretical, it's actually a reality, where the 1115 waiver and the 2805X waiver that has been contained in the budget is being utilized to circumvent the Certificate of Need process of New York. In December, the Department of Health Commissioner approved the expansion based on a hospital hospice collaborative, expansion of the hospice into 2 additional counties. Those counties were not on their original license, and they did not have to go through the CON application process. They did not go through FIPIC process. There was not public comments allowed. This was through the 2805X waiver, and we see this as a threat to the home-based community providers that exist in your communities. We ask that you seriously look at the policies that are being put in the budget related to 2805X and reject those changes until the Department of Health and Commissioner are required to follow public notice, Certificate of Need, and the Master Plan on Aging recommendations that the governor herself requested be done in the end-of-life work group, of which I am the chair. The group recommended Certificate of Need task force to do a full review and to update the need methodology. We also ask that you hold the Department of Health to their word and create the Center for Hospice and Palliative Care. Even though the governor vetoed the bill you approved, the Department of Health said they are going to implement it, and we hope that you make sure that the budget includes that. And finally, please remember that everything that is done in these budget meetings that are focused on Medicaid do indeed impact the Medicare providers, and consider that through workforce as well as other initiatives. Thank you so much for your time.
Oh, I'm trying, thank you. So this discussion you just brought up about cutting around the CON, was this to approve for-profit hospice programs?
Nope. This was actually to allow a current not-for-profit expansion without going through the process.
So you wouldn't necessarily oppose groups because they might even be members of yours. Am I right?
Yeah, the issue is more concerning about the fact that there was no need methodology utilized. There was no proof that there was a need. It's an opportunity for the hospitals to put together a value-based purchase without using the existing providers. They were not considered in the application.
Got it. Okay. Thank you.
Yes.
Thank you. And Georgiana, you were here a minute ago when previous panel brought up the question about whether joining the compacts might put at risk our ability to have providers continuing in reproductive health if they were, I guess, part of a national licensing model and telehealth model. Were you aware of this issue, or can you look into it first?
Yeah, so we don't have a position at this time, but this is a whole new landscape legally around abortion access and the impact on providers. So it's something that we're taking those concerns seriously and looking into.
Okay, thank you. Assembly.
I'm actually going to go first this time. So are you talking about in the budget, there's an expansion for community paramedicine with the hospitals. Is that what you're referring to? You're referring to contracts with hospice and hospitals, or both?
So it's a complicated issue, but I'll try and connect the dots here. The 1115 waiver is primarily supports two CMMI initiatives, primary care and also the AHEAD program, which the focus of the AHEAD program is for community expansion of hospitals, not just outpatient services, but in the home. The 2805X, we believe, is another means by which this expansion is allowed. And although the paramedicine program was one component of it, you'll see that there's a laundry list of things allowed under the 2805, and it includes teaching hospital nurses how to do home visits. It includes things that, although there's supposed to be collaboration with the Article 40 or other article licensed organizations, the intent is to divert and create another revenue stream for hospitals. So if they can't make the money on the inpatient unit, now we'll move to the community setting and see if we can recoup some of the revenue there.
So the objection is bypassing the existing agencies out there.
Yes.
Got it.
Yeah.
And on the compact issue that Senator Krueger just raised, have there been issues during the time of the executive order because we were able to bypass a lot of things during that time, including that. So during those 3 years, was there any notable problem that you know of?
In terms of the
lack of access or problems dealing with the compact as it relates to reproductive rights?
I'm not that I'm aware of based on the questions that you raised, but again, I'm happy to,
Take it
we're
back.
just starting to look
We'd like
into
to know.
it. Sure.
Okay. Do you have other senators?
No.
Okay, Assembly. First, Mr. Jensen again.
Thank you. In the governor's budget proposal, how much was there an increase in allocation and funding for hospice and palliative care?
0.
In last year's enacted budget, what was the increase for hospice and palliative care?
0.
In the past few rounds of the healthcare modernization grant funding, how much money was earmarked for hospice and palliative care providers?
0.
Where does New York State rank in access to hospice and palliative care?
Last in the nation.
Thank you.
Assemblymember Gonzalez Rojas.
Okay, there we go. Thank you, Madam Chair. Ms. Hanson, the bell rang right when you were talking about the Reproductive Freedom and Equity Act, which is A361B. If you could delve in a little bit more about why this is so important. We're on the heels of the 51st anniversary of Roe, where a majority now of this country is either abortion access eliminated completely or extremely restricted. So if you can expand upon that.
Yes, no, thank you. So the Reproductive Freedom and Equity Program would put in to statute a sustained grant program around abortion access. It would support providers in addressing the challenges that they're experiencing delivering care, including uncompensated care. It would also support training, among other things that would allow expanded access to abortion services. It would also allow the opportunity to invest in abortion funds. Those organizations are nonprofit organizations that are really breaking down barriers to care that individuals are experiencing every day, including here in New York. And I think that's one of the things as we reflect on, the loss of Roe. It was very vital to have a constitutional right and around abortion access. But the reality was there was always barriers that prevented people from getting the care they need that often impacted disproportionately people of color, low-income individuals, young individuals. And we're seeing that not just when we had Roe, but in certainly very much more so in the wake of losing that constitutional right. And so this would invest in those organizations that are helping to connect individuals, break down barriers, transportation, lodging. We did get to hear in a recent event from the New York Abortion Access Fund some of their on-the-ground realities right now as they're trying to help individuals. Over 60% of the callers are New Yorkers who are having barriers getting care here in New York to abortion, where we've long had it accessible. So investing in those organizations and providers is critical, and that's what the Reproductive Freedom and Equity Program would do.
And what percentage of counties in New York do not have access to an abortion provider?
I'm not going to be able to say the exact number, so I'm happy to give that to you. I think one of the things we know is that when we talk about the challenges healthcare providers are experiencing staffing, for example, and that vicious cycle we heard about before, that's the case for all providers. It's the case for reproductive and sexual healthcare providers. And so when providers are understaffed, when they're not, struggling to, open up appointment slots, or appointment slots have to be closed because they lack the staff, that's lacking access. And so that's why we really need a strong investment.
Thank you so much.
Thank you.
There we go. I think that's it. So thank you very much, Panel H. And we're on to Panel I. Feeding New York State, the Alliance for a Hunger-Free New York, and the food pantries for the Capital District. And we will take you in that order. Panel J is Home Care Association of New York State, Consumer Directed Action of New York, Empire State Association of Assisted Living, New York State Association of Healthcare Providers, and Home Healthcare Workers of America. So Feeding New York State. Press the button.
Thank you to the committee chairs, ranking members, senators, assembly members, and all in attendance here today. My name is Ryan Healy. I'm representing Feeding New York State, the statewide association of New York's Feeding America food banks. We greatly appreciate the opportunity to talk about the critically important issue of food insecurity across the state. First, I'd like to acknowledge the work of this committee in both chambers for the progress New York has made in recent years. In response to the unprecedented COVID-19 pandemic, New York has stepped up creating the Nourish New York program, which connects hungry New Yorkers with fresh New York grown produce, expanding no-cost school meals to over 300,000 New York children, and increasing funding for statewide anti-hunger programs such as the Hunger Prevention Nutrition Assistance Program, or HIPNAP, and the Nutrition Outreach and Education Program, or NOAP. The reality is we have more work to do, and unfortunately, the executive budget proposes doing less. The executive budget proposal clearly misses the mark on hunger. Its framework proposes a nearly 40% reduction in funding for the HIPNAP program, flat funding for Nourish New York, and a $2 million cut to the SNAP Outreach and Enrollment Program, NOAP. These programs have no meaningful impact on our budget deficit, but they keep New Yorkers fed and they maximize participation in federal nutrition programs. The last thing we should be doing right now is returning HIPNAP funding levels to fiscal year 2017. This year, statewide anti-hunger programs are requesting $64 million for HIPNAP, $75 million for Nourish New York, and additional $2 million in funding, or restored $2 million in funding for NOAP. Why are we asking for additional funding? Because food insecurity is on the rise here in New York State and across the country. Back in October, the USDA reported food insecurity rose at the fastest one-year rate since 2008, which is the first full year of the Great Recession. That came just 1 month after census data reported that in 2022, child poverty rates more than doubled following the expiration of the child tax credit. Just a few weeks ago, our own Department of Health released a report finding nearly 1 in 4 New York adults experienced food insecurity within the last year. And these data points affirm what New York food banks and emergency food providers are reporting. Across our network, we're serving more than 62% more individuals compared with pre-pandemic levels. The DOH Alt report also identifies a strong correlation between food insecurity and the prevalence of chronic disease, including diabetes, hypertension, coronary heart disease, as well as mental health challenges, including anxiety and depression. Hunger and food insecurity persist in all corners of the state. Rural communities such as Herkimer and Oswego, disproportionately high rates of food insecurity. The village of Dolgeville, for example, regularly closes down an entire street for food distributions due to high demand. Also harms suburban communities.
Thank you very much.
Thank you.
Next.
Hi, thanks for having me. I'm Natasha Pernica, the Executive Director of the Alliance for a Hunger-Free New York. As Ryan mentioned, we know there's a direct correlation between people having consistent access to nutritious food and the health outcomes that they experience in their life. The state budget, as drafted, is negligent in responding to the current hunger crisis. Other stats to add to Ryan's include when New Yorkers were asked in the U.S. Census poll, do you have enough food to last for the week? Comparing 2021 to 2023, the number of New Yorkers who answered no increased 87% compared to 35% nationally. People do not have enough food to make it through the week. This hunger crisis is systemic and political in nature, and it's beyond the capacity of what is being pushed onto the charitable sector to handle without government addressing adequate resources that are needed. Just Monday, I was in Dutchess County at their Food Pantry Coalition. Pantries came together. They talked about the increases that they're seeing, the challenges they're experiencing, having adequate resources to handle the increases, the lack of food. And these stories and statistics are across the state, from New York City, Binghamton, North Country, West, across the entire state. The stories and statistics are the same. Fortunately, you have the ability to do the right thing, which is increase the two important programs for our food providers, HIPNAP, the Hunger Prevention Nutrition Assistance Program, which in 2012, a study was done. In 2012, $50 million would have been an adequate budget amount for HIPNAP, more than 12 years ago. Now we're looking at going back to $34.5 million. Food providers across the state are going to lose valuable resources at a time when they're needed most. It's also important to notice that food pantries provide resources for people who don't qualify for SNAP, people who might be $50 above what would be required to be eligible for SNAP. We're seeing more and more families with two parents working having to turn to local food pantries to get their food needs met. Nourish New York is an incredible program to increase the quality and the health of fresh produce and other healthy foods through food pantries. We need to make sure that the stagnant funding is increased. If we look at food inflation prices, last year, the stagnant funding of HIPNAP, we lost $8 million in purchasing power due to food inflation pricing. Food inflation is higher than the general inflation rate.
Thank you very much.
Thanks.
Finally, next.
Hi, I'm Angie Pender Fox. I'm the Associate Executive Director.
Did you press? Is it green?
Yes, I
Yeah.
have. Can you hear me?
Make it a little closer.
Yep.
Yeah.
Is this better?
Yeah.
I'm Angie Pender Fox. I'm the Associate Executive Director with the Food Pantries for the Capital District. And the Food Pantries for the Capital District was funded in 1979. We're a coalition of 70 pantries serving Albany, Rensselaer, Schenectady, and Saratoga counties. As a coalition, we had thought we had seen the highest levels of need in 2022, only to see an increase in pantry visits in 2023. Just last week, our food access referral line received 85 calls from community members seeking food assistance. This is the most calls a referral line has ever seen in one day in the history of our organization. In the governor's state of the state, she spoke of New York residents having to choose which bills they would pay, rent or medical, but she never mentioned food. She forgot food. But I can guarantee you the families we serve every day do not forget about food. The parent with children to feed is not forgetting about food. The senior who cannot get to the grocery store and only gets $28 a month on SNAP is not forgetting about food. The veteran who has served their country and is now in need is not forgetting about food. The child who is going to bed hungry tonight is not forgetting about food. We are asking you to not forget about food and our people. We ask you to support a request at HIPNAP at $75 million, Nourish New York at $75 million, and to expand direct contracts with emergency food relief programs. As a coalition of food pantries, we come together monthly with our members to share information, discuss trends and practices. We survey our members at least twice a year. Our members are telling us that the need continues to grow. Some pantries are seeing 20, 30, 40% increases. Some pantries have had to reduce the number of times people can come to their pantries, going from twice a month to once a month to maximize their resources. Once upon a time, one of our largest pantries in Albany was receiving 3,000 pounds of food a week through our food delivery service, and we thought this was a lot. But now they receive as much as 7,500 pounds of food a week and still worry that this may not be enough to meet the need. Funding is a concern. 30% of our pantries reported that they were concerned that they would not have enough funding to get through 2023. And consistent sourcing is an issue. Pantries are not always able to source foods that meet community needs. Our coalition works with our members to facilitate service coordination and collaboration. We have a handful of pantries who have direct contracts with Nourish New York, and these pantries are working together to provide culturally sensitive and fresh foods to those they serve. They come together as a group.
Thank you so
Thank
much.
you.
Sorry,
Thank
it's
you. Yep.
3 minutes goes by quick.
It does.
Assemblymember Jensen. Oh, you're good. Wow.
You did a great job.
I think then we're on to the next panel.
Wait,
Oh, okay. Assembly members, both. First, Jessica Gonzalez Rojas, and then,
Senators.
and then we have a senator, and then we have Nikki. Okay.
Okay, thank you so much. Mr. Healy, you said 1 in 4 New Yorkers have experienced food insecurity in the past year. That, I think we all need to sit with that. Can you talk about which counties and maybe metropolitan areas are most impacted? Actually, which counties across New York are most impacted by food insecurity?
Thanks, Assemblymember. The county that has the highest prevalence of food insecurity is the Bronx. Up to 40% of New York adults in the Bronx have experienced food insecurity within the last 12 months. In addition, suburban counties like Rockland County and then upstate rural counties, including Oswego and Herkimer, have some of the highest rates.
I can just add the report that he's quoting is from New York State Department of Health, and they list the food insecurity rates by county. It's accessible to everybody.
Thank you. And, you know, there's so many important programs that I am supporting and we're fighting for. Are there some that you would say would really address the root cause of the connection between hunger and public health?
Absolutely. I think in addition to funding the critical anti-hunger programs that serve as a backstop for New Yorkers struggling, we also need to do a lot more in reducing the prevalence of hunger, poverty, and food insecurity. Some things, you have a couple pieces of legislation, of course, universal school meals or healthy school meals for all, as well as a proposal that you and Senator May lead to establish a $100 minimum SNAP benefit. As Natasha had mentioned earlier, when the SNAP emergency allotments came to an end last year, New York households were hit particularly hard. The average household lost about $150 per month, and some saw their benefits go to $23 a month. Doesn't get you very far, so we need to do a little more than $1 a day.
Thank you. Anyone else want to add?
I can add that when New Yorkers do have consistent access to nutritious food, in particular through food as medicine interventions, we've seen people reduce their need for insulin, their hypertension has reduced, and they have lost weight. And so we're excited to be able to do more of that through food as medicine, but we need resources to have healthy food in our food supply chain.
Thank you so much for all your work.
Thank you, Madam Chair. I wanted to ask about the Nourish New York grant. And I've heard from some of the organizations in my district, I represent the west side of Manhattan, that were received a rejection, in effect, and applying for the grant. Do you know why and what the outcome has been for these organizations thus far?
Thank you, Senator. The Nourish New York, which became a permanent program, it was codified in 2021, obviously came about during the depths of the pandemic as an emergency program. But in 2021, when it became permanent, the Department of Health and Ag and Markets, which co-administer the program, put out an RFA in the spring of last year. There were a bunch of organizations that applied. Some great organizations that do fantastic work in the community either didn't receive funding or saw a major reduction in funding. The determinations as to methodology and allocations, we don't have clear answers yet. We would just underscore that there's a lot of great organizations, but there's just not enough funding.
I'd like to add that the increases that we're asking for Nourish New York and Hunger Prevention Nutrition Assistance Program have to have intent in the budget that they're both available to food banks and food pantries and other emergency food providers. It can't be fast-tracked through food banks only. The contracts have to be available to food pantries as well, especially the organizations that lost both HIPNAP and Nourish New York contracts last year because the additional $22 million was treated as a legislative add-on. These increases need to be added to the base budget so that they can be added to the contracts so that these organizations have consistent funding. We cannot be funded year over year and not knowing what the funding is going to be the next year, especially with the increases in demand. Do you want to add?
Questions? Sorry, yes? Hello? Please, yes. It'll pop up on the screen. You press that till it turns green.
Okay, there you go.
Yes, good.
Okay, good evening. How are you? I guess that my question is a spin-off of the previous questions because oftentimes in certain zip codes, Black communities, you see a lot of inequities when it comes to fresh produce. Additionally, in terms of who gets approved for these grants. I've personally watched this. I've had to develop my own pantry just because of what was happening amongst seniors. I watch a lot of these big boxed organizations that are specific to a specific ethnicity receive funding. And then when it comes to distributing out, there is no fresh produce. And when we do get the fresh produce, it is days old and rotten. I experienced and witnessed during COVID where trucks were telling us that they were told to take food, certain foods, to specific neighborhoods, and we were to get the tail end of whatever is left over. So, could you talk to me a little bit about what that process looks like? Do you have any data, um, that would allow us to track and monitor who's the recipient of certain types of food as well as the grants? And additionally, who has this oversight? Because the process when coming to ask for funding, I'm not excited about it because the process is not fair where I live.
Just a couple things real quick. Obviously, systemic racism is apparent across the food system. You have Black and Hispanic and Native Americans 2 to 3 times more likely to be food insecure, which is a significant issue that the state needs to take more seriously, the country needs to take more seriously. In regards to the grant programs, there is, at least for HIPNAP and Nourish New York, there is a competitive bid process every year. The Department of Health makes awarding determinations. Our 10 food banks work closely with thousands of community-based organizations in distributing the food. We haven't heard of the specific examples that you're citing, but we will definitely take a look into that because that's unacceptable.
This is why it's important for all nonprofits to have access to Nourish New York contracts direct and not rely on the food bank system as the only contractor for New York.
And we second that too.
Thank you.
I have 5 too.
Senator Lee Webb.
Yes, thank you, Chair. My question will be really brief. In your proposals, you talk about the desire to expand direct contracts to direct food providers for direct impact. And I was wondering if you could expound upon this a little bit more, because again, this is an issue that I'm all too familiar with in my district. Most certainly, we have significant issues around child poverty. We have some of the highest rates in the state in Senate District 52, and this continues to be an ongoing challenge with respect to food insecurity. So I wanted to, if anyone could kind of expound on that a little bit more.
I can speak to that. What we're seeing, food banks are an incredible part of our food system, but we also need to have local responses utilizing HIPNAP and Nourish New York funding so that pantries and other organizations are able to buy culturally appropriate food for the needs in their own neighborhoods. We are also seeing across the state that food pantries are working collaboratively. The organizations that do have direct contracts, they're even getting prices that are cheaper through wholesalers and farmers than going through the food banks. So the dollars are going farther. The pantries are working collaboratively to meet the unique needs in their own communities. And I know Angie has an example here in the Capital Region about how local organizations working together are being really efficient and effective in the delivery of these services.
Yes, so we do have a group of about 5 pantries who had come together out of our 70 food pantries who have direct contracts, and what they do is they work together to serve, yes, themselves as a collective, but also reached out to those smaller pantries in other communities to see what their needs were and surveyed them. Have a whole system where we worked with them, and we have a whole system in which everyone gets a certain amount of funding. They can do their own ordering, so they order fresh produce, fresh foods, culturally appropriate foods to meet the needs of the community. And they're working at this stage, I think, with about 32 or 33 pantries. It works out really, really well.
And if I could just add, just like to echo the other panelists here, we support direct contracts for all food relief organizations, not just food banks. We support an open, transparent, competitive bid process. On the point about, sourcing food to meet the needs, we have a beautiful state, a diverse state, and there's a lot of important needs, halal, kosher, and programs like Nourish New York and HIPNAP actually help make up for the lack of halal and kosher foods available through the federal programs. That's why, our view is that programs HIPNAP, Nourish New York should be seen as tools for equity within our food system. And so there's a lot of work to do, but, we look forward to partnering on that.
Thank you all very much.
Is that it?
Thank you.
Yes, thank you so much.
Thank you for your
Next
time
panel.
tonight. Good. Last panel.
Last panel. Home Care Association of New York State is first. Consumer Directed Action of New York is second. Empire State Association of Assisted Living is third. New York State Association of Healthcare Providers is fourth. And Home Healthcare Workers of America is last. So press the green button hard.
Very hard.
You're off.
Thank you. This proposed budget contains proposals of high impact and enormous concerns to the home care sector. In addition to the concerns about what it contains, is what it lacks. In particular, certified home health agencies, which are the agencies that accept patients on discharge from hospitals, provide post-surgical care, provide the complex management of patients with diabetes, congestive heart failure, COPD, and so on. These agencies, which serve over 500,000 New Yorkers each year, are substantially functioning below margin in the state, have long been overlooked for any discrete support in the budget or to have their rates adjusted to come close to cost. There is a proposal by Assemblywoman Paulin, A7568, that would address the specific needs of agencies in that category, along with providing essential support for hospices and licensed agencies. We urge you to include 7568 in the Article 7. Wages are a critical issue in the budget. The governor's budget proposes to eliminate the wage parity support for personal assistance in the consumer-directed program. We urge your rejection of that proposal. We also urge your attention to the $200 million, $400 million in the aggregate proposals to cut Medicaid from the executive, which are unspecified. They will only serve to combine with these other proposals to further undermine access and workforce in the system. Home care has unique needs in the workforce area, particularly with regard to nursing. The governor has proposals for workforce in the budget, and those proposals really need to be modified to ensure a focus that supports the recruitment of nurses and other key staff within home care. A prior speaker spoke about proposals in the budget that circumvent current laws to allow for services to be provided in the home by providers that do not meet those license requirements. We urge your opposition to those proposals, your rejection of those proposals in the budget. One area in particular is the area related to 2805X. That area is the home care hospital physician collaboration program. It's a wonderful program. We worked with the hospitals and the legislature to create it several years ago. The executive proposals undermine the core of that program, which is to really leverage the providers who exist to work together. We urge your opposition to the managed care proposals, the procurement, the rate cuts, and the other elements that would undermine services to patients, dislocate agencies. Thank you.
Thank you.
Good evening. My name is Brian O'Malley. I'm with Consumer Directed Action of New York. At the 30,000 foot level, we at Consumer Directed Action are strongly opposed to the $2.54 per hour or 12% wage and benefit cut that would make CDPA workers second-class home care workers. We have deep concerns about the unidentified $200 million in cuts. We support the proposal by Senator Rivera and Assemblymember Paulin to repeal eligibility cuts set to take effect this year that would deem thousands not disabled enough for personal care. And we also support the Home Care Savings and Reinvestment Act, which would phase out MLTCs and replace them with care managers without a profit motive to deny care and fee-for-service Medicaid payments for transparent payment. Coming down from 30,000 feet, this budget forces us to ask questions fundamental to what we want Medicaid to be. Regarding the governor's proposed wage and benefit cut for CDPA workers, I ask, if your salary were cut by 12%, would you look for new work? If you were a PA in New York City earning just over $1,500 per pay period, could you afford losing $200 from that check? Could you afford to go back to slightly more than you were making in 2019? How do 12% wage and benefit cuts for a low wage workforce primarily composed of Black, Latinx, and immigrant women advance in equitable New York? What about the disabled or older Medicaid recipient who needs services? When their worker inevitably leaves, how do they hire someone new at this wage with no benefits when every public and private sector employee pays more? Does it even make financial sense to leave that recipient stranded without services? CMS and others put the cost of a stage 4 pressure sore at $125,000, meaning less than 1% of consumers developing pressure sores as a result of cutting wages wipes out any savings. And the same can be said for the cuts to eligibility. If someone can eat, shower, and go to the bathroom once up, but can't transfer and get themselves out of bed, does it matter that they don't need full assistance with other ADLs? They're not leaving bed. They won't eat, bathe, and they'll lie in their own urine and feces. What's the cost of that? Does it advance equity to deny services to an aging community that's growing more impoverished and is increasingly comprised, again, of Black, Latinx, and immigrant elders? Can we justify any of this while giving billions to MLTCs that were supposed to provide care management but don't? Supposed to do assessments but don't? Supposed to pay for nursing homes but don't? Thank you very much.
Thank you.
That was good timing. Next. Chris.
Push this?
Push hard. There you go.
Good evening, Chairs Kruger, Rivera, and Paulin, and members of the New York State Senate and Assembly. My name is Chris Vitale. I'm the Legislative Coordinator for the Empire State Association of Assisted Living, or ESAL. I'm also a former owner-operator of licensed assisted living communities across New York State for the past 25 years. ESAL is a not-for-profit organization representing 347 licensed assisted living and adult care facilities in the state that serve more than 33,000 frail elderly, some of which are on SSI, Medicaid, and or private pay residents. As we say every year, we continue to suffer from a lack of state support, anemic reimbursement rates, and budget cuts. You have the full testimony in front of you, and I will now highlight some key points. This historic lack of assistance is resulting in closures. We've lost more than 3,100 low-income adult care facility beds in the last decade. 700 of those beds have closed this past year, with these residents ending up in skilled nursing homes at a much higher cost to the state. Given this, we are dismayed that the budget again proposes to eliminate the only source of state funding to ACFs, the Enhancing the Quality of Adult Living, or EQUAL program. This $6.5 million program is directed only to facilities that serve SSI or safety net residents. The money is directed by and for those residents. This is not a new cut, and the legislature has restored it in the past. We ask that you do the same again. Moving on to the Medicaid-funded assisted living program, the low rates for this program are completely unsustainable. The 6.5% increase in last year's budget, although appreciated, doesn't come close to covering the cost of care, labor, energy, food, insurance. It's all way up. The ELP rate base year in statute is 30 years old. I was in high school when it was determined, and it needs to be revised to prevent more closures. We need a bridge rate increase of 13.5% until that takes effect, and we ask that you include ELP rebasing an additional rate increase in your one-house budget bill. Same as last year, the budget includes a proposal to require facilities to report on quality and other measures. We're not against this idea. We just want to be consulted when DOH develops quality indicators and the reporting processes. We support the Assembly Member Paulin Bill A5790 as proposed. I'll wrap up with a couple of proposals we do support. The budget proposes to make permanent the Special Needs Assisted Living Voucher Program, which helps cover the cost of care for individuals with dementia and Alzheimer's who run out of funds. We want to see this program supported. Finally, this budget includes $7.2 million in funding for family caregivers who need access to respite care and at adult care facilities. We want that funding to remain with DOH and support a methodology that distributes it to as many people as possible. In closing, I talk to operators every day who are struggling to keep their doors open, and we need help. Thank you.
Next.
Thank you for the opportunity. I'm Kathy Fabreo, President CEO of the New York State Association of Healthcare Providers, representing home care providers across New York State. So, what else can I say? It's the end of the day. New York has demographic challenges, workforce shortages, reimbursement dilemmas, widespread financial fragility for providers operating in the Medicaid program. Systemic underfunding, astronomical growth, and reform proposals have been a common theme today. Home care is no different, except that funding for home care agencies has remained flat for over a decade, while other sectors have seen substantial investments. We desperately need a 10% increase in Medicaid reimbursements this year. Recent funding to support wage increases has only been partially passed on to home care agencies, while no funding has been provided for running a home care agency. For too many years, there have been discussions about the Medicaid payment system for home care. So let me be very clear. Regardless of the payment system, the rate and amount paid to home care providers is simply inadequate to sustain the viability of the system. So let's ask ourselves if we have any water before we work on the plumbing. We need to have enough money to meet payroll next week before we talk about fixing the system. Nearly 30% of licensed home care agencies operated at a loss in fiscal year 2021. I assume it's worse today. So we are asking for a 10% Medicaid rate increase for home care providers. We want restoration of $1 billion in Medicaid cuts, including the $200 million and state and then its match at federal level and the unspecified home care cuts. We want restoration of the wage cuts for personal assistants of over $2 per hour. We want opposition to home care absent licensure under Article 36. And we want inclusion of S 6983A from Rivera and A 7335 of Paulins to establish a regional minimum hourly based reimbursement rate for home care. My written submission includes the testimony of Karen Clark, who could not be here this evening. She's the executive director of Home Healthcare Partners, a respected not-for-profit home care agency serving upstate New York for almost 30 years. Despite their good work and reputation, the difficult business environment in New York State and persistent fundamental threats to our industry led to their decision to close their doors. To quote Karen's testimony, "The outlook for home care is grim. Our agency is still doing what is right as we grieve and wind down. We are service providers and we have been service recipients. Home care is very real and personal to us." So home care agencies like Karen's work every day
Thank
to
you
make
very
sure
much.
we
Sorry.
provide services. Thank you.
Hello, I'm Connor Shaw, the Political Director of Home Healthcare Workers of America, representing 40,000 home care aides, mainly in the 5 boroughs, but into Long Island and Westchester as well. We are very concerned about what's not in this budget, which includes not the expansion of the Quality Incentive Vital Access Program, which we've come and talked to many of you about in the past. This is a program that provides a slightly higher reimbursement rate to agencies that meet higher levels of training and healthcare access to their members. While there is an upfront cost to providing this extra reimbursement, it undoubtedly saves the state tens of millions of dollars. Every home care aide that does not receive health insurance through their employer receives it through state Medicaid. By encouraging employers to provide more access to health insurance for the people currently working for their agency, you're keeping folks off the Medicaid rolls. By providing higher level of training than the 12 hours currently required for the QuiVAP program, you are keeping elderly folks out of hospitals. We've brought many of these aides to talk to you about some of the training they go through. Providing an extra $1 an hour to folks making $17.50 is nothing compared to the cost of one hospital stay that these can prevent. You're talking about a workforce largely of immigrant women working in their first jobs in the United States. With the reduction of the $1 increase in wage parity that was supposed to go into effect last October, we are seeing home care providers cutting English as a second language provider, childcare services, and transportation to get to patients that don't live near public transportation. By cutting these programs and asking a workforce that to fund their minimum wage increase through a reduction of benefits puts at risk an industry that's already 100,000 aides short in New York State alone and is facing an elderly population. We do not have the infrastructure to deal with the elderly and aging population without investing in home care. We cannot. There's not a possible amount of money that you can put in nursing care that can replace what home care provides this state. And the QuivApp program, acknowledging that there's an upfront cost, saves the state tens of millions of dollars. It's already in place, but was closed off to new employers that want to help New York meet its goal. Why do you have a program that encourages employers to help New York meet its goal, but you don't allow employers who want to access that to participate? We would support raising the standards from QuivApp. Frankly, you only have to provide 30% of their workforce health insurance to qualify. We support raising that to 50%. Again, that helps the state save money by keeping folks off Medicaid. If a home care agent making $17.50 an hour, if they are not getting health insurance through their employer, they are getting it through state Medicaid. Thank you.
Thank you. Senator Rivera.
Hey, folks, thank you for holding on for as long as you have. Just two things. One, and anybody can chime in, but certainly, Madam, you were talking about it. As far as these unallocated cuts, now this is the first time that I hear of anything like this. I'm not sure if you've heard of anything like this before. And if you do, if you give me kind of your impression of what are these folks thinking? What is this unallocated cut thing? It's like $200 million, do what you will. What do you think about this?
Well, when the cost savings for the cut to worker wage parity in the CDPAP
Oh, I'll get to that.
But that's 200 million as well. So 200 million is going to be significant, whatever they decide to do with it. It's very concerning. I haven't seen it before.
And has there been any engagement? Because the argument that they were making this morning was that they want that this is put out there so that we can, together, stakeholders can decide collectively what is best to be able to provide savings, blah, blah, blah. Has there been any outreach from the administration to anybody, certainly at this table? I should have asked this earlier. Anybody at this table on this type of issue? Or have you heard from anybody in the industries that we're talking about that are going to be impacted? I mean, folks talk to each other all the time, whether there has been any outreach from the administration to do what they claim this is about.
Not yet.
Okay. Brian, I want you to take the rest of the time. One of the proposals that I was like, what are you doing here? And I asked him this morning, right? There's a lot to ask about, but the cut to the wages to CDPAP workers, it seemed. Could you tell me a little bit more? I'm sorry I had to step outside when you were testifying, but I just wanted to give you an opportunity if you had anything else to share about the impact that's going to have on these workers, in turn on the people who they serve, and how do you think we should actually deal with this?
I mean, I hope that this cut can be just rejected outright. It is a straight cut to the workers, right? We have worked so hard over the past couple of sessions to raise wages for workers, and we at Cedany have been a leader in that effort, working with all of you here to make that happen. This would bring us below the wages when we started that. This would bring us the wages would not have been lower since 2019. I don't know how we can justify that. People will go without services. People will lose their workers because Chipotle and Target are already paying more. If they have to compete with every other home care agency, and it also leads to the plans exploiting the workers as well.
We'll talk much more about this in the weeks to come. Thank you for being here.
Assemblyman Raw.
Thank you. Mr. Shaw, can you just elaborate a little bit about what the real world impact is of cutting that dollar from wage parity?
Yeah, one of our agencies that we brought up aides from last week had a very innovative program that they had been funding, which was providing after-school tutoring and SAT prep as a benefit to their home care aides. Since they implemented that program, they increased their retention rate from 35% in the first 180 days to 71% in the first 180 days. That is outstanding in one period, because that is a benefit you couldn't pay money in the paycheck to replicate that benefit, providing after school for these, again, a workforce largely made up of immigrant women. They're going to run out of funding on February 15th for that program, because they had budgeted in that dollar increase that was supposed to come in October. They have tutors, they have a whole program that they run for that. That is going to run out of money. We also have spoke to multiple agencies that are trying to figure out what they're going to do. One of the things that wage parity was providing was travel reimbursements for going to patients that don't live close to public transportation. Almost every single aide relies on public transportation to get to their patients. If they're cutting that program, you are going to functionally end home care access to places in Staten Island or in the outer boroughs that do not have access to public transportation, because an aide who's making $17.50 an hour can't afford to pay $30 to an Uber to and from work. So those are two, and we have other examples, but wage parity is what funds every paid time off, health insurance, every benefit that these aides get. And that scheduled increase was put into the money as a minimum wage increase. So again, you're asking some of the lowest paid workers in New York to pay for their own wage increase by reduction of benefits. And I can't name a single other industry that has happened in.
Thank you.
That's it on my side.
Any other Senate? Nope. Oh,
We
I
are.
see an assembly member.
Okay, sorry. Assembly Member Jessica Gonzalez Rojas. To close, I think.
On this mic. Okay, there we go.
Right.
It's been a tough day. Thank you all so much for your work. And this issue is so important to me, because I myself needed a home care worker when I broke my leg, and I'm now currently navigating my mother, who's declining cognitively and physically, and the patchwork of resources we need to pull together to make life work for her to be independent is really difficult. So thank you for everything. Thank you, Brian and Connor, for underscoring that cut that we heard about earlier that Senator Rivera asked about. We were all baffled by the commissioners and the director's comment this morning. But my question is for Kathy. My understanding of home care services for non-Medicaid individuals is that the offices for the aging have to provide that funding for the home care aides, and are required to pay for that increase by law, but haven't received any funding to support that. So maybe, Al, you're nodding too. If anyone could speak to that, what that impact means on our older adults and those that need home care services.
Well, it will definitely increase the waiting lists at the county level. There is a New York State, Becky Prevey would be a good resource to get more detail on the numbers and the quantity. Our members as home care agencies contract with those counties to provide that care, but she would be the one with more data and statistics that would show the impact of what that means.
I think one of the issues is that when the wage requirements were passed within the legislation, I think was the presumption that when implemented, they'd be evenly implemented. So really, regardless of whether the worker is caring for a non-Medicaid, a Medicaid, or Medicare patient, we're looking to support those wages.
Exactly.
And the program has not been implemented that way. And frankly, within the Office for Aging, the waiting lists are very extensive, and there isn't the support that's necessary to balance those wages. I would say that the same impact is being seen for the Medicare recipients. There's no carryover accommodation to support the wage function in that area.
And with my last couple seconds, I just want to thank Assemblymember Paulin and Senator Rivera for their bill that would phase out the MLTCs. I'm dealing with the MLTC. It's a nightmare. It's a waste of money, and I think there's a lot of alignment behind that. So thank you. Thank you so much.
Thank you. Done now?
We're done now. Thank you all
Thank
for
you all
coming
for
and
being
staying, and especially to our last panel, because we know how you feel.
And some of us will be back here tomorrow for the transportation hearing, 9:30, bright and early. Some of
To
us
the members who stayed, thank you.
All right. Thank you all very much for being with us.
Yes, we adjourn.